And award ceremony. Today we are honored to present an esteemed lineup of lecture by renowned expert speakers, followed by fellowship, convocation, awards and valedictory. For the first lecture of today, I would like to invite Dr. A. Siddharth Verma sir. He is Associate Professor at School of Dental Sciences, KVB Karad. Topic of the lecture is the peri-implantitis angina, integrating diagnosis and treatment. I welcome you, sir.
Hello. A very good morning, dear delegates and the organizers. At the outset, I thank the organizing team of PFA for having such a wonderful event and having me here. I'm also happy to stand in front of my mentor. Thanks to PFA, after 14 years, I could meet my mentor in your event, Dr. Sudhakar. So, very good morning to one and all. So, as you can see the picture, so this is one of the latest report by the WHO in the month of November 2024, where they found edentulous being one of the third most prevalent dental disorder, where 7% of people among 20 years and older are suffering from edentulousness, and in age group of 60 years or more, 23% of edentulousness is seen. So the moment we see an edentulous case, we all know one of the most promising replacement strategies has always been dental implants. And one more report in the year 2023, it shows the Indian dental implant market growing in size enormously. And this is being a gradual steep increase of the number of implants we have been placing in Indian scenario. So as per 2022, it was found that a record number of 8 lakh odd implant cases have been done in India alone. So why am I giving this statistics is, we are just not supposed to focus only on the number of implants being done. We should also be aware of the increasing risks associated. We all know the success rate of implants is definitely 95% and above. But eventually over a period of time, there are chances that our patients might suffer from a condition called peri-implantitis. So the statistics say 14% of individuals are suffering from implant-related problems within the first year of implant placement. So that's a cause of concern. Now why? So why is this happening? Probably to enlist few reasons. It could be because of the most common etiology being the oral hygiene, or incomplete healing followed by any systemically compromised patient we are dealing with. Conditions like diabetes and a major indicator of smoking. So today I am here in front of you to give a brief overview about the peri-implantitis enigma, integrating our diagnosis and treatment plan. So greetings from School of Dental Sciences, this is where I work. So I will be covering the content on the following headings. So to start with, we all know the definitions of peri-implantitis. It's nothing but an inflammatory change that takes place around the tissues surrounding your implant. Now when you talk about two specific terms, we are talking about peri-implant mucosal diseases and peri-implantitis. So mucosal diseases are nothing but a reversible reaction in the soft tissue surrounding the implant. And once it extends to your bone, it becomes much more irreversible and causing a bone loss. That is what is called as peri-implantitis. So coming to the prevalence of peri-implant diseases, they range from 14 to 24 to 48% as per different authors. So the difference primarily might be because of the diagnostic criteria each author has considered. But in short, it ranges from 14 to 30% on an average. Now this is one of the recent guidelines issued by the Indian Society of Periodontology, where they found that is, in an Indian scenario, to an extent, there is some knowledge gap, where 75.8% of dentists could identify the proper diagnostic criteria, and only 39.6% recognized the diagnostic criteria for peri-implantitis. So 15% did not measure the probing depth, and 36.3% relied solely on a single radiograph. So there are certain discrepancies among the dentists and the practices they perform to identify the peri-implantitis. So we all know an ideal picture should look something like this, where we have a very good soft tissue and the bone surrounding our implant, and where the probing depth around the pericircular epithelium in the implant should be in the range of 3 to 4 millimeters. Now, because of any reason, if the depth increases, that's where the whole disease starts. So, the basic idea of diagnosing a peri-implantitis, it starts with a simple probing, as we all know, with a plastic instrument. So, any increased probing depth beyond 4 to 5 mm is a cause of concern and the first red line to us. So, evidence of bleeding on probing, presence of exudation, and inadequate keratinized mucosa are the prime concerns for the diseases surrounding our peri-implant. Next most important factor is our radiographic assessment, where we have to pay attention to the baseline radiographic bone level and the current bone level. So that's where many of us may be missing out. We need to have a follow-up radiograph after every 1 year, so that I can compare it with the baseline radiograph to assess what is the condition of bone around my implants. So the signs, what I should pay attention to is presence of any swelling, bleeding, pain or discomfort, presence of pockets, presence of pus or discharge, or in case of implant, mobility of my implant. So the common risk factors, if you categorize it into patient-related and other risk factors, as far as patient is concerned, it could be due to systemic disease, smoking, inadequate width of keratinized mucosa. And as far as other factors, it could be a traumatic surgical technique what we followed, any iatrogenic cause, complications in second stage of surgery, lack of primary stability, and etc. So to summarize, these are the common local factors which depends on history of previous periodontal disease, poor oral hygiene from the patient, depending on the available bone, the overload of the implant, what it is happening, the keratinized mucosa and the tissue biotype, and the implant sulcus depth and titanium particles. And patient related are something like the other factors could be osteoporosis, smoking or radiation therapy, which primarily determine the increased risk for peri-implantitis. So studies have shown an adequate amount of keratinized mucosa of minimum more than 2 millimeters is absolutely necessary for an excellent, prolonged, successful presence of an implant. So whenever we have diagnosed there is a peri-implantitis, I should follow a simple flowchart or a simple mechanism to decide what treatment should be performed. So the moment I diagnose peri-implantitis, my first step would be a non-surgical therapy, where I do complete debridement. After non-surgical therapy, I will reevaluate and see if the infection is controlled. If it is controlled, I directly put my patient under maintenance. If it is not controlled, I would see whether my keratinized tissue is adequate or inadequate. If my keratinized tissue is adequate, I will proceed with my regenerative therapy around the implant, which is bone grafting. If the keratinized tissue is not adequate, I will first do my gingival grafting, increase the phenotype around the implant, and then I will think of regenerative procedures around the implant. So this is a simple flowchart which I can always follow for any case of peri-implant. And the moment infection is not controlled, I should always plan for removal of my implant and replacement of implant after sufficient healing. So the treatment goal of peri-implantitis would be reducing the infection and inflammation, tissue regeneration, implant stability, function, aesthetics, and ultimately prevent the failure. So the various modalities by which I can treat my implant surfaces would be the local debridement with your titanium or plastic curettes, decontamination with titanium brushes, more advanced therapies like using lasers to disinfect the implant surfaces, and certain surgical techniques. So there are a couple of cases which I would like to show you guys. So in this, the common complications after an implant surgery could be maybe a failure to achieve a complete flap closure could be a cause of concern, thermal injury to the implant. The moment I exceed 47 degrees centigrade for 1 minute might cause necrosis of my bone, presence of infections, and flap dehiscence due to tension, and formation of granulation tissue around implants. This could be some complications post-implant surgery. So this was a case what we did where we had a patient with an exposed threads and a necrosed bone. So we can identify here there is complete lack of keratinized tissue. So my first priority would be to regain the keratinized tissue width there. So there are exposed implant threads, soft debris, bone necrosis and soft tissue recession extending to the mucogingival junction. So we had performed a laterally sliding flap procedure first to gain the width of attached gingiva. So once my tissue phenotype was improved, then I would go ahead for regeneration, trying to cover the exposed threads with bone graft and achieve some regeneration of the bone. So improvement in our soft tissue profile, which helps in longevity of my implant. So that could lead to sufficient coverage and increased keratinized tissue width. Similarly, in a second case, so here this was an interesting case because during the second stage procedure, the operator had used an electrocautery, an inadvertent use of electrocautery, which led to necrosis of the bone, where we can see a sequestrum between our two dental implants. So we had an exposed inter-implant bone, sequestrated bone, and inadequate inter-implant soft tissue. So we had to surgically open the site, remove the necrosed bone, fill the site with bone graft, GTR membrane, and suture. And ultimately we could achieve a complete interproximal soft tissue closure and regeneration of the bone around the implant. So from here we could reach there. So uneventful healing and soft tissue coverage was achieved. And similarly, one more case where again there was a positive tension test here. There was an absolute loss of keratinized tissue there. So when you perform the roll test, we can see the blanching and movement of our gingiva. So there is an inadequate keratinized tissue and movement, a positive roll test. So which warrants for addressing the issue by increasing the keratinized tissue width, so that my patient won't be facing a future problem. So the best technique is always a free gingival graft. So we performed a free gingival graft procedure and we achieved a significant amount of attached gingiva there. So that helps in reducing the tension test. So we could see the difference in the pre-operative and post-operative where the tension test is no longer positive after a free gingival graft procedure. So these are few cases where early intervention will definitely improve the life of our implant. So the estimated prevalence when it comes to peri-implant mucosal disease is around 46%, and when it comes to peri-implantitis, it was found around 29%. So the presence of adequate peri-implant soft tissue is always utmost necessary for long-term success of our implant, where we have to take care of the keratinized mucosal width, attached mucosa, and the mucosal thickness as well. So they play a critical role in the prevention and resolution of peri-implant mucosal diseases. So a graded systematic planning according to the CIST protocol can always be used for treatment of peri-implantitis. That depends on the probing depth. So as long as my probing depth around the implants is less than 3 mm, and if my bleeding on index is positive, a simple mechanical debridement, scaling and polishing would be enough. As and when I go down the ladder where there is increase in probing depth with presence of bony craters, along with mechanical debridement, I have to add on use of antiseptic cleansing, local antibiotic therapy, or resective and regenerative surgeries. So the mechanical debridement, ideally which is performed using the plastic curettes or the titanium curettes. Implant surface decontamination is utmost necessary, where it can be performed by air abrasion or citric acid application, or to the latest photodynamic therapy and use of antiseptic agents like chlorhexidine, betadine, hydrogen peroxide. So the local application of antibiotics can be in the form of using tetracycline fibers or minocycline, doxycycline, periochip, and also systemic antibiotics can be prescribed wherever the problem is persistent. So as far as lasers are concerned, they are found to be very effective in management of peri-implant diseases. What we should remember is no single therapy is totally good enough to take care of it. So it would be always a combination of various therapies and what is available in our hands. So as far as laser is concerned, so several studies said use of NDI, diode or FBM. As far as they are used with the right parameters, right energy, they are not going to cause any harm to the implant surface. So we can use laser right from a surgical debridement point of view, where I can remove the granulation tissue. Later I can use photodynamic therapy by injecting a photosensitive dye in the peri-implant surface and irradiating it, so that targeted microorganism disrupted. And ultimately, after everything is done, I can always use a photobiomodulation aspect of laser again to help in the reduction of the inflammation and boosting the immunity of your patient. So laser can have multiple applications. So as far as PDT is concerned, so depending on the wavelength of laser I have, either a indocyanine green or a tauretin blue dye can be used, and then inject it along the peri-implant mucosal surfaces, soaking period of 4 minutes, and then irradiate it. So that will help us in achieving the required target. As far as surgical techniques, I have shown you a couple of cases. It can be a choice of technique based on the patient condition, either a laterally displaced flap or a pharyngeal graft or a subepithelial connective tissue surgery. So one take-home message would be definitely advocating the practitioners to avoid inadvertent use of cautery, so that we don't end up in such a scenario where we are causing peri-implant mucosal damages. And pay attention to adequate amount of keratinized mucosa, either on the day of surgery in the first appointment, or at least in the second stage surgery. I can still address the attached gingiva there. So the long-term outcomes of laterally displaced flap around dental implants proven to be very beneficial. So the literature says that. Similarly, the meta-analysis by Wong also said that FGG was effective in increasing keratinized tissue width and mucosal thickness around peri-implant surfaces. So finally, coming to the peri-implant maintenance. So what is the rationale for follow-up of regimen of peri-implant maintenance? So that it's basically because of the impact of microbial biofilm, the importance of regular care, effectiveness of professional maintenance care, twice yearly recommendations, and lack of clear guidelines. So what we are supposed to do: individualized oral hygiene instructions, demonstration of home care techniques, customized treatment plan, and scheduled follow-up appointments are utmost necessary. So when you come to the peri-implant maintenance protocol, we can follow a simple protocol. I'm happy to have one of our esteemed sir in front of us, who is part of publishing this guidelines from the Indian Society of Periodontology, Dr. Abhay Kolte sir. So based on this, they have given an excellent paper. Each one of us can follow it. Whenever the probing depth is less than 3.5, we have a first year prosthetic loading in the 6 months, and second year onwards we can call the patient after 1 year. As and when there are some coexisting risk factors like presence of periodontal disease or smoking or HbA1c involvement, the recall visit keeps on coming down. So we can follow this simple protocol based on the probing depth around the implant and presence of risk factors, and schedule our patients for regular maintenance. And patients should be guided on effective use of antimicrobial rinses, so that a customized peri-implant care both at home and in office can be provided. Ultimately, the whole aim being improving the longevity of our dental implants. So finally, to conclude, the dental implants as a treatment modality for replacing missing teeth are not immune to complications. We should be very clear. We can never ever guarantee a lifetime problem-free implant in any patient. The peri-implant mucosa plays a vital role in the longevity of your dental implants, and strategies such as FGG, subepithelial connective tissue graft, and a laterally displaced flap, they offer effective solutions for covering the recession defects and increasing the width of attachment. So the implantologist should be aware of the complications of peri-implant mucosal disease and its solutions. So these are my references. Thank you for your patience.
Thank you so much, sir. For the next lecture,
all present here. I am Dr. Upasana, and I am BDS and MDS in the Department of Oral Medicine and Radiology, my post-graduation, and I have done my specialization in orofacial pain from US, and I am a diplomate, certified diplomate from American Board of Orofacial Pain. Today I am going to talk about orofacial pain. So before I start on with the topic, I would just like to briefly review one or two cases. Okay, so now this is a middle-aged female. I will just explain what problem is she facing. This patient came to us with a pain on her left side of the face, and she typically says that the pain radiates to her left cheek region. She has pain in her left side of the eye, her forehead, and she has headache. So basically, you see that she is having pain on the left side of the face, which she says has been since past 5 to 6 months, and this pain is not severe enough that she takes medications or painkillers, but then it is very annoying to an extent that she is not able to perform her day-to-day activities. So then after this, since she went to a neurologist, he said that probably you have a dental pain, so she was referred to a dentist. So when she went to the dentist, this is the history that she shared, that this pain started around 6 months back. So when she went to the dentist, he saw a small cavity in her 2-7 region, so he did a filling for that tooth. Immediately after the filling, she again went to the doctor. She said that no, she has no relief in pain. So then she was advised a root canal treatment. So root canal treatment was also performed for 2-7, but then again the pain persisted. So then the doctor advised her to, go for an extraction of 2-8. Probably there is some missed canal or anything, that kind of a problem. So then she got her tooth also extracted. Later, since the pain persisted, the dentist advised her that there is a 3-8 which is impacted, so probably there is a referral of pain from 3-8 towards her maxillary region and her cheek and her eyes and her forehead. So he advised her to go for extraction of 3-8 also. And but then she was not willing to go for extraction for 3-8. So then she was told probably you have some sort of TMJ problem, so you need to go for further investigations and probably you need some arthrocentesis and all those things. She was not very convinced with the doctor, so then she left. Now the patient is confused because she's already visited a neurologist. She has visited 4-5 dentists, and now probably she was referred to an ENT specialist. This is the second case. This patient also tells us the history of pain that she's been experiencing. इसमें आवाज आती है? Volume बढ़ाइए. Starting से इसकी volume बढ़ाइए. See, these are patients whom we come across in our day-to-day practice, and somehow we are also confused, as in where to refer these patients or how to deal with these patients.
ऊपर या नीचे? ऊपर में। तो काफ़ी दर्द था, 4-5 साल से मैं बहुत ज़्यादा परेशान थी और मैंने वहाँ पे भी अपने दिल्ली में भी काफ़ी दिखाया था पर आराम नहीं लगा। फिर मैंने लॉकडाउन में दांत ही निकलवा दी, जिसमें कि मेरा दांत बिल्कुल ठीक था।
ये जो 3-4 साल से आपको दर्द था, कुछ दवाइयाँ वगैरह ली आपने?
हाँ, मैंने बीच में काफ़ी दवाइयाँ खाई हैं मैंने, जैसे कि किसी भी डॉक्टर के जाती थी सभी 2-3 दिन की डेली दवाई मेरे को आराम लगा। फिर हफ्ता 10 दिन नॉर्मल करते थे, फिर मेरे दोबारा हो जाता था।
अपने आप को?
जी।
किस तरह का दर्द आपको होता था?
मेरे को ऐसे टेस्टेस होती थी।
See, now this is very important. The quality of pain, the kind of pain. What she is telling is tus means she is having a throbbing kind of a pain. The initial patient, the patient number 1 that we saw. The patient number 1 that we saw was giving history of a dull aching kind of a pain. Now this patient typically is giving history of a throbbing kind of a pain. The location of the pain is same, the duration is the same, but now what has changed is the quality of the pain. This second patient, this particular patient, now she is telling whenever she takes any medications, the pain is relieved. Now again, one common factor between the first and the second patient is the first patient also had got her tooth extracted because of the pain in the cheek and in the TM joint region, whereas the second patient also same history, that she had pain in her cheek radiating to her head and neck, and she also had got her tooth extraction done. Later, after we review these cases, we would be able to appreciate and see what basically these patients were. Now, this is the third case. नहीं सेकंड बार फोटोग्राफ पे क्लिक करो तब वीडियो चलेगी. सीधा. Okay, I'll just review this case. This patient had pain in her teeth, and she had got they were mobile teeth, she had got them extracted, and now she has complained of paresthesia. And how is she reporting that paresthesia? She says, I feel there are some ants moving in that particular area. Again, the common factor is again the pain, that there is pain which is radiating to her head, but now there is a fresh complaint of ants which are moving throughout that particular region. Picture पे click कीजिए. एस्केप करके ना उसको स्ट्रेट कर दो. नहीं टेढ़ा कर दो तो सीधा आ जाएगा वो. It happens अगर सिस्टम चेंज हो जाता. This is an important case. This patient is a general surgeon, and he had come again with the complaint of pain. आवाज तेज कर. Starting से कर दो ये वाला.
It has been a year since I am having pain in my terms. Myself, Dr. Osharaj, I am a general and a laparoscopic surgeon. It has been a year since I am having pain in my terms, having pain in my throat, both the side. I have visited several dentists, several doctors regarding this, but they always used to say me so it will be fine, you just take care, take some long walk after medication. But this pain gradually grew up in intensity, and it was very pathetic, and I thought it was really disability to me. So after several visits to the early doctor, someone advised me to get an RCT done. Then very unfortunately I had to go under RCT. My two neighbors underwent RCT, both the sides of the upper jaw. Even though after that it was 4 to 5 days or a week I was okay, but again the intensity of the pain grew gradually. It kept on growing, and my both of the TM joints started pain. And not only that, near the TM joint the pain used to refer to my upper jaw, to the glottis. Even at times I was used to have severe migraine, for which I kept on having anti-inflammatory analgesics on a daily basis. For a person like me who never used to take paracetamol for 3 years, so it was quite difficult. And in the end I had to take gabapentin, very high dose of painkillers and analgesics. It's almost we usually give for patients undergoing amputations. So I got to know about Dr. Upasna.
Now this particular patient also, pain throughout the face, both the jaws and also the neck pain. This patient, and there was a referral to the teeth as well. So this patient again was advised root canal treatment. He got his root canal treatment also done. Probably this did not subside the pain, and then the pain referral was again to the temporomandibular joints for this particular patient. And the pain was so debilitating that he had to take gabapentin, but then he did not. In fact, gabapentin did give him relief, but then he is a general surgeon himself, so he knows that this is not supposed to be taken for long. Now when we see the common factor between all these patients is the complaint of pain. So basically, what is pain? Pain, it is basically an unpleasant sensory and emotional experience with actual or potential tissue damage. The kind of pain that we as dentists deal most commonly has an organic cause. we find that there is a deeply carious tooth or there is an impacted tooth, we need to cure that tooth, or there is a periodontitis, we need to cure that region and we are relieved of the pain. But we do not realize that there are many types of facial pains for which there is as such per se no organic cause, or probably we are not able to discern those causes. So such cases come under the category of potential tissue damage, which we are not able to visualize. For example, cases of neuralgias, atypical odontalgias, and so many else. When we talk about pain, there are majorly two categories, that is the acute and the chronic. Acute, the duration of the pain ranges from 3 to 6 months, anything. There are many articles which say 3 months, but now the latest classification says any pain persisting beyond 6 months comes under the category of chronic pain. So for acute pain, we are very well versed with the types of pains, that is the dental pain, periodontal, mucosal, sinusitis and salivary glands, for which we know that this is the cause, this is how we need to treat. But the challenge lies with the pains like in the chronic orofacial pains. What all 4 cases that I have shown so far are all cases of chronic orofacial pain. So what type of those pains can be? The most important being the musculoskeletal, that is the masticatory, the tension type headaches and the temporomandibular joint disorders. We as dentists should not just reserve ourselves to the pain which is arising particularly only from the tooth, that is the dental the pain of dental origin. There are many cases where there is a referral of the pain for the headache, causing headaches, or TM joint referring to the head region or to the neck region. This all comes, all those things, they also come under our purview. So we need to take care of those pains as well. So then the neurovascular pain, the migraines, the cluster headaches, migraines we have always known, refer the patient to a neurologist. Do we know that the myofascial muscles, that is the sternocleidomastoid muscles particularly, along with the masseter and lateral pterygoid, they also have a very robust cause for migraines. So once we treat those, the trigger points in those sternocleidomastoid and the trapezius muscle, we very well can cure the patient of migraine. Then obviously the neuropathic pains, that is the neuralgias and the continuous pains of neuralgic origin, that is the deafferentation pain. If we go through the literature, we see that the frequency of orofacial pain, I am here in particularly talking about chronic pains, not the acute pains. They range from 14 to 40%. This is the data from United States, Canada and UK. And in the Brazilian population, in fact, this variation, this is ranging from 32 to 73%. When I try to take out data for our own country, perhaps I could not find any review or any systematic review where we could find the prevalence or the incidence of orofacial pain. Particularly the reason, this one article which I could find that research on orofacial pain in India, a bibliometric study, here also the results are inconclusive. Probably the parameters that we are using in our country are not standardized. So that's the reason why we do not have as such data about the incidence and prevalence. But I am sure these kind of cases, as I am working in a dental college, I come across these cases very often, and in my own private practice also now I have started doing exclusive orofacial pain practice. I have seen there is abundance of these patients who were initially neglected, were being referred to ENTs or neurologists, but then again the treatment was not done adequately. Categorizing the chronic orofacial pains, majorly what we see that the dentoalveolar obviously is the most common cause, the toothache. Secondly, followed by the musculoligamentous, and then the non-specific, where are neuralgias and deafferentation, etc. kind of pains. The incidence and prevalence of orofacial pain is so much in general population that very recently, like in 2020, orofacial pain has got its own specialty status in US. So now it is a 12th specialty of dentistry being recognized by American Dental Association, and probably our country is very soon going to follow the same norms, because general dentist, it is very difficult for the general dentist to be able to identify the exact cause of such kind of pains. Now, we're talking about orofacial pains. There are specialists for orofacial pains. Have you ever thought that there is actually no pain specialist for a knee pain, or for a foot pain, or a leg pain, or a hand pain? The reason lies with this pictorial depiction of orofacial pain. This is homunculus, which is a graphic depiction of the functional areas of the sensory cortex. Here what we see, 45% of the representation in the cerebral cortex is of the head and neck structures. Probably this will give very much importance to dentists as such, because it says that since the majority of representation of the pain in the cerebral cortex is through head and neck region, so utmost importance needs to be given to any pain arising from this area. Moreover, the pain associated with this particular region, here what we see, the eyes, the nose, the face. Pointer. So the eyes, nose, here what we see. If we see this particular area entirely being covered by the structures which are in the head and neck region. Ultimately, for us to perceive pain, the cerebral cortex has to be sensitized, and we as dentists are now able to recognize that how much importance is being given to these particular structures. And that's the reason why any pain which is arising in the head and neck region is more debilitating, and the patient remembers that kind of pain much more than the pain in any other part of the body. Just on a lighter side, if we compare the male and the female brain, here what we see, the female brain is mostly preoccupied with the shopping and the commitment needs, whereas if you talk about the male brain, the major focus is on the women. Okay, so now coming on to the main topic, we talk about the chronic orofacial pain. Here I would like to mention the axis 2. Axis 2 has prime importance when it comes to chronic orofacial pain, because any pain which persists beyond 6 months has very high potency of axis 2 being involved with it. Reason being, the brain now becomes sensitized, more sensitized to any input which is coming from any part of the body. And that's the reason why patients who have chronic orofacial pain have more tendency of being depressive, or they have more anxiety issues. So it is very important for us to recognize axis 2 here, that is the psychological factor, because once we are treating patients with orofacial pain, apart from the treatment that we are targeting towards the organic cause, we also need to do psychological counseling or cognitive behavioral therapy for such kind of patients. Again, in US, as I mentioned, that since orofacial pain now is getting a lot of importance, there are many psychologists who are going now towards specific cognitive behavioral therapy to be treating such kind of patients. There are multiple myths and facts being associated with orofacial pain. Now, just to start on with myth first, this is talking in general, that we use only 10% of our brain. Whereas, if we know that while we are sleeping also, majority part of our brain is active. So, considering this myth, the first myth associated with orofacial pain is, are all orofacial pain TMTs? Secondly, is there a relationship between occlusion and TMTs, and are they again associated with chronic orofacial pains? Thirdly, do you treat an asymptomatic click? Next, selective grinding, very important. Selective grinding or orthotic implants. What is the treatment for patients who suffer from TMTs? Lastly, is there evidence-based management to treat patients with temporomandibular joint disorders? Considering the paucity of time, we will not be able to cover all the topics mentioned here, but a brief review about all of them I will be sharing. The first, this is very common for all of us to be referred a patient with simply an OPG or a WhatsApp please just review this patient. He has no dental pain, no dental etiology. Do you think he has a TMJ problem? Now, it's very unfair on our part also to diagnose a patient with orofacial pain of any cause with just an OPG which shows that all teeth are sound and probably no anomaly or no problem associated in the joints. So anybody who's talking to us and sending us a patient with an OPG or just discussing that when we talk about orofacial pain, probably if it is not a tooth, then it is a joint. Well, the answer to this question is that there are hundreds types of diagnosis being associated with chronic orofacial pain, and in this classification I have not included the headaches. I again am reiterating why headaches, they come under the purview of dentists, because many a times the cause for the headache lies within the teeth or with the muscles associated with the head and neck region. So not going into detail of all of this, just they are basically divided into two types, axis 1, axis 2. Axis 1 is the physical condition, all the dental, the periodontal, the migraines, the tension type headaches, all those things or the neuralgias associated with pain, and axis 2 is the psychological. As I mentioned previously, any patient who has more mood or anxiety disorders or a depressive tendency is more prone to develop chronic orofacial pain, and it is vice versa. Any individual who has chronic orofacial pain has a tendency to develop depression. So now with this brief knowledge, let's review our cases initially. Let's see what the diagnosis for those patients were. As it has very well been said, the eyes can't see what the mind doesn't know. So until and unless we know what types of disorders come under orofacial pain, we shall not be able to diagnose those cases. So this is the first case that I was talking about. This lady who had undergone multiple root canals and extractions, but still she did not find any relief. If we go back to her history, which the dentist and the neurologist also missed, she is a teacher. She is a teacher in a college, and she developed this pain during COVID time. So at that particular time, she was asked to make a lot of PPTs and a lot of work. She had to do written work also, and for that she used to bend her neck most of the times. So she specifically said that I did not have similar kind of pain before the onset of this pain. It was mild, but during the COVID time or while she used to work, the pain increased, which is now presently that this pain is there continuously. So now this is again the area where this lady is pointing her pain only unilaterally going towards her forehead, the temporomandibular joint, and also she is pointing towards her neck. Two muscles being involved, sternocleidomastoid and the trapezius. It needs to be noted that these two muscles have robust referral to the joints as well as to the head and also the teeth. So now we are palpating the upper head of the sternocleidomastoid muscle, and she says now as we are pressing it, the pain is going towards her eye and towards her forehead, also the joint. Again, very important point to be noted, the patient will come to us with pain, a dull aching pain. The moment we now, here in this particular point, we palpate the SCM, where we feel the pain might be originating from, we need to ask the patient, when we are palpating or when we are touching that particular area or we are touching the trigger point, are we able to reciprocate the similar kind of pain? So this word reciprocation is very important, because the patient needs to tell us, yes, this is the similar kind of pain which I suffer from. So now this is how the pain referral is from sternocleidomastoid. These are the trigger points. These cross, what are mentioned here are the trigger points. The moment you touch those trigger points, the pain will refer in the same pattern what this lady is mentioning. So now, what is the treatment? There are multiple treatment options for this particular patient. We can give ultrasound, we can give muscle relaxants. Also for instant relief, we can give a trigger point injection. For this particular patient, since she was suffering from this pain since past 6-8 months, she was very disturbed because she had visited multiple dentists and neurologists, so we wanted her to get instant relief. Moreover, this is both diagnostic as well as therapeutic. So once we gave a trigger point injection in the area, in the trigger point of sternocleidomastoid, and we asked her about the relief, she said, now I have no pain. It's been now 8 months, this is now 8 months that I have never felt better and lighter on this particular side. So now this trigger point injection now is acting both, as I mentioned, diagnostic as well as therapeutic. Why diagnostic? Because we know that the pain has completely arrested once we have injected a local anesthetic without a vasoconstrictor in the trigger point area. And therapeutic, why? Because now we are sure that this is the area where the pain was originating from. So further, either we can go for trigger point injections in this lady, or we can also subject her to ultrasound or TENS therapy, which is non-invasive. We had followed up this patient and she was absolutely pain-free for next 2 weeks. Then again we repeated this trigger point injection and ultimately we followed it for a month with ultrasound therapy. And we had also given her some muscle relaxants just for a week's time. Just to apprise all of you regarding the referral pattern of the muscles, of the head and neck muscles. This is a typical pattern, a question mark pattern of the referral of trapezius. Now we see that the headaches, the history of headaches can be from trapezius, which is very common, and also the pain to the angle of the jaw. If there is no reason for the pain to be arising, for the pain to be emanating from the angle of the jaw, if there is no impacted tooth or any deeply carious tooth, please do not go for any invasive procedure. Just try to find out if the trapezius has a trigger point. Then next, temporalis, very common. Temporalis referring to the maxillary incisors. The posterior fibers of the temporalis can also refer to the posterior molars. The masseter, both the deep as well as the superficial masseter. In fact, deep masseter has a more robust referral to the teeth. Lateral pterygoid muscle, referral to the temporomandibular joint and the cheek region. Medial pterygoid, again to the joint and the angle of the mandible. And digastrix, that is the posterior digastric is to the angle and the anterior digastrix to the mandibular incisors. In fact, in my previous institute, I remember treating, not us, the endo department treating a lady with root canal done for her mandibular anteriors, and she said that she had no issue with her teeth. They were not carious, but then since there was continuous pain, so root canal was done for her. But then again, she was not very happy with the treatment because the pain had not subsided. So that time I didn't have this knowledge about the referral of the anterior digastrix to the mandibular incisors. So probably we misdiagnosed that case. Occipitalis. Again, occipitalis has referral to the eye region, and splenius capitis, typical referral to the neck and the vertex. This is, I will just show you the next case. This patient had also come. Click. इससे पहले picture पे click कीजिए video. See, now this patient had come with a complaint, so how, I am just telling you how to reciprocate the pain. Just palpate that particular trigger point, what you feel to trigger the pain, and now she says, exactly the patient will be able to point out, yes, this is the area, now she is referring, the pain being referred to the vertex. So now we are sure it is the splenius capitis which is being involved. This is the, again, same trigger point injection, and the patient completely feels the relief in pain. This is the surgeon whom I had shown the previous video. So this patient again had taken gabapentin and muscle relaxants and painkillers on daily basis. So for this particular patient, he was not ready for trigger point injections, but he had the trigger areas, the trigger points in both the sternocleidomastoid, trapezius, and also some trigger points in deep masseter. So we had given ultrasound therapy for him. Now if we compare ultrasound therapy with the trigger point injections are, they give you instant relief, but for ultrasound, you will have to ask the patient to come to you 4 to 5 times. But then ultrasound also gives immediate relief, but then it is a partial relief. Along with that, you have to put the patient on muscle relaxants for at least a week or 2. So this patient, once we had given him ultrasound 3 visits, he was completely pain-free. And but then, see now, this particular problem happens majorly because of the wrong posture. So once we had, now this patient had become completely pain-free in 4 visits. But then further we need to advise the patient to work on the posture and also advise the patient isometric and isotonic exercises so that the muscle becomes strong enough so that further fatigue or trauma doesn't lead to this amount of pain. This was a very interesting case where I told you the patient had pain being referred to her maxillary premolar, and this patient had the characteristic of this pain was different from the other pains. She used the word throbbing pain. So it was a pulsating and a throbbing pain, and this pain she used to initially have once in the entire month, say 3-4 days. Gradually the frequency had increased. Now this patient used to have pain 15-20 days in a month.
3 दिन बाद इन्होंने मेरे को 3 दिन की दवाई दी थी आपने, उसमें मैं 2 दिन की ही खा के आ जाएगी, तीसरा दिन में
जब आप पहली बार यहाँ पे आई थी, अगर मैं पूछूं 10 में से आपको बताया जाए तो कितना नंबर होगी, मतलब 0?
मैंने जब मैं 3 दिन पहले आई थी मैंने 10 बताया था कि 10 में से मेरे 8 के करीब था, और आज मैं कह सकती हूँ कि मेरे को 3 के करीब पेन है.
Okay. So what was this case? This was a case of facial migraine or neurovascular orofacial pain. This type of pain is typically referred to the maxillary premolar area. Differentiating feature is that this tooth will have no caries. I mean, it can be incidental finding that the tooth is carious, but the pain typically is very different. It's a throbbing kind of pain, and any cold stimuli, drinking water, will immediately shoot up the pain. And also she was giving history repeatedly this pain occurring every month at one particular point of time. So we also correlated it to a menstrual migraine kind of a pain. Later on, for this particular patient, initially I started with triptans. Triptan immediately gave a relief in 3-4 days, but then since the frequency of pain was more than 15-20 days, so it was not advised to put the patient on triptan for such long duration. So I had put her on propranolol. Propranolol, although it is an antihypertensive drug, but it works wonders in cases of chronic migraines. For acute migraines, you can treat with triptans. Any migraine lasting for 3 to 10 days, but if it goes beyond 15-20 days, we cannot give triptan, so it is always better to give a prophylactic treatment. So she gave very good results with propranolol, and her frequency of headaches now had reduced to maybe 1 or 2 days in the entire month, and which she said that she doesn't require to take painkillers, but then propranolol was continued for another 6 months. This patient who she had told us that she had pain in her teeth, she had got extractions done, and now there is a fresh complaint of pain where she feels ants moving around her cheek region. So this patient also came with pain, but now this additional feature of ants, she says that chintiyan chalti hai mere muh mein. So that feeling means there is something else associated with the pain. There is some sort of nerve now which is being involved. So this was a case of traumatic neuroma and somewhere post-traumatic trigeminal neuralgia and neuropathy. So when we palpated this particular area, there was a small area in her alveolus. The moment we touched that area, there was a trigger point, and that led to increase of pain. So that particular area, okay. So one particular area reciprocated the similar kind of pain. So what we did, local anesthesia, we injected in that one, not spicule, it was a very small nodule that we could palpate. We injected that area with local anesthesia and she was completely relieved of her pain. So further, now what needs to be done? We need to put her on corticosteroids. So rather than giving systemic steroids, we were injecting corticosteroids locally in that small neuroma sort of that we were able to palpate, and again in further subsequent visits, 4 to 6 visits, she was relieved of the pain. Along with corticosteroids and local anesthesia, we had also put her on amitriptyline. Amitriptyline is an antidepressant, but then the dose that we were giving her was 20 milligram. At a dose of 20 milligram, it doesn't act as an antidepressant, but it acts as an adjuvant analgesic, which is pretty safe until and unless patient is suffering from glaucoma or any ischemic heart disease that we had already ruled out for this lady. So this is the particular case where we had injected, I can't, देखो फिर से हो रही है picture. ठीक है रहने दीजिए. So we were able to palpate a very small nodule. At that particular small nodule, we had given a local anesthesia initially to diagnose, and further with corticosteroid along with local anesthesia, we injected, and she said that now that feeling of numbness and paresthesia and the ants moving had subsided. Okay, this is the last case.
I am Abhishek Kumar. I am from Punjab.
Okay, this patient was referred to me from Punjab, and a brief history about this patient. Same history, dull aching pain throughout, not being able to sleep at night. Then he was referred to PGI Chandigarh, where he was told that probably since
आज मैं अपनी उनकी प्रॉब्लम डिस्कस करने लगा. मुझे दो या ढाई साल से मुझे प्रॉब्लम चल रही है. कई डॉक्टरों को दिखाया, पर हर डॉक्टर कुछ ना कुछ एक्सपेरिमेंट कर ही जा रहा था. हमें खुद नहीं समझ आ रही थी किस चीज़ की प्रॉब्लम है. कोई बोल रहे कि जॉइंट्स की पेन है, कोई बोल रहे कि TMJ की प्रॉब्लम है. डॉक्टरों ने MRI भी करवाई, तो हमें नहीं पता लगा, पर डॉक्टर अपनी तरफ से एक्सपेरिमेंट कर रहे थे. मुझे प्रॉब्लम इतनी ज़्यादा हो गई कि ना मैं सो पाता था, एंजाइटी होती थी, सिर दर्द रहना सारा दिन, इरिटेट हुई जाना, तो बहुत तंग आ गया था मैं. फिर मुझे किसने रेफरेंस दिया, राजीवा डॉक्टर उपासना मैम का, तो फिर मैं उनसे मेरा ट्रीटमेंट चल रहा है. तो मुझे मेरी 2-3 सीटिंग हो चुकी है उनके पास. तो उन्होंने मुझे सप्लीमेंट दिए बना के, मेडिसिन दी, उससे मुझे बहुत ज़्यादा फर्क है, 80 to 85%.
okay, now see, for this particular patient, since he had all those similar kind of pain, associated feature with this patient was that he said that he was not able to sleep at night. He was so restless. So as I mentioned previously, anxiety, this patient also had anxiety disorders. So just treating the local cause will not do any good to the patient. This patient also had the bruxism habit. So when you are bruxing all the time, obviously your muscles will be fatigued. This particular patient also had trigger points, but this time the trigger points were in deep masseters. He was not very willing for trigger point injections. We had just, I had advised, in fact I had just fabricated this occlusal splint. This is the stabilization splint for him. Gave 3 visits of ultrasound, and then he was absolutely pain free. Along with that, for this particular patient, I again put him on amitriptyline, and also referred this patient to a psychiatrist who did some cognitive behavioral therapy for him, and now he is absolutely fine. So the basic premise for showing all these kinds of cases to all of you were that it is very important for us to rule out the etiology, the main cause for a tooth pain or a pain in the jaws or in the joint or being referred to the head. It is very important, and we also need to be very vigilant about any systemic factor being involved with the pain. Education of the patient and explanation of the treatment is very important. These patients, they would also come to you saying, हमें तो cancer हो गया. and that makes their agony even more debilitating. We need to explain them. There is nothing malignant. We can take care of it, but it will take some time. One thumb rule for treating any patient with chronic orofacial pain is never promise them 100% cure. Because once I told you the pain becomes beyond 6 months, there is something as chronic sensitization in the cerebral cortex, where the pain, even if there is very less stimuli, the pain will be felt in a more exaggerated manner. So we need to be very watchful and careful and not make any false promise with the patient saying you will be 100% pain relief. Once we are able to achieve 60-70% pain relief, I think it's a good job that we've done. So the other treatment options that are available to us are the TENS, the ultrasound, the orthotic appliance, and in pharmacotherapy, most common, your NSAIDs. You can put the patient on naproxen. Why rather than putting the patient on ibugesic, naproxen is better because it's highest concentration in the synovial fluid. So for temporomandibular joint disorders, naproxen is anytime better than any other analgesics. We can put the patient on medroxal, that is steroid. The patient who had got her extractions done, who has now come to us with a different kind of complaint, where the ants moving, probably there was a nerve that was involved. So for nerve, to prevent any nerve damage, first of all, the procedure should be done as atraumatic as possible. If at all, some amount of trauma obviously does happen. If you are suspecting any sort of nerve injury, put the patient on high dose of steroid for 6 days. Nothing will happen. High dose of steroid for next 6 days will do more good to the patient than doing any harm, because once the nerve injury has happened, beyond say 48 hours or beyond say 3 days, the nerve injury then becomes irreversible. Then nowhere can you ever treat any nerve injury. So it is always better to prevent nerve injury. So chronic pain management involves change in the mindset, and as dentists, we need to think and treat beyond just teeth. And just if at all we are not able to do justice to a patient or not being able to diagnose the cause of the pain, it is always better to refer the patient to a OFP specialist or a neurophysician or a physiotherapist or also a sleep physician. See, this is a statistics that has been taken from Canada. The less amount of knowledge that we have about chronic orofacial pain is not purely our mistake. If you see the curriculum, dentistry, where the majority of the patients come to us with the complaint of pain, pain is taught for least number of hours in compared to the veterinary medicine, where the amount of teaching for managing pain is the maximum. So the take-home message is, we should be a physician of the stomatognatic system and not just mechanical dentists, and do our diligence to the patients and avoid doing any irreversible damage to a tooth, because it's not going to do any good to the patient. The patient is definitely going to come back to us with a complaint which is going to be problematic both for the patient as well as to the dentist, brings a very bad name to the dentist also. So it's never late for us to upgrade ourselves, so we need to be very well versed with this new branch of dentistry which is growing. Thank you.
Thank you so much, ma'am. PFA International President, USA, Dr. Ashish Chandra sir, PFA Section Co-Chair, Asia Region, for felicitation. I'd like to invite Dr. A. Siddharth Verma sir. Thank you, sir. Now I would like to invite Dr. Upasana Sethi ma'am.
She was telling me. She told me that she learned a lot.
Oh, thank you so much. Thank you. Oh, thank you.
Thank you, sir. Thank you, ma'am. Thank you, sir. Thank you, ma'am. Is eminent prosthodontist and implantologist. Topic of the lecture is oral implantology.
Congratulations to PFA and Cynodent for organizing such a good event, and congratulations to all the fellows who would be inducted with such a organizing body for the premium and the executive fellowship for the same. So the topic of my lecture is optimizing the key elements to optimize implant aesthetics. So whenever we talk about aesthetics, so beauty lies in the eye of beholder, and what we know is it comes in different shades. So whenever we talk about dental aesthetics or dental beauty, what are we looking at? Are we looking at crowns which our patients get wherein we see any kind of marginal gingiva getting recessed, or cases like these with black triangle coming up over the period of time? Today major focus has shifted all the way from a proper aesthetics to which company implants we're going to place, or maybe cases like these wherein we see a greyish hue or a tattoo coming over the period of time once the patients start using the processes. Or similarly, wherever we need to mimic the soft tissue by giving a pink ceramic. So we have to understand from this point of view, are we really giving justice to our patient by placing implant and restoring the cases? Or we are just placing implant for the sake of doing the same? And if I still see major cases like these wherein there is very thin buccal shield or buccal bone present, and wherein we place implants, it's always better to do a bridge rather than placing an implant in these cases. So these are few cases just to show you what is this titanium tattoo or a greyish hue which is happening over the period of time, and where are we going wrong. So before we start this lecture, having said that, my name is Dr. Jasneet Singh Kalra. I've done my graduation from Saraswati Dental College, Lucknow. I'm indebted to ITS Dental College, Greater Noida for whatever prosthetics I have today. I'm diplomat with World Congress for Oral Implantology, key opinion leader with various implant companies. I've been extensively trained for hard and soft tissue by Geislick, and I'm mentored to two of my major implantology courses, which are foundation courses in implantology and Lex Crown implant. So always believe something wonderful is about to happen. So cases like these, we see a regular 1-1-2-1 tooth missing, and what do we do next? We straight away plan either to give a bridge in this case, to give a removable partial dental or fixed dental processes, or straight away placing implant. So the first treatment plan, it has to be implant today. So whenever we talk about implant, we open up a site, and yes, still we see a decent amount of bone which is there to place my implant. But as soon as I lift little bit more, now what do we see? This buccal dehiscence is something which is not uncommon. It is very, very common, and because of these kind of dehiscence, we have to understand what treatment plan we need to shift from. Or cases like these, as soon as the extraction has been done, we see hardly there is any interdental bone which is present, or we see there is, you can see any kind of bony resorptions in the cases. So the first and foremost, first thing is, before we plan any case, we have to think towards this SAC classification. And we need to classify our case, what are the simple cases, what are the advanced cases, and what are the complex cases as per the classification. Important, very, very important point. So 3D implant placement, we have to understand if my implant is not placed in the prosthetically right dimension, I cannot expect the processes to follow the same. And today what I'm looking in my cases are, the first thing as a prosthodontist, I always see towards teeth. So for that matter, we all have been, right from day one of implant training, we have been learning these kind of classifications. From implant to tooth, it has to be 1.5 millimeters of space, and between the two implants, it has to be 3 millimeters. Furthermore, most important point, which is 3A, 2B classification. From from the implant shoulder to the final CEJ or to the planned CEJ of the crown, the distance has to be between 3 to 5 millimeters if we want to avoid any black triangle. And whenever we talk in terms of orofacial dimension, the implant should be placed at least 1 millimeter parietal to the point of emergence of the adjacent teeth. So until unless we are not taking care of these rules, I don't expect just placing implant in the bone make any sense. What are these 10 successful aesthetic principles, or what are the keys to implant aesthetics? It starts from the very first point. We need to assess the aesthetic risk assessment. What is the smile line of my patient? What is the zenith I'm looking for? My patient has a low smile, medium smile, or a high smile. Furthermore, what is the pink is to white ratio? Next, CT planning. I need a perfect tomographic planning, whether we talk about OBGs, we talk about CBCTs. Minimally atraumatic tooth extraction. Gone are the days when we used to compress the sockets or we need to use forceps. Today what we are using are the luxators or periotomes for atraumatic tooth extraction, which needs to be learned over the period of time. 3D implant placement, narrower versus wider implant. Today we place more of narrower and longer implant rather than shorter or wider implants. Yes, shorter implants are used whenever we are encroaching inferior angular nerve or sinuses, but yes, today we place as wider and take better anchorage from the cortical bone. Bone gap, bone graft, whenever there is a jumping distance, as per the jumping distance, we need to understand whether we need to graft the side or not. Facial gingival grafting, which would suggest CT or FGG grafting. In few cases, we need to take care of we need to augment the soft tissue, because soft tissue will follow the hard tissue. Immediate contour management, final restoration with screw retain process is very, very important. Wherever possible, we should avoid giving a semen retain processes. So starting with my first case, meet my patient Nadeem. He had the tooth which was wherein we planned implant was 1-1 because it was a ailing dentition tooth. We went ahead for ERA. In that assessment, it was a low smile line case. We went ahead, got a CT graft. We got a computed tomography or CT planning. If we can see, the buccal bone is hardly 0.3 to 0.5 millimeters, wherein we have a decent amount of palatal bone in this case. Went ahead, we did a minimally atraumatic extraction. Post that, this is the buccal dehiscence which was there. Placed my implant with the help of osteodensification. So these are specialized denser drills which are there so that I can densify my site for a better stability. Placed my implant, then placed healing abutment, and then we started with GBR. So generally my straightaway plan is to harvest the autograft from the site, mix it with xenograft and the combination of two, and I just use any kind of collagen membrane to cover the same. So this is how we do. So we have stabilized the collagen membrane, sutured it up. This is after 6 months. So if you see, the buccal contour or the labial contour is absolutely perfect. From here we moved on to the temporary processes before moving on to the final one. After the temporary processes, this is the images profile of what we have got. So moving ahead with prosthetic planning, we did open tray impression for the same, and this is what my impression is. Went ahead, got a jig trial fabricated from the lab. We did the jig trial. Once this was verified, we went ahead and got a customized abutment done for the same. So my plan in this case was, since my implant was slightly palatal, even then I wanted to go with a titanium custom-made abutment onto the top E-Max crown. So this is what my final processes was, and that's how it looks in the patient's mouth. This is the access hole which was completely palatal. That means the implant was placed as a 3D implant placement. It wasn't buccal at all. And this is the final processes and final smile of the patient. So this is what we are looking for. So patient will not come to you saying or having a complaint of titanium deficiency. What he doesn't have is a tooth, and if he is giving the right the replacement of the tooth, this is how we need to do, or we need to justify with the patients. Second thing is, none of the aesthetics can be complete without talking about socket shield technique. So this is one technique which has been very handy with my hands at least. And what do we generally do in this case is, we basically split the tooth into two halves, the buccal half and palatal half. We remove the palatal sheet, We want the buccal shield to be intact so that whatever amount of buccal bone is there, it should be intact till the time my implant is placed over there. And my implant goes right in the parietal position. So we started the treatment by splitting the tooth, that's my buccal shield, removing the parietal aspect of the root, placing my implant and taking engagement from the apical bone, that's the final implant placement. And then we need to trim or treat this shield. This shield should be trimmed at least 1.5 to 2 millimeters below the marginal gingiva to have a better emergence profile. And this is a diagrammatic illustration just to show you how do we do this procedure. So we split it, we leave that shield, there has to be a jumping distance. We try keeping that jumping distance of minimum 1.5 to 2 millimeters so that we can have a bone between the implant and the shield. And that's the final outcome. And if we see intraoral, that this is how my periodontal or my marginal gingiva looks like. If you see cases wherein we do a regular implant placement, the basic thing is to match the zenith. The basic thing is to have a perfect periodontium or a healthy periodontium which patient would maintain over the period of time. So this is something like we are disguising the tooth by keeping a buccal shield over there, placing my implant and giving the processes. So my buccal bone knows there is still a tooth which is present there and the resorption of buccal bone will be as less as possible. And the factors which would influence the implant placement in PET, partial extraction therapy or socket shield technique. So these are the factors. We need to see an amount of bone beyond the socket from where we will take engagement of implant. Second thing is, what is my jumping distance? It has to be between 1.5 to 2 millimeters. The facial bone thickness and height. As per this classification given by Howard Gutmann, we need to classify, every case cannot be done with socket shield. You have to see what kind of case are you encountering. If it is a class 1, 2, 3 or 4, still socket shield is very much predictable and it can be done very easily, whereas in case of class 5 socket, it is not possible to do a socket shield. In this case, I would extract my tooth, place bone graft collagen, wait for at least 4 to 6 months, let the host bone completely heal of its own, and then I would move ahead and do my implants and prostheses. Angle screw channel, a paradigm shift in implant processes. So whenever we talk about implant processes, we always look towards passive placement of my processes. My processes should go as passive as possible. It should not be active. The path of insertion and removal should not give stresses to my screws. So if you are doing implant processes in your day-to-day practice, you must have seen the major stresses. They are onto the implant screws. So this is one abutment which can take off all the stresses from the screw, and the chances of any kind of screw fractures decreases. So a case wherein there was alien dentition of crowns over the period of time, went ahead, we checked for ERA. Post that we got a panoramic and a CT board done, a decent amount of bone. We went ahead, we removed all the faulty processes, and this is how the collapsed smile of the patient was. We went ahead with implant placement, placed 2 implants, which was anterior to this premolar, placed 3 implants posterior to the premolar. Now this premolar was periapically involved, because of which I had to lose one of my implants, which was my 3rd implant, at the side of my 1st and 2nd premolar. So we lost this implant over the period of time. Went ahead for processes, we placed multi-unit abutment or angle screw abutments. Okay. Once we have placed that, these are the comfort caps onto the top of these abutments. This is how it look like. Generally, whenever you need to place any kind of angle screw abutment or multi-unit abutments, you have to understand still they should be at least 0.5 to 1 millimeter subgingivally placed if you are placing in aesthetic zone, so that you can have a better emergence profile. But in cases of molars, you can have it either supragingival or equigingival. You will have no issues at all. Rather, the cleanliness or hygiene can be easily maintained. Went ahead, we did splinting of the impression copings, picked up impression, and I am a very old school thought. I am very happy in making open trace impression. I hardly go with close impression or abutment level impression, but nowadays we are more into digital impressions. And that's the final impression. Upper and lower both, got a jig fabrication done, did the jig fly in the patient's mouth. We always rectify jig by making an IOPA and see the connection, and then the final smile of my patient. And this is in the patient's mouth, and this is what my OPG says. So very important thing is, once you complete the prosthetic phase, You have to understand these two things. You need to see the junction of your multi-unit abutment with the implant. There should not be any space here. And at the same time, once your crown is seating onto the multi-unit abutments or any abutment, there should not be any gap there. If at all there is any gap, that means the seating of your processes is not there, one, and it is active. So now, this is what we are looking at once we complete the case. Another case, I would just show you a contour grafting and dual zone grafting with GVR. A regular case of first premolar missing. And what we see, the tooth is not missing just that. If the first premolar generally comes in my aesthetic zone. And can you see that buccal dehiscence, a very prominent buccal dehiscence. A young patient, she was about to get married in 1 year's time. We need to give a good replacement. We went ahead. We did a guided surgery done in this case. First the CT planning was done, got a surgical guide fabricated for the same. We went ahead, did a punch drill with the help of this guide, opened up a flap. Can you see that buccal dehiscence or C-shaped dehiscence? We went ahead, did osteodensification by specialized denser drills. And then next thing was placement of my implant or fixture. As soon as this was done, can you appreciate the greyish hue there onto the buccal side? That means hardly 0.5 millimeters, 0.3 to 0.5 millimeters of bone is there, which is still present on the buccal region. So obviously guided bone regeneration was planned, decortication was done, and basically for decortication what we do, we basically drill holes with the help of round burrs so that we can have a mechanical anchorage of autograft and whatever graft we are harvesting, we are producing over the period of time. And collagen membrane, we stabilize membrane, place our graft. I always overfill in these cases. By the end of the day, I don't want any dehiscence to be there, and I know 30 to 40% of my graft, it is going to resorb over the period of time. We are just stabilizing the collagen membrane with the help of stabilizing sutures. Either you can give a figure of 8 suture, you can do horizontal mattress suture. What I prefer today is apically positioned horizontal mattress suture. The suture is my go-to suture in these cases. And we started from there. This is after 6 months, and this is after second stage surgery. Now you can see whatever C-shaped concavity or buccal dehiscence was there. This was completely covered once the bone grafting was done in this case, and that's the final smile of my patient. So it is not about just replacing a tooth or a soft tissue or a hard tissue. We always have to see in conjunction to white and pink aesthetics both. Final case, wherein a full mouth rehabilitation was planned. In full mouth rehabilitation, there are so many things which we need to evaluate before we plan a case. First and foremost thing is what is going to be my implant position, A, B, C, D, E as per wish classification. Second thing is what kind of processes are we planning? Are we planning to give a removable processes or a semi-removable processes? Are we planning to give a fixed processes? In fixed processes, whatever options do we have? What is going to be my substructure? Am I planning to give my substructure as titanium, chrome, cobalt, teak, and what is going to be my superstructure? Whether I am looking towards a PFA processes or I am looking towards Emax processes. So in this case, we went ahead, we did implant placement in maxilla and mandible both, and as soon as we place our implant, we place multi-unit abutment right on the day of surgery. After the placement of multi-unit abutment, this is how it is. And if you see my multi-unit abutment which are placed in the aesthetic zone are 0.5 to 1 millimeter subgingival to have a better emergence profile. Went ahead, we did a digital scanning for maxilla and a physical impression for mandible. And this is how it is. Post that, we got jig trials fabricated, we rechecked the patient's mouth, everything was verified, we went ahead, did a jaw relation. So this jaw relation or a bite is almost similar to what we were taught at the time of our undergraduate or a complete denture processes. The only difference is we get a fixed bite made instead of a removable bite. So that fixed bite is fabricated onto the top of titanium cylinders. So we have these two titanium cylinders. So these two, we fabricate two trays. The first tray would be just attaching the base tray onto the top of your implants, and the second tray would be having the bite onto the top. And then we do a jaw relation as we generally do in complete dentures. Once the bite was fabricated, we got a final processes from the lab. So this processes was a PFM processes. So we have titanium as a substructure and porcelain fused to metal as a superstructure onto the top. And the processes was mid processes. And that's final in the patient's mouth. Once this was verified, we started from here, we ended here. That's the final smile of my patient. I'll show you through a medium of the video as well. OPG is just to show you where the connection look like, and that's the final smile. Planning is very, very important. Processes, again, what kind of processes are we looking at, and over the period of time, maintenance of the same. What are the key takeaways? Case planning and treatment. What treatment are we, and where are we placing implant? What processes planning are we doing? 3D implant placement, temporization. I temporize almost all of my cases. Either it is if it lies in the aesthetic zone or it's a full mouth case. We do immediate loading in a full mouth case. Learning curve from implant placement to prosthetic, it takes some time, and lab credits and interaction is very, very important. What lab are you planning your processes with? You should have a clear-cut conversation with the same. Every ending is a new beginning. Thank you so much for your patience. This thing. We're open to any questions if you have. Thank you so much.
Thank you so much, sir. For the next lecture, I would like to invite Dr. M. Siddharth, sir. He is the Dean, School of Dental Sciences, Sharda University, Greater Noida. Topic of the lecture is Infection Control in Dental Practice. Please welcome, sir.
Good morning, everyone. I wish to thank Pierre Fochard Academy, Section at Large Asia region, for inviting me for this lecture. I am going to discuss a very basic topic, infection control in dental practice. But I think it's a very important topic, and all of us have gone through the pandemic, and we have realized how important this topic is. So, greetings from School of Dental Sciences, Sharda University. I am the Dean, Professor and Head Department of Periodontology. This will be covered under definitions, fundamental elements for infection control in dental setting, standard precautions, transmission-based precautions, a little bit about COVID-19, sterilization and disinfection of patient care items and devices, special considerations. Now, patient-to-patient infection transmission does occur in dental setting, and studies have shown that mainly it is due to unsafe injection practices, failure to heat sterilize dental handpieces between patients, and failure to monitor autoclaves. Infection prevention should be a priority in dental settings, and they should be equipped. All dental clinics and all dental settings should be equipped to observe standard precautions and infection prevention recommendations as per the latest CDC guidelines. Coming to some important definitions, sterilization. It is use of a physical or chemical process to destroy all the microorganisms, including substantial number of resistant bacterial spores, whereas disinfection is the destruction of pathogenic and other kinds of microorganisms by physical or chemical means, and disinfection is less lethal than sterilization, and it does not destroy all the bacterial spores. Some of the fundamental elements for infection control in dental setting include administrative measures. At least one dental healthcare personnel in every dental clinic or in a department should be trained in infection prevention and program coordination. there should be written infection control prevention policies laid down. And training should be provided to all dental healthcare personnel at regular intervals, whether it is in a clinical setting or a private practice or a healthcare institution. Then safety of dental healthcare professionals is of paramount importance. They must be immunized. Immunization for hepatitis B, MMR, varicella and COVID-19 recently. They should be screened regularly for tuberculosis and they should be referred for post-exposure management. The infection prevention control program in every institution or clinic should be evaluated regularly for improved effectiveness of the infection control program. There should be periodic assessments, checklists and review of occupational exposures to blood-borne pathogens. Coming to standard precautions, it used to be known as universal precautions earlier, now it is known as standard precautions. They are minimum infection prevention practices that apply to all patient care regardless of suspected or confirmed infection status of patient in any setting where healthcare is delivered. This protects both dental healthcare personnel and the patient. The first important aspect of standard precaution is hand hygiene. Hand hygiene should be performed before and after treating each patient. It should be done before putting on and after removing gloves. If the hands are visibly clean, they should be cleaned with an alcohol-based hand rub. If hands are visibly soiled, then they should be washed with soap, which can be plain or antimicrobial, and water. And for surgical procedures, we must follow the standard protocol of surgical hand scrub as displayed in the photographs. Coming to personal protective equipment, gloves, they should be disposable and changed after every patient. For non-surgical procedures, non-sterile examination gloves may be used. For surgical procedures, we have to use sterile surgical gloves. For manual instrument cleaning, we should use heavy-duty puncture-resistant gloves. And in case any individuals have latex allergy, then there is provision for non-latex, that is nitrile or vinyl odor-free gloves. Then we must use disposable gowns and enclosed footwear. Coming to masks, masks should have block particle size of less than 3 microns. They should be disposable. They should cover the mouth and nose. There should be 2 ties. Masks should never be touched during the procedure. And when they are wet, they should be discarded. And they should be put on before hand hygiene procedures. Eye protection, they should be optically clear, anti-fog, they should be close-fitting and should be shielded at the sides. They should be cleaned with disinfectant if they are contaminated and should be worn, eye protection should be worn not only by the dental healthcare personnel but also by the patients. And we can also use a face shield. Now coming to respiratory hygiene and cough etiquette, paramount importance after COVID-19, but these guidelines were included much before COVID-19 came. So they apply to dental healthcare personnel and patients. You should cover your mouth or nose whenever you are coughing or sneezing in the clinical healthcare setting. We should use and dispose of tissues without touching. We should perform hand hygiene after contact with respiratory secretions. We must provide masks to coughing patients. And ideally, there should be a separate area for patients with respiratory infections. Then coming to sharp safety, we must use engineering controls such as self-sheathing anesthetic needles, safety scalpels, needleless IV ports, sharp containers should be present, and we must also use needle recapping devices. Some work practice controls include one-handed scoop technique for recapping needles. We must not bend or break needles before disposing. We must not pass a syringe with needle by hand. And we must remove burrs or scaler tips before disassembling the handpiece from the dental unit. And we must use instruments in place of fingers for tissue retraction. Coming to safe injection practices, local anesthetic needles and cartridges the dental cartridge syringe should be cleaned and heat sterilized between patients. Failure to do this has been found in studies to result in maximum cases of transmission of infection. So the dental cartridge syringe should be cleaned and heat sterilized between patients. We must disinfect rubber septum or medication vials with alcohol before piercing. We must use single dose vials ideally for single patient use. Additional doses from single or multi-dose vials with the same patient, we must use a new needle and syringe. And lastly, multi-dose vials ideally should be confined to only a single patient use and discarded. Coming to environmental infection prevention control, we must use physical barriers such as plastic sheets to protect clinical contact surfaces, and ideally we must change them between patients. We must use disinfectants to clean and disinfect clinical contact surfaces where they cannot be barrier protected, and there must be a laid out policy for cleaning and decontamination of spills of infectious liquids. Now coming to transmission-based precautions. Transmission-based precautions are applied for patients with known or suspected infectious diseases that can spread through contact, droplet or airborne routes such as skin contact, sneezing, coughing. Common infectious diseases include tuberculosis, measles, chickenpox, H5N1, avian influenza, SARS, Nipah virus, and recently COVID-19. Such cases, there should be early detection and management of infection patients at initial points of entry before they enter the dental clinic. We must reschedule non-urgent dental care until patient is non-infectious, and referral to a hospital or a tertiary care center when urgent dental treatment is needed. Coming to a little bit about COVID-19, I think all of us have gone through all the guidelines which were provided by Ministry of Health, the CDC and the Dental Council of India. But in short, risk assessment should be done. If it's what is a low risk patient? Those patients or COVID-19 or they've had history, those who are vaccinated, they are RT-PCR negative and asymptomatic. So dental procedures with appropriate precautions should be carried out regularly with them. High risk patients are those with COVID-19 symptoms, RT-PCR RAT positive. We should only provide emergency procedures with standard COVID protocol, that is level 3 PPE. Then referral to higher tertiary care centers if necessary, and COVID-19 vaccination is a must for all healthcare workers. There should be a time-based appointment system for such patients. Screening of patients at the dental clinic entry before they enter the patient. The waiting area, there should be visual alerts about respiratory hygiene. There should be installation of glass and plastic physical barriers. There should be availability of masks and hand sanitizers in the waiting area. Physical distancing should be applied. The area should be fomite free. Unnecessary objects should not be there, and there should be contactless payment. Some of the infection control procedures we follow for such patients: pre-procedural mouth rinse with povidone iodine or chlorhexidine gluconate. High vacuum suction should be done. We must use a face shield and an N95 mask. Rubber dam wherever applicable. There should be adequate time between two procedures for allowing sterilization to take place. That's very important. Disinfection of equipment and operating surfaces with 1% sodium hypochlorite or 70% alcohol. Floor mopping should be done with 1% sodium hypochlorite. Waste management should be carried out as per the current guidelines. There should be disinfection of impressions, casts, prostheses and appliances. In such times, you must prefer extraoral radiographs to intraoral radiographs. We must maintain air circulation with natural air through frequent opening of windows and exhausts, and use of portable air purifiers with HEPA filters. Now coming to actual sterilization and disinfection of patient care items and devices, there is a Spalding's classification of three types of instruments depending on their risk categories. They are classified as critical items, semi-critical items and non-critical items. Critical items are those instruments which gain or they enter into soft tissue or they come in contact with bone and bloodstream. For example, surgical instruments, scalers, they must be heat sterilized. Semi-critical items include those instruments which come in contact with mucous membrane or non-intact skin. For example, mouth mirrors, respiratory instruments, tweezers, probes, impression trays. They also must be heat sterilized. Whereas if they are heat sensitive, then they should be carried out. A high level disinfection should be carried out. Coming to non-critical items such as which contact the skin only, such as radiographic cone, head, face bow, protective eyewear, whip chain. They should be cleaned, followed by disinfection with disinfectant, and wherever possible we must protect the surfaces with a physical barrier. Now coming to reprocessing, reprocessing in the sterilization and disinfection of devices includes all steps necessary to make a contaminated reusable device ready for its intended use. These are the following steps. It starts with cleaning, then testing to make sure that it is not contaminated with blood or saliva, then packaging, labeling, disinfection and sterilization, and followed lastly by storage. The reprocessing area should preferably be a dedicated room which should be separate from the clinical operatory. There should be separate areas in that reprocessing room for receiving, cleaning and decontamination, preparation and packaging, sterilization and storage. And the instrument flow should be in a direction from dirty to clean. Coming to cleaning, we must pre-clean instruments initially after finishing the procedure by wiping at the chair side to remove contaminants such as blood or salivary secretion. Manual cleaning by hand is discouraged. Automated cleaning can be used using ultrasonic cleaner or a washer disinfection using chemical agents. After cleaning, instruments should be checked visually to ensure that all contaminants are removed, and they should be dried before packaging. Packaging in the form of instrument cassettes, peel pouches of plastic or sterilization wraps. For non-critical instruments we may use cassettes. For critical instruments they must be wrapped. Okay, and we must, where they are wrapped, we must use chemical indicators, either internal or external, with all packages. And all these wrapped instruments must be labeled with sterilization date and time. Coming to the actual steam sterilization, there are basically two basic types of steam sterilizers: the gravity displacement and high-speed pre-vacuum sterilizers. I won't go into the details of the gadgets, but we must make sure that we use steam sterilizers for packaged items. They must have a drying cycle. The most important, regular monitoring of sterilization cycle should be done using by checking the mechanical indicators such as pressure and temperature gauge settings. We must use internal and external chemical indicators such as indicator tapes, strips and tabs, and also biological indicators such as heat resistant spores of Geobacillus stereothermophilus. And we must maintain sterilization records. Storage of the instruments after sterilization. They should be stored, they should be covered or placed in closed cabinets. The wrapped packages should be inspected before use to ensure that the packaging material has not been compromised. Compromise includes if it is wet, if it is torn, or if it is punctured. So any of these compromised packs, whether it is wet, torn or punctured, should be reprocessed before use on a patient. Now coming to special considerations, dental handpieces, they should be cleaned, lubricated, wrapped and sterilized in steam sterilizers after each patient. Dental radiology, devices should be either ideally heat tolerant or disposable. Dry films packaged should be wiped with a paper towel and placed in container for transport before using processing. Protective barriers should be placed on radiographic equipment and should be changed ideally between patients. If the equipment is contaminated, it should be cleaned and disinfected with a disinfectant. RVG sensors should be cleaned, covered with protective barriers such as plastic wraps, and these plastic wraps should be changed after each patient. The curing light should be cleaned prior to having barrier placed and changed. The barrier should be changed after every patient. Now when we use electrosurgery, lasers or air ablations, we must use high filtration surgical masks such as N95 masks. High volume suction should be used to prevent the inhalation of plume. And we should have adequate evacuation systems which remove the plume. Impressions should be rinsed. After taking impressions, should be rinsed with cold running water, following which a diluted detergent should be applied, after which it is rinsed and then immersed in a 0.5 sodium hypochlorite solution for up to 15 minutes. Aeronautic files, ideally hand files should be of single use. If you are using nickel titanium rotary files, then this procedure can be followed. 10 in and out strokes in sponge soaked in chlorhexidine gluconate solution, following which you immerse in enzymatic cleaning solution for 30 minutes, after which ultrasonification for 15 minutes in enzymatic cleaning solution, rinse in water and followed by steam sterilization. Now this is the take home points. Dental practitioners must do. First, we must comply with the latest current infection control guidelines which are provided by CDC and by the Ministry of Health, Family Welfare and Dental Council of India. Dental healthcare personnel should be trained in infection control protocols. We must report, monitor and rectify breaches of infection control protocols. There must be record of workplace incidents and accidents such as sharp injuries. We must regularly monitor the immune status of dental healthcare personnel. There must be an immunization program for all dental healthcare personnel. Hand hygiene programs should be used regularly and trained also. There must be safe handling and disposal of sharps. We must prevent and manage occupational exposure to blood-borne viruses such as hepatitis B, hepatitis C and HIV. We must have an environmental infection prevention control program, and there must be specialist medical management after potential exposure to blood-borne viruses, and of course safe dental practices during any pandemic such as COVID-19 pandemic. Thank you so much for giving me this opportunity. I again wish to thank PFA Academy and Dr. Anmol Bagaria and Dr. Ashish Chandra for inviting me. Thank you so much. These are the references. Thank you.
Thank you so much, sir. For the next lecture, I would like to invite Dr. Pavitra Rastogi, sir. He is an eminent oral and maxillofacial surgeon and internationally renowned facial cosmetic surgeon. Topic of the lecture is facial aesthetic. Please welcome, sir.
This gathering and such, esteemed doctors who some of us have always looked up to. Without wasting much time, I would like to start with the topic, which is aesthetics and aesthetic surgery. This is a very broad spectrum term, and we've done a lot of study and research regarding the same. We've been practicing the same for years now. And when I say broad spectrum term, because there's so much to show and so very less time to actually put it across, I'm just trying to keep it very visual so that you can see the befores and afters and try and understand how this works. Because till the time you don't understand, and there's a lot of science behind it, and understanding the science behind it makes it more important. So, I'm sure not many people will be happy, especially the women, after looking at this slide, which basically says women age faster than men. And I do see some upset faces in the crowd, but I don't believe in this saying. You know why? How many of the males have moisturized or applied sunscreen? I haven't done it. Has anybody done so? But you ask the ladies, they will have a routine and a regime to follow. Everyone. And aging is a continuous process. Till the time you don't invest in your own skin and your own self, you will continue to age by the minute and by the second. So, for me, this study doesn't stand any ground, and I don't validate it at all. So, all the ladies can be happy again. Okay. When I say aging process, that basically means that there are multiple fat pads on the face. When we say fat isn't good, but for the aging face, fat is brilliant. If the fat is in the right proportion in the right areas, you will age gracefully. It is actually the droop and the sagging that happens right from down below from the bone. We are aging from the bone. We are not aging from the soft tissue. We all know that when we are young, we have a profile which is convex or straight. As we age, this profile becomes concave. There are multiple retaining ligaments, true retaining ligaments, which attach from the bone to the soft tissue, to the musculature. And as we are aging from the bone, all this soft tissue and musculature starts to collapse. And that is where the fat pads start to drop. And fine lines, wrinkles, rounder face, all these aging changes happen then. So these are the ligaments that I'm talking about, and this is the triangle that I would want to emphasize. This basically means that when the face is young, any young individual will have more volume starting from the temples and mid-face and the least amount of volume in the jawline. That is why the jawline appears contoured and sharp. When we age, the face will start turning rounder. And as you age, and if you're not looking after your face and your skin, this will become an oval kind of a face. So all the tissue starts to drop because of the effect of gravity. So what is aesthetics? It is so broad that there is a huge surgical domain which we follow, and there is a bigger non-surgical domain or minimally invasive domain. But the end point is, to become a good aesthetic surgeon or follow the same, you will actually have to have knowledge and about everything. Because that means you're not misguiding or have a bias towards some procedures that you are very good at. So you should actually have very sound knowledge about everything, right from surgical to non-surgical things, so that you can deliver results. Now this is the video there. I would request, excuse me, can you just, this guy is quite busy there. He needs to be looking at me. Please look here when I'm talking. Please play the video. So things like this. You think males don't come for surgery? Now look at this video. This young male, also the volume please. Look at the number of procedures we've done for him. A rhinoplasty, closed rhinoplasty, back hair corrections, lip reductions, putting stereolith implants to give him a jawline, a masculine jawline. So jawline augmentation is a must, doing submental liposuction so that his neck tends to be looking firm and stern, and everything is around the jawline for a male. You want a sharp, chiseled jawline, we can give it to you. There's a way to do it. You need to understand the jawlines and how you can actually deliver results. So all this, males are coming in numbers these days, surgical and non-surgical. So, coming on to non-surgical things, you have something known as Botox or botulinum toxin. Multiple different companies give it. What does it do? It basically relaxes the fine lines and wrinkles, which are dynamic in nature, in function. It can be any brand. I don't stand by just one. We can use multiple brands, but make sure your products are actually CE certified and FDA approved. They come at 50 and 100 units in India. Abroad, we have 200 units as well. You need to dilute them. What is the use of the toxin? Apart from the cosmetic use, we use toxin for a lot of therapeutic things. Example, TMDs, atypical facial pain, uralgias. I have a case series of 485 patients in which I have used Botox for TMDs, and the results are so promising that it's a PubMed indexed article and multiple different articles around it, because TMD is something that all of us face on a routine basis. So a lot of patients, how long can you put your patient on relaxants? And the main thing is it's starting from a faulty bite, and correcting that bite takes time. In the meanwhile, the patients actually get relief with this because you're relieving the neuromuscular stress and the tension. So yes, it is a pain-free period for the patient, and the patient will thank you because they're not popping in painkillers and muscle relaxants during that time period. We used it for siluria, TMDs, atypical facial pain, muscle movement disorders. Facial paralysis, we are actually just camouflaging the normal side to make the face look better. Now, before we start, the most important thing is learning when to stop. The idea of aesthetics is to give a natural looking face rather than a made up face, and making someone look better at their own age is the idea behind aesthetics, not to make someone look artificial. So simple cases like forehead toxins, or combining it with fillers in wrinkles which are static, in between, if you can see, we combine it with fillers. So there are multiple things, but there is a lot of science behind it, because if you're using fillers, you need to be wary about something, which are the vessels. If you're close to the vessels, you can actually go into the vessel and cause vascular occlusion. I'll show you some demo cases of that as well. This is a dimple chin or golf ball appearance, again with the use of toxin. Gummy smile. How many of us have seen cases of gummy smile? Now, gummy smiles are primarily because of vaulted passive eruption or vertical maxillary excess. How many gummy smile patients would want to get a leaf-1 osteotomy or a bi-jaw surgery or setback combination for a gummy smile? Very few. In total, I have been able to convince, after the use of regular toxin, because it acts like an aesthetic tool, only 8 patients. But we see it on a regular basis. So toxin tends to be a very good tool, a cosmetic tool, because the patients can actually get motivated for a permanent fix. This point is known as the Yancey's point, where we inject the toxin 5 units each bilaterally, and you will see that the elevators of the upper lip, which is zygomaticus major, levator levae superioris, and the elytra, which are the elevators of the upper lip, tend to relax, not more than 5 units. This case taught me a lot, because I did this case 11 years back, and I overdid it. I did 2 sittings of 5 units each bilaterally. If you see, the patient was happy, but only said just one simple thing when she came back. Doc, whenever I am trying to eat golgappas, they fall out. So I initially thought she was trying to, just crack a witty joke or something. But she was serious. And she was I told her to pout. So the pouting capabilities were also a little less. Secondly, the golgappas were important. So thirdly, I realized that I over-relaxed the muscle. I gave 10 units bilaterally. So there was no tonicity of the muscles. So looking at this, I made this article and I researched about it. And this is the largest PubMed index study for the same in the world. We studied this for about 21 months, and we realized that the effect of the toxin, repeatedly injected, can help in neuromuscular shape memory, and some amount of neuromuscular shape retention stays there even if you're not injecting toxin after the 3rd dose, which is about 25%. There can be some other corrections also which you can do, which are very simple. Simple mucogingival procedure, but these are case selective and the results are permanent. Now we can use it for hyperhidrosis and a lot of other things. For neuralgia, for trigger points, we have been using Botox extraordinarily, but primarily the cause is a different cause. We're just helping with the relief of the patient. TMDs, the areas that we inject are the masseter temporalis and sometimes the lateral pterygoid as well. If you're doing a lateral pterygoid, we usually do a CT guided shot or an ultrasound guided shot, but that's how you inject about 80 units per session. All these muscles as well, we tend to inject when we're talking about atypical facial pain. Yes, coming on to dermal fillers. Now, I want to rush through a little. You can use any, but it all depends on the concentration of the HA, how many ml that you're using. There are multiple different brands available. Now, the synthesis is primarily sodium hyaluronate. It's not available in the normal form, so we have to synthesize it. Our body is made up of 55% polysaccharide or HA. So it's not something which we are not used to. The only problem is you should know that what phases the fillers are available, what is the viscosity, what fillers will work for what indication. Now, two terminologies that you will want to understand with the fillers are G prime and the extrusion force. They need to be inversely proportional. Okay. Techniques, we follow all these techniques apart from cross-hatching. Cross-hatching is obsolete, but the commonest technique that we follow for injecting of fillers is retrograde linear thread. The same technique we also use when we do fat grafting. Plane of filler placement is very important. You can't put a filler too superficial. Here what we do is, the most important landmark on the entire face when you're talking about aesthetics is the facial artery. And most of our fellows who come and train with us, this dissection is done by them. And we tell them to trace the vessels, follow it. The most important thing is knowing what not to do. And when the younger generation who is wanting to make a career out of it trains well, they are able to deliver results to the patients. These kind of dissections are all done. That's how we learn. So that's how we train them as well. Now, if you see this lady, can you tell me how old she is? Just a wild guess. We don't have too much of time. Here. Anyone? Sorry? 40? Anyone else? Come on. 50s? Early 50s? Okay. Now, I injected some filler for her. Okay, I'll tell you the age after the story. What is this black area that you see? This is vascular occlusion, when the filler enters the vessel. And this came up in 4 hours. If it comes up in 4 to 6 hours, that means there is a venous vascular occlusion. If it happens immediately, it's an arterial occlusion. Okay, and it's painful. So immediately you need to inject some Hyalase and you have an antidote for fillers. So there's nothing to worry about. Now, the results are after I overcame these complications. Her age is 72. Okay? She's 72 years old. So yeah. Males, a lot of young males come in for mid-face rejuvenation, but you need to understand the concept of building a face. Till the time you don't understand what will look good on what face, you cannot start your aesthetic journey. So males, they have a different journey because for a lady, I would want to do a high cheekbone. Imagine a guy having a high cheekbone. Would it look nice? You look very absurd, right? The guy will have to have a broader, rectangular face, but a chiseled appearance. So you have to understand the concepts there. Same person. If you see the nose to chin angle, it's quite retrographic. Did not got a genioplasty. Eventually got a genioplasty done 5 years later, which is recently. But 3 ml of fillers I had injected to camouflage the nose to chin angle. Temple fillers are very routine. Could we play the video, please? Excuse me. No, this one. Yeah, thank you. You can combine your temple fillers with something known as cork threads to actually go into the muscle and the subacute plane to lift up this entire area and make sure it tightens and stay there. I told you that all the tightening happens from, all the lifting happens from the temples and the midface, and we need to keep it like that. And these are aggressive barb threads. And you can also use mono threads, which are smaller threads, which do not have too much of effect, but localized tightening. You can combine it with some growth factors. These are all also cork threads, but I'm going to rush through it. I'll show you another video instead. Remember this lady, I'll show you her face later. Just 3 ml of fillers, some cork threads done. And she eventually wanted a rhinoplasty. She came back later and got it done as well. Now she's a doctor herself. This is a triple vector lift, non-surgically. I also have a quadrangular lift, and this is my technique registered on my name. And we also do a submental lift. You can actually lateralize the entire face and make the face look younger and tighter. And that's the essence of it. Superior lateralization of the entire face. Same lady, deoxycholic acid and some submental threads. Video please. Now when you're doing a submental vector, mandibular vector, a small entry point from the retromandibular area, but you need to pass through the masseter, the facial artery, but you're in a subacute plane, the artery is deeper, and you reach right till the depressor anguli oris, which is the corner of the mouth, and you want to pull the entire face laterally. What I want you to focus on is, when I engage these aggressive threads, these are like Christmas tree, and they have multiple curvilinear paths around it. It engages the soft tissue, and same thing I can do surgically as well. But the number of patients who want to get surgery done is minimal. Who would want to get surgery done when there is a fix, minimally invasively? Right? When I pull the tissue, the entire tissue lateralizes. And that is what you can achieve with top threads. You can even do that with double-ended threads. This is the face. Can you see this? This is all done minimally invasively, non-surgically. She has a contour there. Fillers for tear troughs. You can also use fillers for different areas. That's how you would want to use a filler or a fat graft for under-eyes. Video, please. This is the technique which is known as retrograde linear thread, but we're using a cannula there to actually make the hollow under-eyes look better. Same thing we do with fat graft also. And it's just a different thing. Some patients like to get fat graft done because of longer duration, it lasts for longer duration. But immediate results is what you will get with the use of dermal fillers or with fat. In fact, we tend to overfill. In fillers, we tend to be precise. Same techniques, it remains the same. Immediate pre and post, you will start seeing the results. Fillers will get instant results. Toxins will give results in about 12 days' time. This is done with a needle. Now, lip fillers are something very important. There are multiple different cases, but you should need to understand what kind of lip fillers will work best for a face. Lips appeal number one with the nose. And if you want to do lip fillers, please don't always listen to the patient. You will have to understand that sharper lips on a rounder face might look better. Rather than a rounder lip on a rounder face, it will make the face look rounder. So definition somewhere is very important. You can do multiple different things. Bring down the color of the lips. You can. This is a cleft lip, so I did a scar revision, surgical, and then combined it with some fillers, eventually some fat, and you can send the patient out with some confidence as well. This is a filler done wrong by someone, where I surgically take out the lumps, because this could have been avoided if the doctor was a little more careful in avoiding these complications. Routine lip reduction surgeries are something that offers a lot of promising results to a lot of males because they come in with a lot of mucosal excess. I won't go into too much of the details, but debulking and closure is a very simple procedure. Buccal fat removal is a small 35-minute job. Video, please. What it does is contours the face in a way that your face will look pleasing, in a way that somebody will notice that your face is looking better. But the aim is not to remove too much of the fat. The aim is to remove probably less than half the buccal fat, because it's a deep fat pattern. You don't want to remove too much of it. Otherwise, there will be a subzygomatic hollowing, which looks very bad. All done in local anesthesia. You don't have to take the patient under GF for a small procedure like this, and shows very promising results. How does it help the patient? I'll show you. There will be changes which you will notice. Okay. Look at this young girl. Look at her face. An oval kind of a face, and combined with a few procedures, her face starts looking sharper. Does it? Does it not? Very simple, straightforward procedures, right? So you have to have that aesthetic eye and that vision to give results, and small procedures can deliver major results, good results. Rhinoplasty is always surgical, but some patients do not want to undergo surgery straight away. So the alternate, which sometimes we have to follow, is the use of rhinoplastic threads or combine it with some fillers. I don't like to use fillers on the nose per se, if you ask me. But yeah, sometimes we have to follow it to give a camouflaging effect or a sharper nose if the patient is not willing for surgery. This lady, again, time being constrained, her main concern was her nose looks the most prominent on her entire face and the face doesn't show any results. So we tried with the use of rhinoplastic threads, but eventually I had to augment her entire face with a lot of fat for her nose and her entire face to make her face look better. So this is micro fat which I'm using, and some amount of, lot of micro fat for the entire face, some augmentation and an alloplasty to make her nose look narrower and the face look better. Can you see the before and after? Natural looking results is what you want to give the patient. Remember this patient? I told you to remember her, right? She came back and she got a rhinoplasty done, and that's how she looks. We augmented her entire face. We did a rhinoplasty, we did some fat graft, and eventually you have to focus on the mid face to make the face look better. So coming on to a little more different things like, male facelifts are going to be different than a female facelift because the vectors are different, the correction vectors are different. If you talk about this lady, can this be treated non-surgically? No. You can't, have a different perspective, and we are here to do justice to the patient because the patients have faith in us. Look at what we did for her. And if you can see the preauricular area, you can see the vectors for the surgical face and neck lift with the tracheal application and a submental liposuction. You look at her, that is who she was before, and that is who she became after the surgical procedure. Another one. So the multiple different procedures, submental lipo, fat grafting, mid-face grafting. These are all videos. I don't want to waste too much time. We don't have too much time. Things like these, the platysmal glands. So this was a beautiful looking Australian lady. We eventually did a face and neck lift for her, SMAS application for her, platysmal application with the SMAS application, mastectomy as well, a lot of fat grafting. That's the video. And that we're preparing micro and nano fat for her. And then after the facelift, I inject the fat graft for her. And it's very important because there's a loss of volume. After you've done the mastectomy and lifted up the entire face, you need to give volume to the right areas. So the time you don't do that, the face will not look nourished and volumized in the right proportions. So you put in a decent amount of fat, we actually overfill because the fat is going to shrink. We keep it to about 20-25% excess. And I want you to take a look at her bands are gone. This is immediate post-op. This is how she looks in a lateral profile. The bands are completely gone. The face looks better. Look at this, right? That's how you can make a difference. Another 62-year-old lady, pretty much the same. Look at the number of procedures we did for her in one session. Face and neck lift, tracheal application, blepharoplasty, lip lift, forehead reduction, genioplasty, facial fat grafting. All done in one session. It's a 5-hour surgery. This is how the facelift looks like. Neck lift. It's a deep plane lift, so we've gone. So that's the forehead reduction, the genioplasty, the blepharoplasty. And on the third post-op day, you see the difference. And she flew off on the 5th day. She's that good. No drains, nothing. So fat grafting offers a lot of solutions, and I think a lot of surgeons should train on it. It offers a world of solutions to males and females for volume loss, more lasting. Look at this 4-week post-op fat grafting. These are pathologies like morphia, so you can offer camouflaging results. Growth factors have offered a lot of promising results. We use a lot of PRF. I have never used PRP in my practice, and PRF is the way forward. And there's a lot more research that you can actually follow of low centrifugation rate. You can combine the use of lasers and growth factors with it. It offers promising results in hair regrowth. Hair transplants are something that need to be combined with growth factors. They are not to be done on their own before and after the procedures. Hair transplants, we usually follow a combination of an FUT, FUE. Okay, I'm just going to rush through it. Taking a lot of time, I think. There's so much to show, that's why I said it's a massive topic. If I start talking about one of them, I can take multiple days and deal with one too. So, we do a lot of transgender facial feminization procedures as well. Hair transplant becomes a major part of it, beard transplants. These are all made of beard, And then there's new devices like the regenerative devices. Look at the difference coming on tray and tag end of it. Every face is different. You want to actually combine multiple different techniques to give results to them. Contour, correct, and reconstruct. Look at this one. Complete different change, right? But you have to have an eye and a vision to actually develop results like these. Okay. Last video, please, and I'll end with this. So, aesthetic can also be done with different other things as well. Can you just play this, please? Excuse me. So this young patient traveled half the world for this one procedure. Look at his face. He's got a fibrous dysplasia which was operated 3 times. Look at his skull. Everything, the cranium was opened up 3 times. And this is how his cranium looked like. I had to shave the entire cranium. He had all the signs and symptoms of actually very aggressive fibrosis present. And once we did that, we recontoured the entire face and looked at the osteotomies that were done to recontour, to make his face look normal, like the frontolateral side. A jawline osteotomy, a chin osteotomy, zygomatic osteotomy, shavings all over, and then grafting also in the right places. So the aim is to actually make his face look better. I just want you to see his before and after. Before he left. These are the osteotomies. This is how he looks post-operative in 14 days time. And he left after that. Does he look better? This is also part of aesthetic and aesthetic surgery. So you have to think out loud, think broad, and have a vision there. And thank you for patient listening.
I would like to invite Dr. Jasmeet Singh Kalra sir on this stage. Thank you, sir. Now I would like to invite Dr. M. Siddharth, sir, for felicitation. Thank you, sir. Now I would like to invite Dr. Athir Rajgopal, sir. Now I would like to invite Dr. Athir Rajgopal, sir, on the stage. Thank you, sir. Thank you, ma'am. The slow 2 lectures will be resumed after convocation and award ceremony. Kindly wait for the arrangements. Academic conference, convocation and awards. Lined up today, we are having knowledgeable lectures by eminent speakers. The first lot of lectures has already been completed. This will be followed by convocation and awards. We welcome our chief guest, Honorable Dr. Cheryl Bradford Billingsley, Ma'am, PFA International President, USA. Guest of honor, Mr. John Billingsley, sir. Dr. Anmol Bagaria, Ma'am, PFA Section Chair, Section 8 Large PFA Asia Region. And Dr. Ashish Chandra, sir, PFA Section Co-Chair, Section 8 Large PFA Asia Region. I request all the dignitaries to grace the dais, please. Thank you, sir. Thank you, ma'am. I kindly request all the dignitaries to come forward for the lighting of the lamp. Thank you, sir. Thank you, ma'am. Following our culture of Atithi Devo Bhavo, we would like to start with the ritual of presenting a bouquet and memento to our chief guest by Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, and Mr. John Billings, sir.
Ma'am? Wait. Wait.
I kindly request dignitaries to felicitate our guest of honor, Mr. John Billings, sir. Thank you, sir. Thank you, ma'am. I would like to invite Dr. Ashish Chandra, sir, to address the gathering and to give insights about PFA.
A very good morning, everyone. A very good morning to one and all present here today. I, Dr. Ashish Chandra, Section Co-Chair of Section at Large Asia Region, I would like to brief you something about the Pavitra Academy. Pavitra Academy is an honorary dental service organization established in 1936 by Dr. Anmol Bagaria, a US dentist. PFA was founded to help dental professionals to prevent its literature from commercial interest. Anmol's passionate concern for knowledge and raising of professional standards laid the groundwork of the academy. PFA has about 11 global regions in which it has 142 sections worldwide. 52 sections are in the USA, 82 sections in the America, Europe, Asia, Africa and Australia. PFA has more than 11,000 of its global fellows. PFA is an affiliate member of FDI and APDF. The academy was named after the Pavitra of France, who is the father of modern dentistry. He wrote a book named Leech Regan Dentistry, OU Trades, Des Dents, the first true textbook of dentistry. Our mission as a fellow of the Pavitra Academy is to recognize and develop outstanding leadership in our profession internationally. The objectives are: the Academy fulfills its objective through meetings of its international sections, annual awards, presentations of the Fawcett Gold Medal, the Trade Fair, Industry Awards and Best Memorial Award, the Student Award of Merit and publications of Dental Abstract and Dental World. The goals of the PFA are to make fellows known throughout the dental world, to have the knowledge and most outstanding fellows, dentists in every country of the world, to select and induct individuals of the high ethical morals and professional standards, to develop service-oriented projects, to orient all PFA levels with uniform workable guidelines, to make PFA a peer-recognized body by virtue of its appreciation awards, fellowship, and its service to dentistry. This is the PFA organogram. This is our PFA International President, Dr. Cheryl Billingsley, ma'am. I welcome you, ma'am. Our immediate past President, Dr. Pankaj Patel, sir. Our Executive Director, Dr. Robert Katoy. And I would also like to welcome Mr. John, hello sir, and Dr. Anmol Bagaria, Madam, the section chair of Section at Large, Asia region. The PFA Fellowship is by invitation nomination to honor accomplishment of dentistry and encourage future productivity. Professional leaders select fellows based on contributions in dental literature, service to the profession, and service to the general community, thereby bringing credits to the dentistry, are among the criteria sought in recruiting new members. As today you all will also be inducted as a fellow, so you can also have the power to nominate new fellows in this academy. We have the PFA Museum. PFA Museum of Dental History was established in year 2000. The museum houses several displays related to dentistry. The museum is located in Nevada, US. This is the PFA Museum. These are the community service programs which were held throughout the country, in which many of the colleges participated, and around 561 camps were organized. Under the PFA section, various colleges across the Asia region have undertaken a remarkable community service initiative, demonstrating their commitment to innovating public health and well-being between September 7, 2024 and November 19, 2024. A total of 581 health camps were organized, providing essential medical and dental care to undeserved population. These camps set up in diverse locations catered to need of more than 48,995 patients, offering treatment, preventive care, and health education. Additionally, an extraordinary feat was achieved with the organization of 1,536 dental camps, which were organized in the duration of 180 days, providing dental treatment, oral cancer screening, comprehensive care to a remarkable 127,177 patients, which were screened in just 180 days. The initiative highlights the collective effort of participating colleges to bridge healthcare gaps and foster community health development on a large scale, showcasing their dedication to improve lives through prevention and curative healthcare services. Now, I would like to invite Dr. Misbah for the induction ceremony.
Thank you so much, sir, for words of wisdom. Now, I would like to invite our guest of honor, Mr. John Sir, to address the gathering.
Well, first off, I'd like to thank our new friends, and Anmol, for those gracious reception we've received. We've been here in town since Monday, and they have treated us like royalty. I mean, we've been to the Taj Mahal and all kind of places, so I want to thank them for their gracious hospitality and making us feel welcome here in India. It's been wonderful. So, I met this beautiful lady, Dr. Cheryl Billingsley. She was a doctor when I met her about 45 and a half years ago. She's an amazing woman. I was out playing tennis one day, and she saw me, and she said I had really nice legs, and we found we had a mutual friend in common. I was glad she said I had nice legs. She didn't work her way up to my face, so she might not have gone out on a date with me. But we had our first date, and on our very first date, she told me she had just been accepted into the dental hygiene program. And little did I know this would be a long journey in dentistry, through dental hygiene, through dental school, being president of the Virginia chapter of the Academy of General Dentistry, working with the HUD, the Virginia Dental Association, and then working her way to PFA, where she is an amazing woman. When you think about PFA, you think about PFA as being a leadership organization in dentistry. And the woman that drove that change for dentistry was Cheryl. That was her brains, that was her idea. But anyway, I didn't want to hear from me. I'm not a dentist. But I'm honored to be here, and thank you again for such a warm reception.
Thank you so much, sir. Now, I would like to invite our chief guest, Dr. Cheryl Bradford Billingsley, ma'am, to address the gathering.
Thank you all for allowing me to be here. I'm very honored. It's my first time to India, and let me just say that. It's my first time to India, and it's been a wonderful experience. Anmol and Ashish have been amazing, taking us around to different places. We were in Bangalore, there was a graduation there. We'll be in Indore tomorrow for a graduation. Your graduation is the largest of all three, and it's definitely an honor to be here. Some of you I can see out there, some I can't. But this is about you. This is about you, the fellows, and to honor you because of what your accomplishments have been. So this first slide, I'm going to go through a little informational PowerPoint here. This is the Pierre Fauchard Academy. This is our headquarters behind them. So if you can see the top of the building. And, okay, you can go to the next. The PFA, of course, represents 11 regions in the world, and we're growing. So our leadership gives back. We've donated over $3.5 million awarded over the years for scholarships, for mission, what you all call camps. So this goes for good causes. And this is some of our leaders working hard around the world. It's one of our trustee board meetings. This is PFA fellow graduations. This is a graduation that was held in Georgia in the United States. This is in Virginia prior to COVID. Of course, during COVID, everything, like you all, shut down, and then we're now bouncing back. Our headquarters in Rockville, this is the Fashard room, and if you look at the back wall there, if you donate $1,936, which I'm not sure how many rupees that would be, your name is put on the back wall. So we're starting to fill that up. And that goes for philanthropic help for others, and also for our leadership courses to help develop the fellows as they go on their way in their journey of being a dentist. We offer dental services for those who need throughout the world. So many times PFA is a sponsor for some of these events. Our publications are Dental World magazine and Dental Abstracts. We also have a newsletter now that goes out to all the fellows. And you all will be in the next Dental World and Dental, well, probably at the end of the Dental Abstracts, but Dental World you will be in, and you'll also be in the newsletter. So thank you for your leadership. Now I have one more thing to go to. So, the mission of Pierre Fashard Academy is to recognize and develop outstanding leadership in our profession internationally. So who is a leader? I'm going to give you a little bit of leadership sort of insight. Okay. A leader helps an elderly person who is struggling. I find in India you all have a better you help elderly people, I think, from a seniority standpoint better than we do in the United States. And I love to see that. That's wonderful. A leader is a dentist who spends extra time with a nervous patient. Every single one of you out there has had a nervous patient sitting in your dental chair. And those extra minutes that you spend with that patient can reap huge benefits for you. Many cases they'll refer every single person in their family and their friends. This is the best way you can build your practice and also help a patient and help them with their struggles of being nervous. A leader offers their first class seat on an airplane to the elderly. This actually happened. This was a military man and he offered his seat to this lady. A leader is a dentist who does not over-treat. I see this in our country quite a bit. I hear about it in other countries. Many times you can do just a restoration. You don't need to do a crown. And I know all of you have had patients that come in and they said, I need a crown, I need several crowns. The dentist diagnosed this on me. And you look at it and you go, there's no way this tooth needs a crown. And so I would do a very good restoration. 25 years later, that patient came back and that restoration looked fine. It looked great. So, they did not need a crown in many cases. Sometimes they do, and in those cases you do go ahead and proceed with the crown. A leader is a person who gives support to a drug addict in recovery. A leader is an addict who seeks help. A leader is a neighbor who buys groceries for those in the community during a crisis, particularly during COVID. A leader is someone who listens before acting. Listening is probably much more important than speaking. And so you need to listen to your patients. You need to spend that extra time. And once again, it's that time. I know we're all on a really strict time. You're watching your watch for that next patient, but spend that little bit of extra time with that patient. And a leader looks at the big picture before making decisions. The big picture's huge. I admire probably most of all people who can look at the big picture. When we get into, and as dentists, we tend to be very detailed. So if we can look at the big picture and stop looking, and like she was speaking just this morning on looking at the whole patient. So it's holistic dentistry. It's looking at everything. When they walk in, many times they would just start telling me they would tell me their symptoms. I could actually diagnose it before I even looked in their mouth because of their symptoms. And so I think we need to start looking at the whole body and everything. A leader respects people from all walks of life. and this is very true. We have a Capital One is in our town. We have many, many Indians in our town, and it's wonderful. And they actually, I can tell you this, they were my favorite patients. They respected me, they thanked me. I loved my Indian patients, so thank you all. So, and this is this is the graduations. This is Philippines. This is our board, and down below is a Virginia continuing education. So my plans for 2024 are to increase the number of fellows in the world, grow the database of courses online and in-person lectures, increase interaction with all fellows and leaders of PFA, encourage volunteer opportunities and philanthropic organizations, become that more of that, and continue to develop our leadership foundation planning and giving. So we have CE. If you all don't know, it's on the website, and it is under the membership tab, and it's free. This is free leadership courses. And some of them, leadership during turbulent times, is we have a part 1 and part 2. Each one has 10 parts. At the end of it, you receive a certificate you can print out, and you can actually put that into your office and frame it. And that gives your patients, they look at that and go, oh, you know, my dentist is, you know, achieving leadership certifications. So it gives them trust in you. This is my wonderful husband hurdling. He's a hurdler and a sprinter. But, and then my son to the side, he started hurdling, and then he became a pitcher for baseball. But dentistry faces many hurdles. However, dentistry remains in the top 10 jobs in the world. My husband competes nationally in track meets, and he's won several gold and silver medals. He's competing in the world championships soon. And my son is doing vaccine research in microbiology, immunology. He was a pharmacist, did not like pharmacy. He's now becoming a researcher, scientist. So when I'm not leading PFA, I'm an impressionistic artist. I love to paint. I want to form a nonprofit when I finish PFA leadership on this level and do art from the heart for seniors, where we donate paintings for seniors that don't have paintings in their nursing homes. A fellow in PFA equals a better leader. Thank you very much.
Thank you, ma'am. Please wait for the stage to be cleared. Invite Dr. Cheryl Bradford, Gray ma'am, Mr. John sir, Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir on the stage. The fellows will be recognized on the stage one by one. Dr. Anaida Acharya, Dr. A. Siddharth Verma, Dr. Arthi Muswati, Dr. Ashish Handa,
सभी सामने सभी सामने देखिए वेट ठीक
Dr. Ashish Handa. Dr. Abhijit Mumne.
देखिएगा सभी सामने थोड़ा सा आगे आ जाइए बस आप भी चल देखिए यही
Dr. Abhijit Mumne. Dr. Abhinaya S.
देखिएगा सभी सामने देखिए वही ठीक
Dr. Abhinaya S. Dr. Aditi Nanda.
कैमरा उधर घुमा देखिएगा सभी सामने देखिए वही ठीक
Dr. Aditi Nanda. Dr. Aditya Kapoor. Dr. Ahmad Shoaib Hashmi. Dr. Aishwarya Verma.
वही या
Dr. Aishwarya Verma. Dr. Ambrish Maniar.
but my center is ready wait ma'am सामने ma'am
Dr. Ambrish Maniar. Dr. Amish Bansal. Dr. Amish Bansal, Dr. Amit Kumar,
Ma'am. Wait. Yeah.
Dr. Amit Gupta, Dr. Amrutha D. Shinoy, I request everybody please stay back for the group photograph.
Wait. Ma'am.
The group photograph will be posted on official website.
Yes, Amit. Ready? Wait.
Dr. Amrutha D. Shinoy, Dr. Anamika Shri Krishna, Dr. Anamika Shri Krishna, Dr. Anil K. Shiron,
Wait. Yeah, thank you.
Dr. Anil K. Shiron, Dr. Anirudh Rehani,
Wait.
Dr. Anirudh Rehani, Dr. Anirudh Sharma,
Wait. Yeah.
Dr. Anish Raj Gurvarti, Dr. Anirudh Sharma, Dr. Anjum Patan, Anjum Patam, Dr. Anshul Fogart, Dr. Anuj Shankar Tiwari, Dr. Anuj Shankar Tiwari, Dr. Arya S. Prasad, Dr. Arya S. Prasad, Dr. Asjad Nizar, Dr. Asjad Nizar, Dr. Ashwini Y, Dr. Ashwini Y, Dr. Athari Rajagopal,
देखिए
Dr. Atreya Rajagopal, Dr. Bhaskar Saini,
सर सर भाई या
Dr. Bhaskar Saini, Dr. Cheti Sarkar, Dr. Cheti Sarkar,
फुल लेना एक बार बीच में गैप मिलेगा हॉल की वीडियो फोटो ले लेना रूम के पीछे सर
Dr. Cheti Sarkar, Dr. Chandana Sudalla, Dr. Dhruv Ahuja, Dr. Dhruv Ahuja, Dr. Dhwani Desai, Dr. Disha Gupta, Dr. Disha Gupta, Dr. Divya Kahiliani, Dr. Gitika Arora, Dr. Gitika Arora, Dr. Ibrahim Fazal, Dr. Indrajit Padukone, Dr. Isha Singh, Dr. Isha Singh, Dr. Jasdeep Kaur, Dr. Jatinder Pal Singh Chawla,
Ready? Follow.
Dr. Jatinder Pal Singh Chawla, Dr. Jaya Krishnan, Dr. Jaya Krishnan, Dr. JCP, Dr. Jitesh S, Dr. Justina Joy, Dr. Justina Joy, Dr. Karan Manak, Dr. Karan Manak, Dr. Kirupa Shankar R, Dr. Kirupa Shankar R. Dr. Kopal Singh. Dr. Kopal Singh, Dr. Kaushika Tandon Sinha, Dr. Kriti Pallavi, Dr. Kaushika Tandon, Dr. Kriti Pallavi, Dr. Shitiza Patil, Dr. Kumar Amit, Dr. Kumar Amit, Dr. Lakshmi Girish, Dr. Lakshmi Girish, Dr. Lishoy William, Dr. Lishoy William, Dr. Lovely M, Dr. Mahajan Mandar Manish, Dr. Mahajan Mandar Manish, Dr. Manish Bhargava. Dr. Manish Bhargava. Dr. Manisha Verma. Dr. Manisha Verma. Dr. Margi Sojitra. Dr. Minu Anna Emanuel. Dr. Mithun J. Dr. Mohammad Tharwad. Dr. Mohammad Hanif. Dr. Monica Tandon. Dr. Murmun Datta. Dr. Murmun Datta. Dr. Muzammil Moin Ahmad. Dr. Nagendra Kumar. Dr. Nagendra Kumar. Dr. Nandini Dabas. Dr. Nandini Dabas. Dr. Neelam Suman, Dr. Neeraj Agrawal, Dr. Neeraj Agrawal, Dr. Neha, Dr. Neha, Dr. Neha Jain, Dr. Neha Jain, Dr. Neha Saini, Dr. Neha Saini, Dr. Nishant Khurana, Dr. Nishant Khurana, Dr. Nithya, Dr. Nithya, Dr. Omar Mukhtar, Dr. Omar Mukhtar, Dr. Parthivi Sharma, Dr. Parthivi Sharma, Dr. Pavitra H. Dave, Dr. Parthivi Sharma, Dr. Parthivi Sharma, Dr. Pavitra H. Dave, Dr. Pawan Yadav, Dr. Pawan Yadav, Dr. Pavan Rebello, Dr. Pavan Yadav, Dr. Pavan Robelo, Dr. Poonam Goyal. Dr. Poonam Goyal. Dr. Preet Jain.
Ma'am.
Dr. Preeti Priyadarshi. Dr. Preet Jain. Dr. Preeti Priyadarshi. Dr. Rahul P. Dr. Rajkumar Manoharan. Dr. Rajkumar Manoharan. Dr. Richa Angi. Dr. Richa Angi. Dr. Ruby Gupta. Dr. Ruby Gupta. Dr. Rupesh Gupta. Dr. Sachin Chauhan. Dr. Samir Gupta. Dr. Samir Gupta. Dr. Sana Khan. Dr. Sana Khan. Dr. Sanup George. Dr. Sanup George. Dr. Satyavani. Dr. Satyavani. Dr. Saurabh Juneja. Dr. Saurabh Juneja, Dr. Saurabh Juneja, Dr. Shashikaran, Dr. Sean Uppal, Dr. Sean Uppal, Dr. Shikha Gupta, Dr. Shikha Gupta, Dr. Shilpi Chawla, Dr. Shilpi Srivastava, Dr. Shilpi Chawla, Dr. Shilpa Chawla, Dr. Shilpi Srivastava, Dr. Sheenu Salim, Dr. Shruti Rajagopal, Dr. Shruti Rajagopal, Dr. Subhabrita, Dr. Shubhabrita, Dr. Sumati S, Dr. Sunil Kumar, Dr. Sunil Kumar, Dr. Sushant Sundar Shetty, Dr. Tarun Kumar Singh, Dr. Tarun Kumar Singh,
Ignore, ma'am.
Dr. Sushant Sundar Shetty, Dr. Tarun Kumar Singh, Dr. Tejas Kadam, Dr. Tejas Kadam, Dr. V. Ranjit Akshay, Dr. V. Ranjit Akshay, Dr. Vaibhav Gulati, Dr. Vaibhav Gulati, Dr. Vikender Singh, Dr. Vaibhav Gulati, Dr. Vikender Singh, Dr. Vinit Vinay, Dr. Vinit Vinay, Dr. Vyom Akshay Rathi, Dr. Vyom Akshay Rathi, Dr. Vyom Akshay Rathi, and Dr. Ramakrishna Shinoy. Dr. Ramakrishna Shinoy, congratulations to all the PFA fellows. I would like to invite Dr. Cheryl Billingsley ma'am for oath.
Could you all stand, please? All the fellows. Fellowship in the Pierre Fauchard Academy is a distinct honor bestowed upon you by your colleagues because of your specific accomplishments. Your ethical leadership principles and abilities speak to your future commitment to dentistry and society and the lives it will make better. in order that each of you approaches this fellowship with a keen sense of the privilege of association with previous honored colleagues, I ask that you publicly ascribe to the following pledge. So, and I'll read it. Recognizing that the Pierre Fauchard Academy exemplifies and supports the highest levels of dental professionalism and leadership around the world, I hereby pledge to continue to grow in leadership and service to the profession of dentistry, my community, and to society. And please say, I will. I will. Congratulations to every one of you, and I know you're all going to be very successful. Thank you.
I would like to invite Dr. Nitya. Everyone please be seated. I request all the fellow, please kindly stay. I request all the fellow, please stay back for the group photographs. Now it's time for award ceremony. First of all, I would like to congratulate all the awardees for being selected for the most prestigious award. Before announcing them, I request all the college awardees to share few insights about their academic excellence, community services and scientific research after receiving the award. For the first category, Best Dental College in Academic Excellence. The award goes to Sharad Pawar Dental College and Hospital from Maharashtra. Sharad Pawar Dental College and Hospital from Maharashtra. She is taking on the behalf of her college. Many congratulations. Second prize goes to Government Dental College and Hospital Nagpur from Maharashtra. Another prize goes to Government Dental College and Hospital Nagpur from Maharashtra.
Sir.
Sir. Sir.
Thank you so much, PF Academy, for this recognition. I am Dr. Pavitra, Dean, Government Dental College and Hospital, Nagpur. This Academic Excellence Award for GDC probably is because we are running the undergraduate research program where we have one mentor, one student concept, and our UGs, other than PhDs, PGs and the fellows, our UGs are also doing the research, and probably that might be the reason. They do patent writing, they do copyrights, and they do publications also. I congratulate the organizers and thank you so much for this opportunity.
Congratulations, sir. From Delhi NCR, the award goes to Maulana Azad Institute of Dental Sciences. From Delhi NCR, Academic Excellence Award goes to Maulana Azad Institute of Dental Sciences.
Thank you so very much for this beautiful award, and thank you to the organizers. Our institute is the best one. I know this because this is there in all the private and the government surveys. This is for the last 10 years. We are number one in India Today, Outlook, and the Week magazine also in NII ranking first dental college in the government institutes. And now this one. Thank you.
Thank you, ma'am. Now I would like to invite Dr. Ashish Chandra, sir.
I want everyone to stand for a moment. In the profound memory of Dr. U.S. Krishna Nayak, sir, we will not make it today. We will keep a minute silence for the soul. Thank you, everyone.
Thank you, sir. From Karnataka, Best Dental College in Academic Excellence, the award goes to A.B. Shetty Memorial Institute of Dental Sciences.
Good afternoon, everyone. I am receiving this award on behalf of my alma mater, A.B. Shetty Dental College. And sir called me last Thursday morning that, Manish, I am unwell, so can you do the honors? Don't go as a dean, but you receive the award on behalf as alumni of the college. But destiny had some other plans. Tuesday evening, we got the news that sir is no more. So this is for you. May your soul rest in peace and keep your blessings always. Thank you so much.
Next award from Puducherry for the Best Dental College in Academic Excellence goes to Mahe Institute of Dental Sciences and Hospital. From Tamil Nadu, award for the Best Dental College in Academic Excellence goes to SRM SIM Kattan Kulathur Dental College. For the next category, award for the best dental college in scientific research of state. From Maharashtra, award for the best dental college in scientific research goes to Ranjit Deshmukh Dental College and Research Center.
Yes, sir. Sir. Wait. Yeah, thank you.
One more from the Maharashtra.
Good afternoon, everyone. I am Dr. Abhay Kulte, representing the Ranjit Deshmukh Dental College as the Dean of the Institute. I dedicate this award to my faculty members, my staff, and the student members, because it is all the hard work they have done around the year. And I also thank PFA for organizing such an innovative program over here. Thank you.
Thank you, sir. From Maharashtra, award for the best dental college in scientific research of the state goes to School of Dental Sciences, Krishna Vishwavidyapit.
A very good afternoon to the August Assembly and the dignitaries on the days. I am receiving this award on behalf of my Dean, Dr. Shashikaran ND sir. So we, School of Dental Sciences, coming from a small rural setup, without the constant support of our management, our Honorable Chancellor, Dr. Suresh Bhosle sir, and our constant encouragement from the Dean, all UGs, PGs and staff have put their tremendous efforts in generating enough of scientific content, let it be in terms of copyrights, patents or publications. So it's very a proud moment to receive it from the hands of such luminous dignitaries on the stage. And I really thank the Peri Flowchart Academy for recognizing our efforts. Thank you.
Thank you so much, sir. From Karnataka, award for the best dental college in scientific research of the state goes to Dayananda Sagar College of Dental Sciences. Award for the best dental college in scientific research of the state, Puducherry, goes to Mahatma Gandhi Postgraduate Institute of Dental Sciences.
Good afternoon, everyone. I am Dr. S.P.K. Kennedy Babu, Dean at Government Dental College of Pondicherry. I first of all thank the PF Academy for considering and encouraging the government sector also. And we are a 30-year-old college. All the credit goes to my faculty members and my dear students who has done all the works. Thank you.
Thank you so much, sir. Award for the best dental college in scientific research of the state Haryana goes to Manav Rachna Dental College.
Everyone, I would like to thank Perifujal Academy for this prestigious award, and I would like to thank the faculty, the undergraduate students, the postgraduate students, and the PhD scholars who have made us stand here. Thank you.
Thank you, ma'am. Award for the Best Dental College in Scientific Research of the State Andhra Pradesh goes to Vishnu Dental College.
Good afternoon, everyone. I am Dr. Sudhakar Reddy from Vishnu Dental College. I am the Vice Principal. And our college is also located in the very rural area. And past 3 years we were getting the NIRF rank and even Outlook today, everything. And it is dedicated to all our faculty, students, postgraduate students, PhD scholars, and at the same time our visionary management. Actually, we have a good service to the community. We have a lot of satellite clinics. We have around 44 satellite clinics around Andhra Pradesh and Telangana, Karnataka. Thank you very much.
Thank you, sir. Award for the Best Dental College in Scientific Research of the State Tamil Nadu goes to Adi Parasakti Dental College and Hospital.
Good afternoon, everyone. I am Dr. Mahesh Kumar. I am representing Adi Parasakti Dental College as a principal. So at the outset, I would like to thank Perifujal Academy Asia region for recognizing our contribution to the field of scientific research, and we are duly humbled and motivated by this award. So all the credit goes to our visionary management, especially our correspondent Dr. T. Ramesh sir, my faculty members, my students, and all those people who motivated us. So thank you so much for this award.
Thank you, sir. Award for the Best Dental College in Scientific Research of the State Uttarakhand goes to Seema Dental College and Hospital.
Good afternoon, one and all. I am myself Dr. Narayan Prasad from Cynodent College. This credit goes to my students, undergraduates, postgraduates, and my faculty. And I thank Perifujal Academy for recognizing this.
Thank you so much, sir. Award for the Best Dental College in Community Service of the State. Award for the Best Dental College in Community Service from the Uttar Pradesh goes to Sri Banke Bihari Dental College and Research Center. For doing highest number of camps in India and screening 8,000 plus patients. It's a wonderful record by Sri Banke Bihari Dental College and Research Center, Uttar Pradesh.
Good afternoon, one and all. I am Dr. Sunanda Roy Chaudhary, the principal of Sri Banke Bihari Dental College. I am deeply honored and grateful to PFA for giving us this award, for giving us this opportunity, and all the credit goes to the Public Health Department of my institute. Dr. Anubhav is with me. And ma'am, I should say that it was one of the most inspiring speeches that I've heard from the president of PFA. Thank you very much.
Thank you so much, ma'am. Best Dental College in Community Service from Tamil Nadu goes to Tagore Dental College and Hospital. She is receiving award on behalf of her college. Best Dental College in Community Service from the state Telangana goes to Kamineni Institute of Dental Sciences.
Good afternoon, everyone. I am Dr. Mahesh. I am the Dean of Convocation Institute of Dental Sciences, Telangana, here Hyderabad. Actually, my college is located in a very, very rural place, and everyone knows it's very close to Nalgonda, where fluoride is very, very high in the entire India. So we conduct the camps on a regular basis, and we do most of the things free in the college, and the credit goes to my department, community department. Dr. Nitya, Dr. Radhika, and all the team of interns. And most importantly, we have a very good plan of we have more than 20 villages adopted, which we regularly do the camps. This is the reason why we could achieve this one. Thank you so much. Thank you, PFA. Thank you, the organizers.
Thank you, sir. Award for the Best Dental College in Community Services from the state Andhra Pradesh goes to Anil Nilokonda Institute of Dental Sciences. Award for the Best Dental College in Community Services from State Karnataka goes to Bapuji Dental College and Hospital.
Good afternoon, everybody. I am
Dr. Ashok, Professor and Head of Oral Medicine and Radiology and Vice Principal from Bapuji Dental College and Hospital. I would like to congratulate all the other award winners who are assembled here. Then I would like to dedicate this award to my management and my staff members and the students who have helped us in getting this award. Today I am here because of their hard work. So I would like to dedicate this award to them. I would like to congratulate the PF Academy for having conducted this particular convention to award all those people who work hard for the betterment of dentistry. And my sincere thanks to Madam and then Dr. Ashish Chandra, Madam, for considering our work for these community services. So keep the good work going. All the best to all everybody. Thank you.
Thank you so much, sir. Best Dental College in Community Services from the state Maharashtra goes to Nair Hospital Dental College.
Good afternoon, everybody. Believe me, I'm deeply honored to have this award for my own alma mater, Nair Hospital Dental College. Nair Hospital. So, this award means a lot to us, and it is because of my dedicated staff and my students. We do a lot of community service. We have a footfall of nearly 1,200 patients every day. We go to multiple satellite centers, and our mobile van goes to prisons, goes to red light areas, goes to orphanages, goes to the school of the blind and the old age homes. So madam, thank you so much for recognizing this for us. I thank Pierre Foucault Academy USA for giving us this. I thank the organizers of this academy. You're doing a wonderful job. By giving us this, you give us incentive and a motivation to work harder. Thank you, Dr. Cheryl, Mr. John, Avinash, and Madam for this. Thank you so much.
Thank you, ma'am. Award for the Best Dental College in Community Services from State Maharashtra goes to Singer Dental College and Hospital.
Best Dental College for scientific research in the state of Madhya Pradesh goes to People Dental College.
I thank PFA and the organizers for the innovation or contribution for the research activity, and Dr. Shiv Kumar GC and Professor Anmol Bagaria from People's Dental College and Hospital, Bhopal. I'm so happy to stand in front of this gathering. We have got more than 150 publications in this year of 2024. We got around 10 patents, 10 copyrights, and one ICMR grant also. And we got around 10 to 15 chapters in the textbooks of different subjects. and it is all dedication from the faculty, students of our college, and the management, and they have given a lot of support in writing the manuscript, preparing, and the amount of research we conduct from the PG students to UG students. Since we got more publications in the international journals like BMC Oral Health and Clinical Oral Investigations, Technology in the Healthcare, and all human journals, we have got publication. And in fact, I'm so happy today that my guide, my teacher, Dr. Ashok sir also has come here. And thank you, sir. And thank you once again. Thank you so much.
Once again, congratulate to all the college awardees. Before starting Student Merit Award, I would like to congratulate all Student Merit awardees. Award for the Best Undergraduate Student of the State. Student Merit Award, Best Undergraduate Student of Telangana goes to Dr. Adarsha Narayana. Best Undergraduate Student of State Rajasthan goes to Dr. Misbah Kadri. I would like to call Dr. Preet Jain on the stage, Principal R.R. Dental College.
Ashish.
Best Undergraduate Student from the state of Tamil Nadu, Dr. Akila KL. Next, Best Undergraduate Student of the state Karnataka, Dr. Ista F. Best Undergraduate Student of Karnataka, Dr. Sagar C.A. Next, the Best Undergraduate Student of State of Karnataka, Dr. Akansha Kolipara. Best Undergraduate Student of the State Maharashtra, Dr. Nisha Yadav. Best Undergraduate Student of the State Maharashtra, Dr. Shivani Patna. Best undergraduate student from the state Andhra Pradesh, Dr. Yashashvi. Best undergraduate student from the state of Haryana, Dr. Riya Solanki. Best undergraduate student of the state of Haryana, Dr. Vidushi Agarwal. Best undergraduate student of the state Haryana, Dr. Nandini Gupta.
Now award for the best postgraduate student of the state. Dr. Shruti J. from Department of Orthodontics from Tamil Nadu. Best postgraduate student of the state, Karnataka, from Department of Periodontics goes to Dr. Mehrotra. Dr. Mehrotra Dipshikha Vishal. Best postgraduate student of the state, Karnataka, goes to Dr. Femi Maria Beni from Department of Prosthodontics. Best postgraduate student of the state, Maharashtra, from Department of Periodontics goes to Dr. Ranu Oza. Best postgraduate student of the state, Maharashtra, from Department of Periodontics goes to Dr. Avani Ramesh. Award for the best postgraduate student of the state, Haryana, from Department of Prosthodontics goes to Dr. Shubhani Singh. Best postgraduate student of the state, Haryana, goes to Dr. Janvi Kalra. from Department of Prosthodontics. Best postgraduate student of the state Haryana from Department of Endodontics goes to Dr. T. Sai Vakul. Best postgraduate student of the state Haryana goes to Dr. Twinkle Chawla from Department of Periodontics. Best postgraduate student of the state Haryana from Department Periodontics goes to Dr. Lakshmi Chandrakiran. Dr. Lakshmi Chandrakiran. Best postgraduate student of the state Haryana from Department of Orthodontics goes to Dr. Sanjana Mathur. Time for Student Appreciation Award. Appreciation Award for the voluntary service goes to Shubham Bharti. For token of gratitude, as Executive Committee Member, Section at Large Asia Region, goes to Dr. Athare Rajgopal sir. I request all the fellows please stay back for the group photographs. I would like to invite Dr. Anmol Bagaria ma'am for vote of thanks.
Very good afternoon and warm greetings to one and all present here. I once again welcome you all to the PFA Conference, Convocation and Awards 2024. Firstly, I would like to thank God for blessing all of us with His choicest blessings. I would extend my heartfelt gratitude to all the dignitaries who have graced the occasion today. Respected Chief Guest, Dr. Sheryl Ma'am, PFA International President. Thank you, ma'am, for gracing the occasion with your presence and your constant support in making this event a grand success. Respected guest of honor, John sir, Dr. Ashish, PFA Section Co-Chair, Asia Region. I would also like to thank all our dignitaries of the dais, respected guests, deans, faculty members. I wish to extend my sincere thanks to the entire organizing committee, especially immediate past President Dr. Pankaj Patel sir, Dr. Merina, Dr. Arvind, and Mr. Robert Katoy, Executive Director, PFA Headquarters. I would like to thank all the keynote speakers who have enhanced knowledge and skills of all our delegates. A big thank you to all my dear delegates and students who have trusted us and joined us today. Sorry if I've missed any names, but I'm highly thankful to each one of you. I would end my notes by saying a famous saying by Dr. APJ Abdul Kalam. All birds find shelter during a rain, but eagle avoids rain by flying about in clouds. So problems are common, but attitude makes the difference. Thank you once again for being there with us and giving us a valuable time and support. Wishing you a happy day and happy conference ahead. Thank you. I kindly request everyone, please stand up on your seat for national anthem.
शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे, जय हे, जय हे, जय 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 जय।
I request all the fellows please come up from the stage for the group photograph, and rest can proceed for the lunch.
एक फोटो ना खाने की भी वीडियो ले लेना।
आप उधर ठीक है, सभी सामने ही है। सभी सामने देखेंगे। वेट।
मेन बात तो यही है मिशन।
I kindly request all the college awardees in all the categories, academic excellence, scientific research and community service, please come forward for the group photograph.
देखिए सामने देखिए। आप इधर आ जाइए, आप थोड़ा पीछे ले लो इधर यार।
I'll be talking about art of predictable composite restoration, and I'll give you the basics, and it will be continued by Nikhil Vaugana in the later part. So in today's practice, can I have a hand mic please? Oh, okay. Since I see only youngsters sitting here, at least they are interested. Do you know what are the challenges in dentistry today? So I'll be addressing only to you guys, and I'll make sure that you learn something and go back. So today patients are aware. I'm sure you are also from Google generation. You know, I'll give you a small example. I went to take exam to a college, and I asked them a question in Viva. What are the post-operative instructions given after amalgam restoration? So 50 students, I asked same question. None of them answered. I asked them, what's wrong with you? You didn't ask anybody, any of your teachers. They said it is not there in the Google. So nobody asked a question which is being asked by everybody to their teachers. They only asked it from Google. So today's patient ask their problems to Google, and then they come back to you that this is my problem and this is the solution. So you have to be really on your toes when you are deciding about a treatment plan. You should not be caught, unaware about certain treatment plans. So keep yourself updated if you want to succeed in dentistry today. And you also have to be cost effective. Competition is increasing. So either you generate more money, plus you are cost effective. That's how you will succeed. Also, the newer materials are not unlike amalgam. They are very technique sensitive. Okay, so you have to read about that material which you are planning to use. And nothing is permanent except change. You have to keep on updating yourself if you want to succeed in dentistry. I always give tribute to these two great gentlemen, Dr. G.V. Black, who brought amalgam to operative dentistry, and Michael Pinocchio, who brought adhesion into dentistry. So what is the restoration? Restoration कोई भी हो, amalgam हो, composite हो, gold हो, aim यही है, एक ही. It has to act like a natural tooth. Sometimes you are in dilemma. कौन सा path लें? Which restoration is good? Mild and temporaries still use amalgam. Okay, they are still using amalgam, and very effectively. I also use sometimes. The dilemma is whether we go for old school of thought, that is resistance and retention, or we go for preservation. Amalgam has been there with us almost 120 years now. Fantastic results, no doubt about that. It's like a wife. It gets old, but it will always be faithful, And it is also a material which is used, practically the most, and also abused practically the most. Is it time to say goodbye to amalgam? What do you think? Yes or no? Yes. Am I against amalgam? Absolutely not. But there are certain reasons. There are certain reasons which I feel it is time for you to jump from amalgam to composites. Now you see a clinical scenario. There are 5 small carious lesions. If you want to do amalgam, you will have to make a class 1, correct? This is how a class 1 looks. Now the problem with amalgam is, it will last for 10 years, 12 years, 13 years. So if I do class 1 for this lady here, at this age, by the time she's 60, I must have done it another 4 or 5 times. and every time I remove amalgam, I'll remove some more of tooth structure. Whereas if I do a composites, I'll make small cavities and fill it up with composite. Even if it lasts for 10 years, by the time she's 60, I may reach a stage of a classical. Okay. So you are preserving a lot of amount of tooth structure by doing composites. Plus certain areas where amalgam doesn't stay, but composites will bond. Like it's a tooth colored material, so aesthetically it's better. Since it bonds with the tooth structure, it also reinforces the remaining tooth structure. Another advantage, if amalgam fails in an area, you have to remove the whole amalgam. Whereas if composites fail in a small area, you can repair it. So every time you remove whole amalgam, you cut some more amount of tooth structure. Here you don't have to do that. So welcome to the world of acid etching, bonding and composites. So I'll give you a small brief and some takeaway tips for your practice. So acid etching, we all know 37% phosphoric acid. I'm sure all of you are exposed to composites. Okay. Now I'll give you a small clinical situation. You have done a acid etching and I'm sure you were not using rubber dam. Yes? In case some saliva comes in touch with tooth, what do? If some amount of saliva comes in contact with some area of your etched cavity, what do? You should repeat it. Okay? Most of the people wash it off, but don't do that. So if there is a contamination with saliva or sulcular fluid, this hydroxyapatites absorb these proteins very efficiently. So it cannot be removed by rinsing alone. You are supposed to re-etch. So every time you are etching, please remember after your etchant is washed off, it should not be contaminated, that area. Okay? Now bonding agent, how do you classify it? How many generations? तू तो पुरानी हो गई भाई. कौन सी generation चलने लग गई हैं आजकल तो I don't know. You know, from the time we started, the generations keep on increasing. Just forget about generations now. There are only 4 types. Multi-bottle total edge, which is not used anymore. One bottle total edge, which we still use even today, or self-edge. Self-edge can be 2 bottles or 1. Most of us are using the last one nowadays. Now bonding with enamel is easy. With dentin it is difficult because dentin is a hydrophilic material and composites are hydrophobic. अब problem में क्या है bonding में dentin की? Once you apply the etchant, you wash it off and then what do? Air dry. Are you supposed to air dry? If you air dry it, collagen fibers will collapse. If you leave it wet, bonding agent will not bond with the tooth structure. So you are supposed to leave it moist. Yes? But how dry is dry, how wet is wet, how moist is moist? With my age I can't see. Even with your age you can't see. So if you leave it wet, it is doomed. If you dry it, it is doomed. What do? You don't know. So it's only guesswork. That's the reason now self-etch has solved that problem. You don't have to worry about how wet the surface is or moist or dry because you don't have to wash. Etchant is gone. You just apply the bonding agent, leave it for some time, cure it. So that headache is not there. Because that's a very major problem with dentin bonding agents. In case you are using the 5th generation, that how to leave it, how do you leave it moist, okay? Then comes the composites. There are a lot of things in composites you have to keep in mind. So I'm not going to this problem, the composition and all. Composites are basically 3 things: fillers, your monomer and coupling agent. Okay? So all the composites change, always keep it in mind. whichever composite you take, they will shrink. And shrinkage is the major problem with composite. So I'll tell you how to tackle it. So there is a polymerization happening. Correct? You all understand that? What is polymerization? Why do we have shrinkage with polymerization? Can I have 5 of you here, please? 5 of you, please. 5 volunteers. Are you sorry? It's okay. Let them have an idea for this. So I want you to make a circle, stand apart. एक सर्कल बना लो, दूर होकर खड़े हो। Now you have to hold each other's hand. आप इनका पकड़ो, आप उनका पकड़ो। See, to hold each other's hand, what is polymerization? When monomers make a chain, they make a polymer. And to make a polymer, they have to come closer to each other. That is polymerization shrinkage, which is happening in every composite. Okay, please have a seat. I'll call 2 of you later again. Okay, so understand polymerization shrinkage is happening because from monomers there are polymer chains forming. And when you do it clinically, there are some consideration you have to keep it in mind. Do we give a base below composite? Should we give a base below composite if it is a deep carious lesion? Any idea? करते हो composite? Okay. Do we give a base? If there is a deep cavity, okay. You don't give a base. It does not require any base. Okay. But if you want to reduce the quantity of composite you are using, you can use either resin modified glass ionomer. Okay. So you basically don't need any base. If you want, you can use resin modified glass ionomer or light cured glass ionomer. Don't use the normal glass ionomer. You know why? They won't.
They don't bond with the composite.
They do. The problem is their setting time is 24 hours. But आप क्या करोगे? Set हुआ और छट एचेंट लगाया उसके ऊपर. It will crumble.
Resin modified and conventional glass ionomer.
Resin modified, at least the superficial layer is cured. Now water is not going inside. Okay? And when you place it, it is not amalgam. So don't use it as tooth-colored silver amalgam material. Some people try to, place it, push it inside, fill it up. It has to be adapted, sculpted to the cavity walls. How do you do shade selection? Shade selection कैसे करते हैं composite की? Beta shade guide? Yes. Spectrophotometer है तेरे पास? College में. Clinic में नहीं होता किसी को. So people use beta shade guide. But please mind you, you will also agree with me, beta shade guide is for ceramics, not for composites. So you will not have a good match with the tooth structure. So test is, you take 2-3 approximate shades. Before the tooth is dry, you put it on the tooth and see which merges well. That's the easiest way. Isolation is very important. So we recommend rubber dam for all the cases, but I feel that quality of isolation is more important than how you achieve it. So even if you don't have rubber dam, it is okay, but isolate it well with the help of your cotton rolls. Now we understand post-polymerization shrinkage was there. Yes, it is there in all the composites. Some have more, some have less. We also understand C factor, yes? Number of bound surfaces by unbound surfaces. So class 1 is actually the most difficult to do. Higher the C factor, the chances of composites failing are higher. So what is the clinical relevance? What does polymerization shrinkage do? दांत के साथ कर क्या रही है वो? Can I have two of you? See, imagine I'm a two structure. I'm a cavity. Okay. This is the buccal wall. This is the lingual wall. We also have a mesial and distal. I am the composite. Now, when composite is placed, I'm supposed to bond with all the sides, right? Just hold my hand. When composite is cured, it shrinks. It is shrinking. So what is it doing? I'm pulling them. अगर polymerization shrinkage ज़्यादा है, so what can happen? I can leave this hand, or this wall is separated, so I get a white line. Or I can break her hand, means some part of two structure is broken and come with me. Or my hand is broken, some part of composite is broken and gone there. So this is what polymerization shrinkage does to a two structure. Please, thank you so much. So how do you tackle that? Simple ways. So this is what is happening. Okay. If the polymerization shrinkage is high, if you do a bulk placement, I'm not talking about bulk composite anymore. So there can be gap formation or there can be fracture lines. How do we manage it? The easiest way is layering technique. You use small layers. Okay. So I'll show you, once you are done with the bonding agent, you cure it and then you place 2 mm incremental layers. But if you see, I have placed the increment like this, not flat. Why? You should always have oblique layers. Now what is happening, if I place it like this, my bonded surfaces are 1, 2 and 3. So my C factor is high. Now by oblique layering, I have reduced the C factor. It is now only 2 bonded surfaces. So the chances of polymerization shrinkage affecting my tooth is lesser. So this is how you place oblique layering and complete your restoration. So some clinical cases I'll run through fast because the last part is more important. So some key points. Always remember composites are sticky materials. So don't use your normal plastic filling instruments. Okay. They will stick to it. Every time you place and remove your instrument, it creates a gap between the tooth and the composite material. Always invest on a good kit of hand instruments for composites. And I've seen some people have this habit that they use plastic instrument and it should not stick with composite, so every time they dip it in bonding agent. Please don't do that. Increment should not be more than 2 mm. Okay? Always in oblique shape. And when something goes wrong, whom do we blame? आपने एक composite किया patient ने, वो अगले दिन pain लेके आया, तो आप किसको blame करते हो? Composite को आपकी गलती थोड़ी है. It's not your mistake, right? Yes or no? We all do that. Okay? But it is time to confess that it is your own hand, how you have placed the composite, which is making it succeed or fail. So some take-home messages. Understand all composites shrink. So placement technique is more important than choice of material. You can buy material of any company. They come with good R&D, but make sure before you start using it, read the manual which is given along with the material. In India, we have a habit of keeping our composite in refrigerator. Yes or no? Cold composites cure less efficiently. So if you have a patient, please take out the composite kit at least 1 hour before the procedure so that it comes from the room temperature. Check the intensity of your light. Check it regularly. If it is not efficient, please replace it and change it. The ideal distance between light and composite material is 1 mm. I have seen some of my interns, I saw one intern recently, he was curing it from the side. It will not cure. Okay. The increment should not be more than 1 to 2 millimeters. And please remember, dark shades take more time to cure. So you need to cure it for longer time if you are having a darker shade. Take one mistake, one more common mistake many of the clinicians do. After they finish the composite, they will start polishing. Your curing time is over, but the polymerization is still happening. Okay, if you start polishing it, that's all doomed. So please wait 10 to 15 minutes. That's the time it takes for composite polymerization to complete. Okay, please wait 10 to 15 minutes. Do you know, even the operatory light can cure composite? But that is bad curing, because you need a visible light spectrum. It has also have UV and infrared. But you can't remove it because you need something to work. Only thing you can do is keep it as far as possible. Or if you have a filter, please use it with a Velcro. Another problem. Different clinics will have lights of different sizes. So before you start using it, because once you put the light, everything is blue. You don't know whether you are curing all the areas or not. Keep your curing light and see how many cycles you will need. And if you have a much bigger area, where cavity is small, but you put the etchant, it spreads all over. Okay, that area will get discolored because you are not putting any bonding agent or composite in that. So just apply fluoride gel in case you are over-etched. Another problem we see, we buy a kit, 4 syringes, 1 bonding agent. And once the bonding agent gets over, we go to market and buy another bonding agent, whichever is the cheapest. Go to Exponent and buy one. Don't do that. Buy bonding agent and composites of same company, because they might be using different monomers. Okay? So try and have composites and bonding agents of same company. So always remember, the key to success does not belong to restorative material, but the operator. Thank you so much. I think I am in time, 25 minutes to go, but these are my contact details. In case you have any query, you want to contact me, please do that.
Thank you so much, sir. Next, I would like to invite Dr. Malika Sethi, ma'am. She is a professor at IP Dental College and 6 key opinion at Biodent India Private Limited. So, topic of the lecture is dental lasers. Welcome to you, ma'am. Ma'am is key opinion leader at Biodent India Private Limited. So over to you, ma'am.
Conference, Pavitra Academy, Convocation and Award Ceremony being held in Delhi NCR. At the very outset, I would like to thank the organizers, Dr. Ashish and Dr. Anmol, for giving me this opportunity to be here today on this platform. Well, ladies and gentlemen, I am also fortunate to share the platform with a galaxy of eminent speakers. I am Dr. Malika Sethi Rishi, professor at IP Dental College, key opinion leader, BioLase India Private Limited, certified tobacco cessation specialist. Well, I also offer fellowship in laser dentistry, faculty associated with the London Academy of Dentistry. Recently, we started with offering fellowship in sports dentistry, which is affiliated to the Indian Academy of Sports Dentistry in collaboration with IDA, and now which has gained international affiliation, that is European Association of Sports Dentistry. To begin with, we all know we are moving from steel age to laser age, And today I will be deliberating on the topic which is very, very close to my heart, photobiomodulation, an invaluable tool in dentistry. Well, we all know what is laser, light amplification by stimulated emission of radiation. It is one of the most captivating technologies which has revolutionized several areas of treatment in the last few decades. So when laser strikes the tissue, it can either be reflected, absorbed, scattered or transmitted. As far as the absorption curves of different dental compounds by various wavelengths is concerned, you can appreciate here the shorter wavelengths are readily absorbed in pigmented tissue and the blood elements. The longer wavelengths, like the erbium family, they are more interactive with, anybody? They are more interactive with water and hydroxyapatite. That is how, if I broadly classify lasers, soft tissue and hard tissue. Soft tissue lasers will act more on the gums, gingiva, because melanin is there. Hard tissue will act on the tooth because we have hydroxyapatite and water, which is more in the hard tissue. Now, as far as the relative depth of penetration is concerned, the longer wavelengths, that is the erbium family, they have surface absorption, that is, they penetrate to a depth of 0.01 millimeters, whereas the diodes are said to be deeply penetrated. They penetrate to a depth of more than 100 millimeters. Now let us have an interactive session. I don't want all of you to doze off. If I ask you, you have a diode which is a 940 and an 8110. Which has a deeper penetration? Anybody? Correct. 810. So, wavelength is inversely proportional to your penetration depth. Rightly said, 8110 has a deeper penetration as compared to a 940 or a 980 nanometer laser. So, if I talk about surgical lasers or class 4 lasers, lasers are meant to cut a blade, reshape and oral soft tissues with minimal bleeding. No suturing is required, minimal anesthesia. You just need to put a topical. You need not give an injectable anesthesia. There is less wound contraction, minimal scarring, allows for greater patient comfort and safety as compared to your normal electrosurgery. There is less pulpal pain as well. Well, I'll show you a few cases as far as surgical lasers is concerned. The topic of my presentation today is photobiomodulation, that is soft lasers, cold lasers, but just to differentiate between a class 4 and a class 3, I'll just show you 3 cases out here. A case of frenectomy, you can appreciate papillary attachment as classified by classic and appreciate the rhomboidal shape of the frenectomy area. Absolutely bloodless field done at 0.8 watt in contact continuous mode. This is 1 year follow-up of the case. Now lasers have also been used for depigmentation. Again, this is a case of depigmentation done with Epigex 940 nanometers at 0.8 watt, immediate post-operative. 6 months follow-up of the case. Now this case was also subjected to histological analysis, and this is a pre-operative dense pigmentation with basal photonar stain, and this is post-operative view at 6 months after treatment. I'm sure all of you know what is operculectomy. An operculum which is associated with an unerupted third molar or an impacted third molar. You just have a flap and you have a lot of plaque accumulation, food accumulation beneath. So diode laser is used here at 1 watt in contact continuous mode. Can you appreciate the precise cut with laser? So precision is offered here. Precise cut with laser. Now all this while I am talking about excision, ablation, cutting, incision with laser. You need to understand the difference between these. Excision is what? I am excising what? I am excising maybe a tori, okay, Incision is what? Maybe an abscess. Okay, so that is incision. Ablation is what? It is a superficial excision. Suppose if you have leukoplakia, you can do ablation, you can do excision. Excision is you have to go deep, 2 to 3 millimeter, and excise the lesion in total. Ablation is what? Just superficial, 1 to 2 millimeter is removed. So there lies a difference between ablation and excision. Now, if I talk about, this is very, very interesting, and recently it has gained momentum. Well, photobiomodulation, if I talk about, is more than 3 decades. Photobiomodulation is all about what? Well, Professor Henry Mester, the father of photobiomodulation, demonstrated that low-dose laser treatment was capable of promoting hair regrowth in mice. And this article was quoted way back in the year 1968. Well, it was in 2014, the North American Association for Light Therapy and WALT agreed by consensus to promote the term photobiomodulation as. Now, this is very, very important. Form of light treatment that utilizes non-ionizing forms, including lasers, LEDs, broadband light in the visible and the infrared spectrum, involving a non-thermal process with endogenous chromophores, eliciting a photophysical, that is linear and non-linear forms, and photochemical events at various biological levels. Now there lies the difference. Non-thermal. LLLT or photobiomodulation has a non-thermal effect. No heat is generated. Whereas if I talk about class 4 lasers, obviously it has a photothermal effect, that is conversion of light into heat, as the name suggests. And what is the outcome? So basically immunomodulation, that is, it offers therapeutic outcomes including 2, reduction of pain, the patient is very, very comfortable, immunomodulation and promotion of wound healing and tissue regeneration. So this is what is photobiomodulation. Synonyms are class 3 medical devices, cold lasers and therapeutic lasers. Again, very, very important. What is the depth of penetration? So LLLT, basically they can reach a depth of 3 to 15 millimeters in both hard and soft tissue. What is the power? 50 to 500 milliwatt. See, you're doing a frenectomy, you set the power to maybe 0.8 or 1 watt. If you're using Epix, obviously that is preset. You have frenectomy at 1 watt, gingivectomy at 1 watt. What are you doing? You are excising, you are ablating. But LLLT works at 0.5 watt. That is low level laser treatment. And the electromagnetic spectrum ranges between 630 to 980 nanometer. So you can use a 940 for photobiomodulation, you can use a 630, you can use a 980 as well. Well, these are certain specifications I've already talked about, but few terminologies which are associated with LLLT is what is power. Power is joules per second. What is fluence? Fluence is energy density, that is joules per centimeter square. And when we talk about photobiomodulation, the dosage, the amount of energy reaching the tissue is very, very important. So how do you calculate the dose? Dose is calculated by dividing energy upon area. Treatment interval is also very, very important. If you're treating a case of TMJ, I'll walk you through various clinical cases. Well, if I talk about lasers, I talk for full 1 day, or maybe we have, like 2 to 3 days of my listening. I just have to finish it in 30 minutes. So I'll walk you through various clinical cases. I'll show you cases of photobiomodulation. Before that, if I treat a case of TMJ, or maybe anybody walks into my center with hypersensitivity, what is the normal treatment interval? How many sessions you have to give? So generally 2 to 3 treatments per week, and you have to follow the patient for quite some time. If I talk about TMJ, you have have to follow the patient maybe for 8 weeks. Give 2 to 3 sessions per week. This is very, very important. Now, various devices, as I mentioned before, single laser probes, cluster of laser diodes, LED clusters, mixed clusters, where you can combine LEDs with laser and flexible LED arrays are used for photo biomodulation. Now, what is LED? You know what is LED? So, what is the difference between LED and laser? LED works with the principle of electroluminescence, whereas laser works with the principle of stimulated emission of radiation. Slow response with LED as compared to laser. Okay. If I talk about photobiomodulation long-term, I did a case with LED with that LED lamp, red lamp. Have you seen that? If you place it close to the patient, heat is generated. Okay, so thermal response here, non-thermal. The junction area is wide. Here you have a narrow junction area. Obviously, laser is very, very costly. LEDs are said to be less costly as compared to laser. Now, what is the mechanism of photobiomodulation? So, photobiomodulation works at cellular and molecular level. When laser enters the cells, what happens? It acts on the photoreceptors, widely known as cytochrome C oxidase or polyphyrins. They are activated and will liberate ATP. ATP in the mitochondria has various actions. Vasodilatation. If you place a laser probe on the cheek, your skin will glow. For girls out here, your skin will glow. Vasodilatation. Okay. Increased cellularity, increased fibroblast proliferation, increased collagen formation, analgesic effect, decreases C fiber response, decreases the action potential, okay, and decreased bradykinin, decreased histamine, increased endorphin, decreased prostaglandin E2. These are the mechanisms for LLLT acting on the cells and on the molecules, right? Now, this is again an important part. Photobiomodulation works on this Arndt-Schulz law. So basically, photobiomodulation has both effects. It will stimulate and it will inhibit. There is a therapeutic window where you have both the effects, and this forms the basis of PBM, that is photobiomodulatory treatment. As far as the wavelengths used for PBM are concerned, you have the red and the infrared. The red and the blue wavelengths, they are preferred for treating superficial tissues. This slide is again very, very important. The red and the blue wavelengths are used to treat superficial tissues, whereas infrared, they are used to treat deeper tissues. As you can appreciate here, the different wavelengths, red, infrared and blue. Now, LLT or photobiomodulation finds its use in all aspects of dentistry. I am a periodontist. I use it for all my cases. If I am raising a flap after suturing, I just raise the buccal and the lingual side. At the time of placing the sutures, recalling the patient after 48 hours, recalling the patient when you have to remove the sutures. So please remember, LLT has no side effects because the effect is what? Non-thermal. So you can give as many sessions you want. Prosthetics, orthodontics, implants, if you're doing a second stage surgery, okay, all of you can go through it once. Now, you have a laser. So LLT is what? It is a handpiece, like an attachable, like you have. Suppose this is the LLT. For treatment of temporomandibular joint disorders, place it on the outer surface of the skin, 1 centimeter in front of the tragus. Ask the patient to open and close the mouth in maximum intercuspation for 2 minutes. Use it in a scanning motion. Up ek jagah nahi rakhoge aise. If you keep it at one place, what will happen? The patient will be like, yeah, heat. Obviously, usko heat lagi. You just have to use a scanning motion. Okay, give 2 to 3 sessions per week, follow the patient for 8 weeks. So where are we aiming? We are aiming at the capsular ligament, the discal ligament and the retrodiscal which are raised. In case a patient walks to you with sensitivity, I have two cases I'll show you. You do photobiomodulation, 0.5 watt, lays the tooth, I'll show you. So my question to you is, can a soft tissue laser be used on the hard tissue? Anybody? Can you use? I'm using a diode. See, before starting my lecture, I told you soft tissue and hard tissue. You have a diode, you can do the pigmentation, you can do gingivectomy, crown lengthening, but can a soft tissue laser be used for a hard tissue? Can it be used? Where? Tell me. अभी मैंने आपको बताया ना, hard tissue you use it on the tooth. But any area where a soft tissue laser is used on the tooth. For? Okay, endo in the canals for hypersensitivity. A soft tissue laser and a hard tissue both can be used. Hard tissue तो आप वैसे ही use करते हो tooth पे, but a soft tissue laser for treatment of dentinal hypersensitivity can be used on the hard tissue. Okay, but in a non-contact mode. See, photobiomodulation is out of touch. We are not touching the tissue. It is 1 to 2 centimeters away from the tissue in non-contact mode. Suppose I have given 4 to 6 joules of energy per root to a patient and the patient is not responding to treatment. I have a case I'll show you. Please do RCT for that particular tooth. Have you understood? Are you understanding? I'm talking about photobiomodulation as far as hypersensitivity is concerned. You have already lased the site, given 2 to 3 sessions per week. The patient is not responding to your treatment. Please consider endo treatment for that particular patient. Third area, in case if you plan to extract the tooth, just laze the injection site, give 1 joule at the injection site, then extract the tooth, then give another 2 joules per centimeter square after extraction on the socket, both buccally and lingually. Obviously faster onset of it will be very, very comfortable. Try it out. It really works. Photobiomodulation really works. Herpes radialis. If you have a lesion on the lips, herpes. LLLT has an analgesic, anti-inflammatory effect, helps in fibroblast proliferation, and it increases the interval. Suppose if you give LLLT during the prodromal stage, the lesion will disappear in 2 to 3 days rather than the normal 8 to 10 days course of this disease. Now, LLLT is generally given in the silent periods between the attack. 2 joules per centimeter square out of touch. You are not touching, that is out of contact, in a non-contact mode. Paresthesia of the inferior alveolar nerve. This is again very, very interesting. In case if you have or you encounter paresthesia, just do photobiomodulation on 52 points. 52 points on the area. So these are how many, if you can count? First picture, 10 points extraorally along the course of the nerve, 16 points extraorally on the ventral region, 16 points intraorally on the lower labial mucosa, and 10 points intraorally starting from the labial mucosa inside in the central incisal region, that is vestibular fornix, follow till the retromolar area. So in case if you encounter paresthesia, just do photobiomodulation at least 52 points. See, just using laser is not sufficient. For each case, now during my presentation, I'm not able to show you how you treat pocket, how you treat flap, see, because that is not the topic of presentation, but then maybe we can have it any other time. So each case, what I do, be it pocket, flap, crown lengthening, every case has a protocol. So it is very, very important to have proper training and then start with laser. So all these protocols are very, very important. In case if point on the wrist. Give 3 to 4 joules of energy on the meridian point and gagging reflex will drastically be reduced. Cases of periodontitis, massive destruction, you can appreciate bone loss, recession. So what does photobiomodulation do? It helps in stimulation of periodontal fibroblasts, reduces pocket depth. Overall, it has an anti-inflammatory and an analgesic effect on the area. Now, I'll walk you through various clinical cases. This first case is a case of efficacy of LLT in the management of intra-bony defect. Can you appreciate the defect there? As measured with a calibrated periodontal probe after raising a mucoperiosteal flap. So 0.5, have you understood the parameters? 0.5, you can either use a continuous or a pulsed mode, non-contact. You're not touching. 0.5 applied for 2 minutes, repeated after 5 minutes for 90 seconds. Well, I also placed an allograft here, DFBBA, sutured, again did photobiomodulation. Recall the patient after 48 hours and just see the result. Preoperative, can you appreciate on the radiograph? And this is 1 year follow-up of the case. The good amount of bone is formed on the radiograph. Now, your question to me should be, ma'am, if we would not have used laser, I would have placed a bone graft, obviously you would have got the result, but why not take the advantage of laser? Laser is always used as an adjunct to your conventional treatment. Okay, never as a monotherapy. It is always used as an adjunct. What advantage is it offering? It is various articles have been quoted where lasers have been said to regenerate bone, remodeling. It brings growth factors to the site, increased vascularity, and that's how we got the result. 1 year follow-up of the case, where a good amount of bone is evident on the radiograph. Now, whenever you plan to harvest a free gingival graft, what do you see on the palatal side? Profuse bleeding, yes or no? So how do you manage that? You would have placed a foil, whatever, like normal perio procedure. If you do photobiomodulation, 0.5 watt, raise it for 30 to 60 seconds, you will achieve good hemostasis and your bleeding will stop. So again, in free gingival autograft, continuous mode, non-contact, 60 seconds. A case of TMJ, well, this TMJ disorder, this patient walked into my center. Can you appreciate the occlusion? He was complaining of severe pain in the TM joint. So I did photobiomodulation for him. Can you see the motion? Scanning motion, 1 to 2 centimeters away on the outer surface of the skin. But my question to you is, if you have cases like this, see, you have SNEA. This patient came to me, did you see the occlusion? Yeah, did you see the occlusion? I did laser, but please, treat me. Yes, treat that. Just identify the etiology. Doing just laser, I always tell my students, all my PG students, please do not just treat it. Identify the etiology and treat the etiology first, so that it have a long-term effect on your outcome. Now, a case of laser desensitization, where lasers have been used for treatment of dentinal hypersensitivity, and its effect was first noted by Matsumoto in the year 1985. Lasers have been used as an adjunct to various desensitizing agents. That means you can combine laser with a desensitizing paste. So this lady walked into my center with a chief complaint of 100% hypersensitivity. Okay. I did laser, that is photobiomodulation for her, 0.5 watt in continuous fashion. Just see the protocol. Application of the gel, leave it in place, thoda volume kar do. Bhaiya? Hello, volume thoda place kar do, thoda. So, keep the gel in place for 10 to 20 seconds. Okay. Fire the laser at 3 points. 20 seconds each side. I'll show you. Taste karo. Fine. See. 20 seconds each side. Mesiobuccal, midbuccal, distobuccal. 60 seconds per tooth. 20 seconds each side, 60 seconds per tooth. 80 point pe mat rakhna, keep it moving. So, I laced the entire oral cavity for her because it was more in the anteriors, less in the posteriors, so I laced it all. 20 seconds each side, 60 seconds per tooth. Except, I just gave her one sitting of laser for the biomodulation. The second time she came to me, she had only sensitivity. She had sensitivity only to teeth. Posterior molars and premolar. Well, I suggested RCT. Why? There was severe abrasion. Why do I do laser? I have done laser for her. So, for her benefit, I suggested RCT. Even if you're given 4 joules or 2 joules of energy for repeated sessions, 2 to 3 sessions, consider RCT in the next appointment in case the laser does not work. And this is what the patient had to say. Volume control. So sometimes what happens, you have to convince the patient. The patient doesn't know you have this technology for desensitization. And I'm telling you, this works wonders.
Much better. Almost 100% head was
So you can use any like desensitization.
और उससे आज ट्रैवल लगाने के बाद भी और भी बेटर हो जाएगा. But later से I feel much better.
Now, interesting case. He was an NRI from Australia, followed the same protocol for him. What was his chief complaint? His chief complaint was inability to have ice cream since he was a 3-year-old kid. And this is what he had to say after he walked off from the clinic. He did not come to me for laser. He had some other treatments which I gave, like RCTs were done, crowns were done, but I convinced him for laser. Volume kar do bhaiya.
Because I couldn't write, because the sensitivity levels were beyond sparkling in my head. So I getting my treatments done there, I spoke to her, and after speaking to her, she told me about this new technology that she has, and that is the laser treatment sensitivity that she performed on me. And I can tell you this, that if it was about 100 earlier, now it's come down to, let's say, 1% or probably not even 1%. So it's a life-changing experience. Now, I've met a lot of doctors, and I've met I live in Australia, and I've met a lot of dentists overseas as well who have not communicated this thing. But coming down to Dr. Sethi, I have seen the way that she's performing the treatment. It has been mind-blowing because it was painless. It was something that I actually enjoyed, and I'm walking away today with this sense of confidence and knowledge.
So he was quite happy. I think we're short of time. He was quite happy with the treatment. If I talk about ulcers, photobiomodulation of the lesion is done with laser. This case, 940 nanometer diode laser, lays the site for 30 seconds in non-contact mode. Please remember the tip is moved in a circular fashion from the periphery towards the center. So what are the changes? Lesion size decreases, color changes. If you have a red vascular lesion, maybe you have a light one later on. 2 joules per centimeter square. Now this case, I did photobiomodulation. He came with mild swelling on his cheek. You can appreciate impacted third molar after extraction at baseline, photobiomodulation and pain therapy done for this case. And OSMF case, oral submucous fibrosis, he had difficulty in opening his mouth. Now, I was talking about ortho. Ortho is generally patient complains of pain during the initial treatment, that is 2 to 4 days after treatment. So LLLT decreases pain 2 to 4 days after treatment but does not alter the most painful pain. So this case, ortho treatment is being done. Again, you can appreciate how do we do this? Just lasing around in a scanning motion. Can I play this video? So what is the effect? Non-thermal biostimulatory neuropharmacological effect on the synthesis, release and metabolism of serotonin, kinase, acetylcholine at the central level and histamine at the peripheral level. Now mucositis. What is the treatment protocol? Well, I'm also associated with Max Hospital at Vaishali, where we do photobiomodulation for premalignant lesions like leukoplakia, lichen planus and erythroplakia. So what is the protocol? Intraorally lays 4 points of the soft palate and onto the oropharynx, extraorally lateral and ventral surface of the pharynx and the larynx, midline and the lateral aspect of the tongue. Various systematic reviews have quoted that LLLT can be given prophylactically as well as therapeutic effect. So 2 to 3 joules offers prophylactic effect and 4 joules per centimeter square offers therapeutic effect. This was a meta-analysis by Jordan et al. Well, this case was treated at Max Hospital. Can you appreciate massive swelling post-operative like post-chemotherapy and radiotherapy? He was complaining of severe burning sensation and itchiness. And I did photobiomodulation at 0.5 watt, just raised the area and he was quite happy. Immediate effect, he was not able to have food also, but immediately after photobiomodulation worked wonders. So he said 70% relief of pain and burning sensation. Lichen planus, where I happened to treat this case when I was there at ITS heading the laser section. She was a patient who was taking corticosteroids initially but left corticosteroids just to see the effect of lasers. You can appreciate, as performed by the oral pathologist as a case of lichen planus, you can appreciate white striae on the gingiva and the buccal mucosa. She was there in India when she reported from Oman. She was there in India for 2 weeks. I did LLLT 0.5 watt, 3 sessions per week, no harm, for 14 days. And it worked wonders. What is the mechanism? Cross-hatched pattern is made on the surface. And she was quite happy. Well, I'll skip this. So, I just wanted to tell you about, all this while I've been talking about PBM, that is photobiomodulation. Let me tell you about PDT, because there are similarities between PDT and PBM. What are the similarities? Both use low-level laser, right? But what is the difference? So PDT works on the premise of destruction, whereas PBM works on the principle of therapeutic effect, offers therapeutic effect. The amount of ROS generated in PDT is more, that is reactive oxygen species, whereas the amount of ROS in PBM is less. Exogenous chromophores in PDT, you're giving a dye, indocyanine green, methylene blue, whereas in PBM, endogenous chromophores. You are activating the cytochrome C oxidase and the polyphenols which are present in the mitochondria. There are similarities, but there are major differences between the two. Just walk you through this case. Indocyanine green was used for pocket treatment, which is a photosensitizer, just injected inside the canal, just injected inside the pocket. Base it, 0.5 watt for 5 seconds. 3 months post-operatively, there was a drastic reduction in the pocket depth as measured with stent. This is how we do calibration. In the end, I would just want to highlight sports dentistry. I'm into sports dentistry now. And photobiomodulation has all these effects. It heals the damaged tissues, increases immune response, decreases inflammation. There is tissue regeneration and recovery. Well, it has protective effects. You can just take a picture if you want. So what are the effects? It decreases the oxidative stress, decreases muscle fatigue, inflammation, dyspnea, etc. So photobiomodulation is also gaining its use in sports dentistry. You have a tooth fracture, cases of intrusion, cases of fracture of fragile tooth during preservation, tooth avulsion. All these can be taken care of with photobiomodulation. Again, TMJ problems, lip contusions, again a fracture. One last interesting case of massive tongue bite treated with photobiomodulatory treatment. Well, this patient bit his tongue, but did you see how? I did photobiomodulation for this case, 0.5 watt, just raise the area reduction in the bleeding, that is, instant hemostasis was achieved. See, agar aap bleeding dekh lo, the first thing what would you do? You will just take something and press it. Okay, thereafter do photobiomodulation. Wonderful results. Accelerated wound healing. This is how scanning motion is applied on. I'm not keeping it at one point, just placing it around. Immediate post-operative, 2 days, normal course of healing, 12 days and 7 months follow-up of the case. So the patient was quite happy. In the end, I would like to conclude my presentation with these certain points which I'm sure you must remember. Well, photobiomodulation is said to be non-invasive, non-pharmaceutical, economical. Impact of this LLLT is through its non-heating effect. There are no side effects of offering photobiomodulation, but myriad of positive effects like immunomodulation, accelerated wound healing, increased fibroblast, increased osteoblast, increased collagen formation, and good healing. Effect is most prominent in cells with reduced detox potential. Effect on healthy cells is less prominent. Effect is localized as well as LLLT offers systemic effect. What do you mean? If you're having tendonitis, I use a laser. Tendonitis is what? Inflammation of the tendon. Where is tendon? Deep inside. How will laser work there? Laser strikes the tissue. It will be carried through the blood metabolites, and therefore the effect is systemic. So it offers both the effect systemic and localized. Well, these are the other important points. PBM improves quality of life, sleep disorders, tiredness, muscle spasm, circadian rhythm, all these they are taken care of with photobiomodulatory treatment. Well, I will skip this. I think dental laser safety is important. You must wear a protective eyewear. You should have caused it. The line high volume evacuation is mandatory. So this is the emergency button. In case of any emergency, please press the emergency button so that you do not have any explosion. Avoid using laser in presence of nitrous oxide or inflammable objects. Remove your metal. Avocado, rings, watches, everything. What happens? It gets directed into the eye. What happens? Retinal damage and corneal damage. Retinal damage with deeper penetrating lasers like the diodes. Corneal damage with superficial lasers. We should always have a danger sign outside your operation. That laser in use. Well, I will end my presentation and I would just take 2 minutes of yours. I would just walk you through my journey. I completed my mastership and diploma in laser dentistry from the University of Vienna. Worked with Professor Andries Moritz and Marcus Leakey. So this was in Vienna. Thereafter, I have lectured at various national and international platforms, starting with Delhi Dental Show in 2018. Well, this was at the ISPPG convention in Jaipur. I deliberated at Dentistry 2018 in Kerala. At the 40th UP State Dental Conference in Prayagraj. This was again at UP Dental Show, ICT, IBC Indore. Delhi Dental Show again in 2019. Well, I was also invited for the 33rd International Conference of Dental and Oral Health in Dubai. I have deliberated at Dhaka at the International Symposium of Academic-Based Clinical Dentistry, where we conducted a 3-day workshop, worked with different lasers, both hard and soft tissue. Well, this was at Lucknow. This was at Faridabad, again consecutively for Delhi Dental Show in 2022 and UP Dental Show in 2022. I also deliberated at the most prestigious conference, the 46th National Conference of IST held at Bhubaneswar, Odisha. This was the CT program at Agra, Sri Aurobindo College, Indore. Well, again at 40th IDAMP State Dental Conference in 2023. I also conducted a workshop there at Mansarovar Dental College. I was invited by the Government of People's Republic of Bangladesh to deliberate on lasers at one of the government medical colleges, Chittagong Medical College in 2023, where we had a 5-day workshop on lasers and endo. Again, ABCD, this was at Rishikesh Chhabra College. I also deliberated in my own college at IDS Dental College, where I'm also a panelist. I was a panelist at the first Masters Tobacco Cessation training, which was done at Faridabad. This was again at Cynodent, KGMU Lucknow, where I conducted a workshop. For the first time, I was invited to another medical college, government medical college in Cynodent in Bangladesh in 2023, where again a 5-day workshop was done. This was at Max Hospital, IT Dental College. I happened to meet Professor Arani, who's actually a pioneer of photobiomodulation, University of Buffalo. Yeah. So he talks a lot on photobiomodulation. So this was at Max Vaishali. I also deliberated at 11th World Dental Science and Oral Health Conference. This was a lecture at Rajasthan, at Mathura. Well, recently I deliberated at the Professional Enrichment Program at ITS Greater Noida. In 2024, recently KD Dental College, Mathura, and Christian Dental College at Ludhiana. This is my own venture in the heart of Gurugram by the name of Gamsopolis. Well, this is my logo. I also conduct courses on laser where we have a 3 or 4 day workshop on lasers along with practical as well as life surgery. In the end, ladies and gentlemen, I would just like to say a successful warrior is the average man with laser-like focus. Thank you so much, and thank you once again for having me here. I would like to thank Dr. Ashish and Dr. Anmol, and especially all of you for being a wonderful audience. Thank you so much.
I invite Dr. Ashish Chandra sir, Dr. Cheryl Billingsley ma'am, and Mr. John sir to felicitate Dr. Malika Sethi ma'am. Thank you, sir. Thank you, ma'am. Now, I would like to... Thank you, sir.
Wait. Yeah.
Thank you, sir. Now, I would like to invite Dr. Sumit Goyal, sir, for felicitation.
Chin down, buddy. Wait.
Thank you, sir. Thank you, ma'am. For the next lecture, I would like to invite Dr. Nikhil Bahuguna, sir. He is the president at Indian Academy of Aesthetic and Cosmetic.
Of the Indian Academy of Aesthetic and Cosmetic Dentistry. I am a happy dentist. I don't run through these slides because I want to show what I've done, but just to mention that I feel very happy when I stand on a podium like this. Even if there's one person in the audience, my wish is fulfilled. Because I cannot talk to 1,000 people at a time, and one at a time is what we always aim at. And I've traveled a lot across the world to learn what little I know. And it's always a very nice moment to share it with whoever is interested, people who want to update and upgrade. Usually the thanks comes at the end, but I wish to start with the thanks because the gratitude should not be missed for the organization, for the PFA, for the audience who's sitting here. A big thank you to all of you who have spared your time because truly this is what we do every day. So for me this is nothing new, but for you to, select of you who are sitting here right now, squeezing out of your schedule is an important thing. And that's my family, and I always thank them as well. Because if it's not the support of those guys there, we can't be doing it here. That's my organization, the Indian Academy of Aesthetic and Cosmetic Dentistry. We are into our 34th year now. And we are proudly the only organization in this country which is organized conferences in India, across abroad, and connected with the IFED, the International Federation of Aesthetic Dentistry. Recently, I've just been to the Asian Academy of Aesthetic Dentistry, so we do a lot of work in the branch. So the topic that we discussed in Dr. Ashish called me was something that I like talking about a lot, and that's why if you, whoever was here, when Dr. Sanjay Miglani was talking, he said he'll dilate it further, because that made his job easy. He just spoke very basics and left everything else to me. So let's discuss and dissect the word biomimetics. It's a very common word being used these days. People like talking about it. Everyone is doing biomimetic dentistry. But at the end of the day, is it new or old? The term biomimetic may have struck our heads or minds a little years back, but this is as old as dentistry. Because if you know and realize, we have been trying to do this for the longest time. The only problem is we call them fillings. And the moment you call them fillings, there's nothing called biomimetic. It's bio, probably energized. When you call them restorations, is what you call as biomimetic. This picture has been taken in a park in New York. We were walking in the morning, and I saw this tree being reinforced with the help of some cement and stone. And that's exactly what we dentists try to do. We are trying to do dentistry which is non-breakable, which is hard. And when our patients ask us, Doc, how long do you think it would last? We love telling them that we have a warranty on the material. But sorry if someone feels bad about it, that is the biggest trash of dentistry. How long will it last? And people tell this could last as long as probably 5 years, 10 years, we give them warranty cards. Trust me, on the code of law, all of us could be sued for doing that. Because what is the patient asking you? How long will this last? Means the tooth. And what are we answering? The crown or the filling or the metal or whatever. We've all done this test. The labs come with a hammer and start banging the crown, it doesn't break. How many of you have the force of a hammer in your mouth? Your masseters can apply about 200 newtons. This is about 500,000, 10,000 newtons. You actually bang your teeth like this. And that's when this very old saying from a great philosopher Osho comes to the mind. Everything which is natural will degrade. And if it's not degrading, it's going to break something. And that's what is the basis of my dentistry. Because yes, Dr. Malika also mentioned about this. You had a orofacial pain discussion in the morning. I feel we dentists are the best people to treat orofacial pain because you have to solve your own mistakes. We are the best people who are giving orofacial pain to the world. We are the guys who are contributing towards temporomandibular disorders, and that's why there's a whole new branch of dentistry created called the temporomandibular dentistry. And trust me, I'm one of those who's gone through the phase of change. People never had so many TMDs and adhesions and absorptions on the tooth 20 years back. Try and check your chronology. Since we have introduced hard non-breakables in the world of dentistry, people have started having TMDs. And then, again, my previous speaker was talking about it's not a bulk fill and he laughed at me because he knows how much I'm in love with this material bulk fill. That is again a big lie that dentists talk about. We are forced to believe that if I push a material 10 mm into a cavity and cure it, it will get hard. The fact is no. It cannot get hard because God made the tooth in multi-layers. If there was one unit or a monolithic structure, then why did God spend so much of time creating enamel, then a DEJ, then a dentine, and then a hollow pulpal cavity with some periodontal limited bone? I mean, do you think a lab giving you 21 years warranty is better than the Lord Almighty? Thank you very much for accepting that false statement. Dr. Miglani quite nicely explained the basics, so let me just go through and talk about what he harped a lot upon. And you got a couple of you here standing trying to show what is polymerization shrinkage. And yes, everyone feels it's a very bad thing, but I am probably one of those very few people in the world who says I'm happy that the monomer shrinks. Because if it shrinks, I can use it to my benefit. Nothing shrinks away from the tooth. Shrinkage means it has to shrink somewhere, right? And we always feel it's going to shrink away from the tooth. He also made some people dance left and right, that I'm breaking here and I'm breaking there. Ideally what he should have done is hold one person's hand first, shrunk towards that particular girl who was standing. Okay, then you are done. Now hold the second girl's hand and shrunk towards her. The shrinkage is zero. There is no shrinkage at all. If you look at the tooth, what substrate is the tooth made up of? You know more histology probably than me. Which is the bulkiest portion of the tooth? The dentine. And dentine is elastic. And everything which is elastic can shrink and contract back. So shrinkage in dentine is inconsequential. You should just know how to use and what to use. Shrinkage is maximally important when we come to enamel because that's brittle. If you pull enamel, either the enamel gets pulled and cracks or you pull the material and crack. So what do you think should be the strength of a restorative material that we use in the oral cavity? Because nowadays we have some crowns which promise 1200 megapascals, which is so-called non-breakable. I don't know how many of you have actually practiced the art of giving warranty cards. So labs give you a 5-year warranty card, then there's a 10-year warranty card, then there's a 15-year warranty card, a 19-year and 21-year, and recently a company said lifelong. Wait for a couple of years, you have a warranty card which says you die, you'll be born in the next birth, your tooth will still be there. That's the biggest falsity they're living with, to be very honest. Do we need 100, 12,000, 1200, 1500 megapascals? What is enamel and dentine? The term megapascals, strength, compressive strength holds only true for enamel. And enamel is just 384 to 400. Maximum 500. What is most important is the bulk of the tooth, the dentine. It doesn't rely on compressive strength. It relies on the flexural modulus, which should be around 18 to 20 GP. And here I have given you the recipe of your entire restorative life. You want to do a direct restoration, indirect, semi-direct. Choose a material which has a compressive strength of about 500 and a flexural modulus of 18 to 20. And trust me, the polymerization, shrinkage, crack, fracture, breakage, nothing will happen. And if it happens, what will break? Not the entire tooth will come out, the superficial layer will crack and it's always repairable. And then comes the social media fact, the dentistry today. Because you've taken the word book very seriously. So Mark Zuckerberg launched Facebook and we thought it's a dental book. How many of you ask questions to your seniors, teachers, colleagues? Sadly, we go to a so-called social media education page, post our questions there. Until India is a democracy, everyone has the right to give opinions. And everyone gives an opinion. And at the end of the day, are you convinced or confused? Because there is no consensus. The fact is, when you see those sharp-looking, nice, beautiful cusps on social media, you feel, oh my God, this XYZ radio gentleman is doing such excellent anatomy, and I cannot make a single cusp. My cusps are all flat. Well, let me tell you the truth. Half of them are pre-polishing and pre-occlusion, and if not, then most of them are going to go into fracture state very soon. Because the sharper the substrate, you look at the first picture, you can dance with heels or flat shoes. Your tooth is dancing 24/7. You want to give the tooth heels? Because the moment you give heels, you increase the stress. My previous speaker spoke about TMD. A big cause of TMD is giving sharp inclines. Look at the structure and tell me where do you have beautiful sharp edges, cusp slopes. God made tooth in dome and reverse dome. The furcation was a dome, the DEJ was a reverse dome. And that's exactly what we need to replicate. But if I ask you, how many of you actually restore a DEJ? And the answer would be, this man has lost it. He was waiting for an hour and a half, I think his mental balance has gone off. But yes, you have to replicate the DEJ if you want to restore, because that's the only structure which is going to create the internal dome to dissipate forces. And then we all know the dentine is made up of collagen. So do we add any kind of a collagen substitute in the tooth? Not at all. Because at best we have one syringe which was given to us in a kit. We open that, we don't even see whether it's enamel or dentine. We pack the entire tooth with it, and then the forces change dimensions completely. The tooth cracks and breaks. And then what do we blame? Rightly pointed out by our previous speaker, we blame the composite. And then what happens next? We do a crown. Then the crown breaks. Whom do we blame? The patient. You must have bitten on something hard. So what do you want? Everyone should follow a vegan diet. I mean, I'm a voracious eater. I can eat everything on this planet Earth. So if you tell me my tooth will break because I ate that, I'm so sorry. I will not take that as an answer. Just look at this one picture. I know maybe I don't have the right audience to explain this entire concept, but just imagine. You have a compression dome, which is the enamel. It's like an outer covering, like a cap on your head. Underneath, you have a lot of soft dentine. So when the harder outer cover gets pressed, what happens to the internal dentine? It collapses and bounces back. It expands and contracts. But imagine you have a hard material top to bottom, from occlusion to furcation. So when the patient bites, where do the forces go? And when you have a vertical split, whom do we blame? The patient must be biting on stone. Right? He must be eating gold. We do crown preps. All of us love doing tooth preparation. Some people call it crown cutting, rightly so. Because you're cutting, you're not preparing. The moment we reach and breach the margin of a crown, which is the cemental enamel junction, this tooth has lost its lifespan almost about 10 years. Keep the margins as high as possible. Look at this diagram. The lower you go towards the CJ, how much of tension increases? Tension means bending. Compression will never break a material. Flexing will break a material. Try and do it. Try and hold a stick and flex it and break. Try and compress it. It will never break. So what are the objectives? Minimally invasive? Yes. Use a lot of magnification. One thing which is quite sadly not followed by a lot of undergraduates, postgraduates, even most glorious people teaching. But if you do not have right vision, you are not practicing good dentistry. And I know I may not be mincing my words, but the fact is it has to hit someone hard. If you cannot see it, you cannot do it. And if you think your two beautiful eyes are giving you that vision, I'm so sorry. Humble submission, I'm very sorry. It's not. And second is, replace nature. Build the structure correctly, use the right material, and follow the right substrate. That's all we need to do. 3 concepts which I base my dentistry on. Number 1, as I said, compression does not break anything, the tensile forces do. And which component is going to give you that reactionary tensile propagation? Dentine. So when you're doing deep cavity fillings, do not fill them with universal composites, fill it with dentine materials. Number 2, stress concentration. No sharp edges, no sharp spots, no sharp line angles. Composite cavity preparation is a myth. Take a pier or a round diamond, excavate what is weak, remove the weak walls, and that's all you need to do. You do not need to make flat walls, floors, and angles, etc. That's not for composite. And third is, whatever you've made, it should sustain. That means you need to add tensile stresses, something that can bear tensile stresses better. Just to give you a very short example, look at these 2 structures. Which can you break easily? Beams will bend and crack. Domes will dissipate. And that's why we do not like letting people give very sharp edges or making flat floors at the furcation. Remove what is needed but preserve what is there. You do not need a flat cavity for a composite, it was for amalgam. For composite you can have one floor at 20 different levels and you'll still be doing better off. See, because whenever there's a dome which presses, you'll have tension and there'll be a resultant expression of it. So if we can control this somehow, it's negated. But if it keeps on pushing down for a brittle material like a universal composite or an enamel composite or even a glass ceramic, it's going to break somewhere. Creating dome concept. The enamel compression is very necessary, but replicating the dentine and DEJ reverse dome is also equally important. So which part do you think gets maximally affected? Again, going back to that villainous word, you all feel that this one word polymerization, shrinkage, is the biggest problem, right? What is worst about composite? Shrinkage. So let's analyze shrinkage. Where does shrinkage matter the maximum? This is a finite element analysis which shows you it is maximum at the base and as you go up, corners. Number 1, do not create walls with angles. Saucerize your cavity. That's why I said use round or pier diamonds. Do not use flat end diamonds or carbides. Again, a question was asked by my previous speaker, do you use a base? And people were confused. No one was wanting to answer this question because it's a very I would say challenging question, right now very complicated thing to answer. But if you ask me, what is a base? A base is nothing but a layer between the material and the pulpal surface of your dentine. Now, I'm not using a glass ionomer, I'm not using a calcium hydroxide because, to be honest, these are outdated materials. For me, even RNJIC is something which I may have probably used 2 decades back. Today, what we use is something which is bioactive. And a base does not mean to give a 2 or 3 millimeter thick base, it's just a partial cover on the base. So it could be either a bioactive material or an elastic layer. Why? Because whenever the composite will shrink, it will try to pull away. Right? Like those girls were getting pulled. So what if you exerted equal force back when Dr. Gutmann was trying to pull? You would have negated the force. And if both the sides were equally strong, they would have had 0 resultant. What happens on a normal day? You have a patient with a restoration, forces follow it, they go directly to the base, the stress concentrates, the teeth crack. What if you add that elastic layer in between? There's compression still. When you're sitting on your stools that you're sitting on right now, what is happening to the cushion underneath? It's deforming under stress. But when you get up, what will happen? Will it still remain deformed? It will bounce back. The base was still hard. The base will never crack. But if I make the same cushions, remove them and make you sit on the flat wood, first of all, how long will you be able to sit? Your back will hurt. And if you two or three of you sit on the chair will break. So try this. 3 of you sit on one chair, it will not break right now. The reason is not because you are strong or the chair was weak. The reason is because we removed the cushion in between. And these cushions are nothing but fibers. As I said, dentine is made up of tons of collagen. But when we restore teeth, where is the collagen structure? We restore it with monomers and polymers. So you need to add certain collagen-based materials which are fibers between the layers of your filling. You could use stretchable, thin glass fibers. Okay, polyethylene and glass are two variants. Polyethylene is rigid. And for me, nothing in dentistry can be rigid enough. In fact, always remember, you want to be successful in life? Stop being rigid. People who can be flexible are the most successful people. And that's exactly what happens inside the tooth as well. You need flexible materials. Things which have a very high tensile strength. So that no matter how much the tooth wants to bend, it still stops it. How many of you seen the movie Iron Man series completely? Till the end game? All of you? So when it started, Iron Man, look at the bulky iron suit he had. He was falling everywhere. Iron Man 2, the suit gets lesser and lesser in weight. He's still not very happy. Then 3 finally for an end game. Why do you think from iron suit they came to a fiber suit? Because with iron fingers he couldn't have done this. Trust me, the world wouldn't have been safe. You need flexibility to save people, not rigidity. Whenever there is force on the tooth, the areas of stress concentration are much below. If you hit your foot on the ground, try this. Where will you feel the maximum jerk? Not on your foot. You will feel it on the hip joint. Because that's where is the connection it starts. The tooth will never feel the stress on the top, it will feel it at the junction of the base and the floor. And the moment the stresses go there, it cracks. All we have to do is just add in a layer between that place so that the tooth doesn't crack. And that's again the fibrous material we're talking about. You have materials which have fibers incorporated into them. You still have to do a dentine material. Rather than a plain dentine material, use a flexible dentine material. Rather than only monomers and polymers, use fibers with monomers and polymers. And just tie them inside the cavity. That's all you need to do. Bond the layer, add those fiber-based materials. And now restore the top with the amalgam. Composite. Do whatever you want. But the stress should not come to the base. These are studies which show you that if you use fiber-based materials or softer materials at the dentine core and just rebuild the top amalgam, which is about 1 to 1.5 millimeters, stress concentration does not go to the base of the tooth, but it goes through the dentine, to your roots, to the PDL and to the bone. That means if anything is going to break in the future, what's going to chip off? The top enamel layer, which is repairable, rather than the full tooth, which is replaceable. And I'm sorry, I have been practicing dentistry for more than 2 decades. I haven't placed a single implant. People feel very shocked that you don't do implants. No, I don't. Because I can give you my guarantee, not a card, that if I have a fibula of about 2 millimeters, that tooth will never crack. Because we don't believe in non-breakable or hard dentistry. All we do is very soft material, soft loadings. Okay, one thing which I would request you is never call a tooth simple. Patients walk in like this, hey, that's simple. Let me sit in my chair, I just restored it in half a minute. Never tell this to your patient. Never commit before you've seen everything. The so-called simple cavity, you start excavating it, and look what happens. Always use caries detecting dyes because again I would say, even if you're wearing a 10x magnification or a 100x magnification, you cannot see bacteria. You cannot see what is non-remineralizable. These dyes help you check that. Keep on excavating till the tooth is clean. And if you expose the pulp, let it be. You still have materials to seal the pulp, biomaterials like dentine, MT, etc. So don't worry, you have not committed a crime. Gone are those days where you expose the pulp and you'll be thrown out of the school. Today you are allowed to expose the pulp and seal it. Once you have etched and bonded, look at that white thing on the base. It is not a base material, it's a bioactive liner. which has the property of adhesion to the tooth. It's not a physical block, it's an adhesive material. It is exactly behaving like dentine, the megapascal strength is same, and it allows you to etch and bond. So now you can at least go deep and etch. Here we do circumferential etching, we don't do a total etch. Can you see the frivolous thing on the base? What's that trellis on the base? Let me show you the fiber. Now this fiber is going to decouple your entire restoration from the pulp. That means whenever there is any pulling force, it will not let the material completely blank out. It will just pull it back. And even if it fails, it will fail at this interface. Your pulp is going to be safe throughout. We seal it with a fiber-based dentine material. We use blocks of fibers and composite. This is all dentine material. Restore the base. Always remember, you have to recreate the DEJ. So very small fiber at the dentine junction so that we can have all stresses gone. After so much of fiber, trust me, anything that will happen will only crack the enamel. Dentine is absolutely safe. That means your tooth is not going anywhere. Restore the anatomy of the enamel. Please remember, enamel can never be restored in bulk. You can only find dentine in bulk. Enamel has to be cusp by cusp. Again, there was a mention by my previous speaker, wait for 10 to 15 minutes. Why do we wait? Enamel or dentine or whatever we've done is getting what? Relaxation. They are under constant curing stress. They need to open up. And in that time, there's always an uncured layer on top which is very, very perceivable to the ambient dirt. So please cover it with the glycerine jelly. Re-cure it for as long as you've cured your permanent restoration. Finally go ahead, finish polish, and that's your work done. That's a 6-month recall. Another case, slightly more complicated in terms of stress management. What part of the tooth has broken? The marginal ridge. And what bears the loads on a tooth? The marginal ridges. And here it's broken. What does it suggest? I'm under a complex load structure. And shaving off the opposing tooth does not help, because it will regrow and make the condition even worse. It was a cement restoration before. Trust me, cements do not work anymore. Everything is gone adhesive. We excavated. You see the blue line? What does that blue line denote? It's a big mistake. We never practice occlusion pre-operative. We all like doing occlusion checks after we've done restorations. We put those blue and red papers, patients bite, we get spots and we randomly chop them off. Did you even know where your starting occlusion was? Where was your centric stop? For all you know, you may have just rubbed the centric stop a little. And now what happened to the opposing tooth? It will drift and start creating interferences. So we have taken a mark before we start the cavity preparation so that either we completely exclude or completely include the cavities within this line. Isolate rubber dam is very important. I always request that please use rubber dam specifically premolar backwards. Anteriors you can still put lots of cotton and suction into whatever. Posteriors you cannot control the tongue. Please apply rubber dam. We've isolated with the sectional matrice. Again, protected the pulp, selective edge. A class 2 gets converted to a class 1. You see a lot of fiber inside. That's my proximal wall created. Doesn't want to go after that. Okay, now. The cube-based material which has fibers in it, pack the cube, restore the enamel, put the enamel covering layer, the glycerine, and that's the restoration done, finished and polished. That's the marginal ridge recreated. Now someone who came with a broken marginal ridge, we want to give him the ridge back because ridges give supports. And if you take the support off, 10 years later this patient is going to be coming to you for anterior grinding, no vertical collapse in the posteriors, and we are confused how do we raise the bite. That's the contact position. Non-vital teeth, again we love doing post and goes, right? And we were all taught it. In fact, I was taught, take a drill, go 3 sizes higher, make a nice conical cavity, then take impression and make metal out of it. I was taught doing that because the curriculum demanded that. That's for practice, but that's not for my clinical practice. How many of you will let me drill your tooth 1.6 mm and take a metal post and shove it inside? I would not allow anyone to do that. Nowadays, our concept has gone slightly different. People call it minimally invasive dentistry. We call it maximally preservative dentistry. All of us know that we have tapered instruments for root canal preparations, 4%, 6%, etc. Just utilize the already created taper. Clean the root space by about 6-7 mm. You do not have to put thick posts, big fiber posts. You have flexible fiber pins available. The best part is, what is the modulus? Exactly same as dentine. So all that I'll be talking, you'll realize I always base my discussion dentine for dentine, enamel for enamel, and nothing more than that. As simple. Look at this root. It could be a canine, it could be a premolar, it could be a distal root or a parietal root. It is not always round, but our posts are always round. And if I do this, I may end up perforating a premolar or a canine. And then whom do we blame? Again, the materials, the science, etc. Your biggest enemy is you, no one else, trust me. If you want to see who can help you, look into the mirror. And if you want to see your problem, again look into the mirror. There's nothing beyond that. Metals, even bigger posts concentrate a lot of stress, but the fibers, thin fibers, they only dissipate. They act as a monoblock rather than a physical entity. See, all you need to do is just do your root canal, preserve that space, do a down pack or remove the gutta percha with a retreatment instrument once it's an old obturation, and that's all you need. And you don't need to go 10 mm, 12 mm, 13 mm. We've done studies and we've proved it to the world, the best depth is 7 mm. In fact, there's a study that we've already published which is if you have 6 mm and you push fibers into the tooth, it's the highest push-out constant that you get. Let's jump through this. Even if you have oval canals, long canals, you could spread across the occlusal table. But now comes the best part. We've done everything in a biomimetic manner. And now we have to give a crown on top. Let's say it's a root canal treated tooth. When I say crown, it could be a crown or an onlay. What is the material of choice? I listed everything out. So I get to hear lithium disilicate. Absolutely right. Lithium disilicate is a very good choice for restoring the occlusal anatomy and proximal anatomy along with buccal and lingual, because lithium disilicate behaves like enamel. But what if you're doing a cusp protection onlay, or an inlay onlay, or an endocrown, where you have to go into the dentine and come out with enamel? Then a lithium disilicate is not the right choice because that's too brittle and it will break. That's where again, and if you see, ask me, ask anyone who remotely knows me, even if I have to tell 1,000 lies I will, but give me a composite syringe in my hand and I become a saint. I cannot lie with the composite in my hand. I love that material. I'm built up by that material. They didn't like that statement. Please do not choose materials which promise you non-breakability. Choose materials which are more natural. And I'll just show you a graph or a study that has been done internally. We did that in the Pavitra Dental College at Chennai. We did that in the University of Berlin. We did that at the University of Massachusetts. Across the world we've done that study and everywhere the results have been the same. That what is enamel, dentine and TEJ in terms of compression and flexion, what do we need and what do we have? That's probably the last statement that I need to make, provided this gentleman gives me the screen. Yeah, right? So anyways, I just have to show you an aspect of this particular material. But all in all, what I want to put across today to everyone and anyone here is, stop giving warranties to your patient. Give trust, give faith, but don't give a warranty card. So look at this material. Remember what did I say, what is enamel? 384 to 400, maximum 500, the compressive strength, 550. What is the flexural modulus of dentine? 18 to 20, 20. What is the surface hardness? 100. That means it will behave like natural enamel. Enamel is about 120. Lots of shades available. You can do good aesthetic work with these materials. It's not that composite is not aesthetic. For anyone who says ceramic veneers shine more than composite veneers, I am there to accept the challenge openly. I can put a ceramic down in front of a polished composite. Because the biggest issue is, you cannot repolish the ceramic in the mouth, but I can polish my composite 20,000 times. I can re-occludate them as many times. My research which was done was in the University of Geneva, under no one else but Dr. Dici. Just type this name and probably you guys will turn old, the old ones will take a rebirth. The amount of research he has on bonding. This gentleman, I'm still lucky that I worked with him a lot. That's what he gave me. Exactly natural substrates. Enamel 550, dentine 20 because hardness of 100. That means if anything goes wrong, it will go wrong with the superficial substrates. And I tell all my patients, there is zero guarantee. You may break it right when you walk out. But your tooth is never going to crack. Check this and you will understand why I do not like any other material but composite. And nowadays we have hybrid composites, hybrid resins, glass infiltrated resins which can be milled also, the CAD-CAM blocks. Look at this. All the strengths are mentioned out. Look at zirconia. The compressive strength, the second one, 1200 megapascals. Flexural strength, 1000. Flexural modulus, 200. Surface hardness, almost 1200. And we are wanting to give this in a random mouth, which is dynamic, which cannot bear loads. And now if it starts bearing this load, let's say you give one zirconia crown. Even if you are so itching to do it, please do not give monolithics, give layered zirconias. But even that I would not recommend. But even if you give one wrong zirconia, you've created a huge cascade. And trust me, keep the phone numbers of those patients handy and start doing courses on TMDs. You will get your patient back, you will only retreat them for a TMD later. So if you look at it, my entire philosophy is within the tooth, outside the tooth. Let it be restoration, post-core, crown, even pediatrics. I am amazed when I see people these days putting steel crowns. And those guys who call themselves aesthetic pediatric dentists put zirconia crowns for kids. Well, there should be a separate law in the Indian Penal Code to get those guys banned from dentistry. And I can see that openly. Teeth like these, a lot of people would have shown this on an implant podium. And look at this, how the patient came, there was nothing left, no cervical margin, no ferrule, blah blah blah, and I'll extract and I'll put implant in the central socket and whatnot. I'll spend lakhs and lakhs of rupees from the patient, from my pocket to buy a thing and to give him that thing. I'm sorry, I'm a simple dentist. And I'm happy being a simple dentist. Expose it, find the canals as many as you can. First, rebuild the tooth. Do not do endo without rebuilding. Complete your endo. That's a recall. This gentleman is a dentist. He's based in Dubai. He heard one of my lectures in IDS in 2019 when I had gone to IDS Germany. And from there he followed me and he's getting all his treatment done here in India. And I know how much money he spends. These are his post-obturations. These are his post-pace preparations. Only removal of GP with the help of warm plugger, no preparation. Those thin fiber pins go in with a dual cure material, the fiber at the base, fiber-based materials throughout, the tubes inside. Everything is dentine with fiber. Once that's done, that's this tooth prep. His opposing tooth also needed the same work. There was a bad root canal, we redid that. Removed his crown again the same day. Small pins as posts, fiber-based materials. Went through the digital workflow, got everything designed correctly. We used a very soft block for milling this. Even the labs love this material. The drills last 5 times more because they don't have to drill hard zirconia, 12 megapascals. And the best part, no sintering, no glazing, no lab set required. Get it out of a mill, you can polish it as many times as you want. Finish it, polish it, and there goes the material in the patient's mouth. That's the upper, that's the lower, that's the occlusion. He came 2 years later, post-pandemic, he came for a checkup, everything was fine. He's due probably in December end. It's almost what, 5 years. And people feel composites break and this tooth shouldn't have sustained. It's there and I know it will be there as long as the patient doesn't do anything harmful with the tooth. So the materials that we choose are not just functional but also aesthetic. If you match them with the digital workflow where you can actually see what is going wrong, this is just an eye-opener for everyone who says, I'm doing the best dentistry because I just touched blue and red points and everything is cleared off. When you use a digital dentistry tool like a scanner or a T-scan or an OccluSense, you can actually quantify pressure areas on your tooth. And obviously red everyone knows is the sign of danger. So let's go through a case very quickly. This gentleman had 0 problems. He's getting his daughter treated and he says, when I tell him, I think you should also sit on my chair, doc, I don't have a problem. I said, you sure you don't have a problem? He says, no. I said, I think your left shoulder should have a little pain. And he's looking at me, how do you know? I can look at the face and tell you, not because I'm a face reader, because the muscles on the face tell you how the face is deviating. And I told him when I opened his mouth and this was a beautiful PFA, it was very good. First of all, the occlusion is wrong, the crown is wrong, the margins are open, and this guy is happy with it because he's adapted. Now look at this, these are his scans. Can you see all the red color? Which shows he's heavily occluding on that side, the muscles are stressing the tooth over there. All we do is we go ahead, see the crown has been removed. The moment we remove it, I give him a T-programmer for 10 minutes. A modified Lucia's jig, he sits outside, comes back. All the red spots will you see, that's his lower arch. That's his upper arch. All the reds have vanished, 10 minutes. Muscle deprograms. You go back, give him a bisacral temporary, use the same soft blocks, give him a final crown, and look at this, pre-op and post-op. This is his pre-op upper, all the reds on the right side of your screen become blue, that's his lower. So what have I solved? I have not solved a dental problem. I have solved a musculoskeletal, probably more than that, a neurological problem for the patient. And it's not just function, it's also good if you want to have good aesthetics, rehabs. Because here also, people are doing tons of zirconia, which I feel very sad, that these patients are going to develop muscular stress very, very soon. This is all soft loading being done. These are all beautiful, same indirect composite CAD/CAM block build restorations. Whenever I say composite, I don't know why they don't like it. Is the owner of lab zirconia guy? Maybe. Always be as preservative as you can and trust the patient's philosophy of dentistry. Because if you read, there's a book by a very famous dentist who has a big academy in US, Dawson, Peter E. Dawson. He is the master of occlusion. He's taught occlusion to probably generations and his academy still runs. And very clearly it's mentioned on when you step out of his academy on a stone wall. In the battle between the joint and the muscles, who wins? The muscles win. In the battle between the tooth and the muscle, who wins? The muscle wins. That means you do whatever you want, the muscle will break and find its position. So if you give wrong restorations, wrong places, muscles will pull them back. But you're the only person in the world who's treating bilaterally hanging joints. If one side muscle pulls back, the other side will pull it back, and that's the starting point for so-called abrasion, which we call night grinding. So these are all the restorations. That's nicely planned on a digital articulator. You can see they're all onlays and overlays, and that's a post-op. It's not just function, as I said, the art of doing bioaesthetic restorations, aesthetics with biology in mind. Because the idea is not to break teeth, the idea is to prolong the life of the tooth. Because if we start with fillings and we directly go to crowns, trust me, we have to do implant process very soon. Because they're going to break somewhere. But if we start doing fillings, then inlays, then onlays, then veneers, then endo crowns, probably then crowns, especially with the life expectancy in our country not beyond 70, 72, people will live with their teeth till they're dead. And if they live till 70, trust me, nothing will break. My philosophy is very simple. I am not a crusader, I am not a preacher, I cannot keep everyone happy. And that's why every time I say something, I say people may feel bad about it. My aim is to make one person happy at a time. That's why I said, even if there's one person in the hall, I'm going to still do as I do it. If one person at a time can change, that person's world is completely changed. And that's what I practice my dentistry with. Well, before I end, if you want to learn more of these, okay, you're most welcome. I'm very close here in Noida. I travel all across the country and the world. You can tap me anywhere through any social media platform. I'll answer back. But we organize a conference every year of similar-minded people. And trust me, there's no political science degree given there. It's purely clinical science. So you will not find any elections, you will not find any posts. You'll just find a lot of mad people talking just dentistry and passionately. That's in Goa. I'm highlighting Goa because even if you don't like dentistry, you can still come and have a good time. We leave you by 5:30 every day. Provided you come back next day morning. Keep a tab on that. It's in August 1st, 2nd and 3rd. Well, thank you for your attention. And before I leave, if there's anything I have missed out or I have not confronted or corrected, please feel free because I want all of you to make smiles as beautiful as you can. Thank you very much.
Thank you so much, sir. Now I would like to invite Dr. Sumit Goyal, sir. He is a professor at Department of Oral Medicine and Radiology at Subhati Dental College, Meerut. Topic of the lecture is diagnosis of oral lesions in clinical practice. I welcome you, sir.
Each other in Subhati, so I start with Jai Hind. Good evening. I know you all must be very, very tired attending the session since morning. I promise I'll keep it very short. I'll try to finish in 10 minutes or maximum 15 minutes, and then you can go for your awards and whatever you'll be getting. I am taking you to the medical world of dentistry. We were all focused on dentistry, on the tooth, on the cavities, etc., lasers, everything. I am taking you to the medical world, and I will make the presentation interesting by just sharing 5 stories. Now these 5 stories will freshen up you. I believe that will happen, but let's see. So this is a disclaimer. You can change the slide from there. So this is a disclaimer to tell I am not here to show any, promote any brand of any medicine or anything. Most of the cases which I will be showing you are from my own college, from my own practice. Plus I am not putting down any other speciality. But yes, I want to prove one thing, that we dental surgeons are unique. We are not dentists, we are doctors. I will show you the cases which were wrongly diagnosed and treated by medical specialists. We treated them right. Next slide. So most of the lesions, I repeat, we are in the medical world of dentistry. So most of the lesions what we come across in dental practice, they look simple. But most of the times they are not. They are wolf in the sheep clothing. But at the same time, nowadays what is happening because of continuously wrong diagnosis which is taking place, please change the slide. We have lesion which looks like wolf, but they actually are not. Which animal is this? No, it is not wolf. It is a dog. Next. So I just start with one very simple case. I don't know how many of you will be able to diagnose it, but this is a female who was just brushing her teeth and she noticed that on the buccal mucosa there is a growth. Now she was very conscious about it. She consulted medical doctors, dental doctors. Everyone said go for biopsy. She was in Bihar. She travelled to Delhi. She showed to the best of the doctors and most of them asked her, please go for biopsy. It looks a growth wherever it is present. You know, it can be something dangerous. An ENT surgeon, I have cut the details. Now ENT surgeon said it could be ulceration, but there is no ulceration. It could be a retromoral trigon, some mucosal tag, a polyp, whatever he thought of, he made the diagnosis. Started with topical corticosteroid. Now why I am shouting is, so that जो लोग थोड़ा थक के सो रहे होंगे, वो थोड़ा सा उठ जाएंगे. So that is why. So now this doctor diagnosed her with this and gave test gel. Now test gel is topical corticosteroid. She kept on applying for 15 days, 20 days, 30 days, 1 month, 2 months, nothing happened. And literally this patient came to us and then when we saw this case, so what is this? It is just a parotid papilla, an opening of parotid duct which was misdiagnosed since past 6 months. That patient was subjected to a lot of mental trauma, cancerophobias, and it was nothing. And I took 1 hour to convince her, no, I am a doctor. I am telling you right that it is just opening of Stenson's duct which is prominent. So then finally she got convinced and happy. Next slide please. Another case, patient again noticed some growth, swellings on the posterior part of the tongue, and then the patient Google पे गए and then Google पे type किया swelling on the lateral border of the tongue. Whenever you will type swelling on the lateral border of tongue, what will come? Malignancy, squamous cell carcinoma, patient finished, khatam, wahi khatam. Again this patient was going to from one doctor to another doctor, misdiagnosed, problem, pareshan, everything done. Finally came to us and then again I took 1 hour to convince this is normal. These are just papillae which are present on the posterior part of tongue which are hyperplastic. Now these papillae in this region which are present are called as, you can please change the slide, foliate papillae. And when these foliate papillae are a little bit enlarged or hyperplastic, we call this condition as foliate papillitis, and this was the condition. And again I was lucky enough that I could show the pictures, everything to the patient and convinced that patient, and now that patient is happy and I am the only doctor whom he visits. Next slide. So many normal things. Does it look like a pathology? Does it look like candidiasis? It is simple smoker's palate. Please change. But then most of the times, most of the doctors treat it as candidiasis and patient topical antifungals लगाता जाता है, लगाता जाता है, लगाता जाता है. Please change the slides. Please, this is candidiasis. It is different from that picture that was just smoker's palate, and that is candidiasis. Another case, just one slide back. Another case, there were diffuse ulcerations on the palate, some sloughing, painful, and this was present since past 3 months. Now the patient visited a medical doctor, and this was the prescription given to the patient. Please see the slide. Patient was given corticosteroid, patient was given Ocubine, antiviral drug. So the doctor thought it's a viral herpetic gingival stomatitis. सबसे पहले यही समझ में आता है हर एक medical doctor को, and patient kept on taking this antiviral. But then when we examined the patient, viral disease persisting since 3 months, it is not possible. We could have acute multiple ulcers, but we will never have chronic multiple ulcers. Agar chronic multiple ulcers are present, that would be pemphigus. Pemphigus is not uncommon. You must be thinking, why are you talking about pemphigus? It is common these days. And why it is common? Because stress is common these days. Everyone is stressed. We all are stressed. You all are stressed. So we all are stressed, so we are developing these autoimmune disorders. So it was pemphigus, misdiagnosed, mistreated, and finally we started with a better treatment and patient was happy. Next case, please. Another case, the doctor thought it is pemphigus now. But this was present since past 5 days, not from months. And it was unilateral, not crossing the midline. So this was a case of herpes zoster, intraoral herpes zoster. Again very common, because of stress, our immunity also gets affected and we get such disorders. So again this was herpes zoster, but then the doctor diagnosed it, please next slide, as pemphigus. And a herpetic patient who was already immunocompromised was given Dapsone, anti-leprotic drug acting as an immunomodulator. Finally again, that patient came to us and we started with valacyclovir and those lesions disappeared in just 3 to 4 days. So this is why I say that it is important to make a correct diagnosis and to treat the patient correctly. And medical doctors, किसी से ऊपर नहीं है. ऐसा नहीं है, we are less than anyone. They are not diagnosing anything correctly, they don't know anything about it. So, we can do many things which they can do, but they cannot do anything which we can do. So that is the beauty of our speciality. Next slide. I thought I had many things to show you, but I will skip everything. Another case, now this was a case of hypersensitivity reaction called as erythema multiforme. Next slide please. It was again misdiagnosed. समझ ही नहीं आया उनको lichen planus aphthous and then it was sent for the opinion, then we were able to treat it. Next slide please. So ऐसे several interesting cases are there which I wanted to show, but I will cut down everything. Can anybody diagnose it? Is it a hematoma? No, it is not. I don't know how many of you know about it, but whenever you will practice, you will come across such blood-filled blisters. So I'll tell you that this condition is called as angina bullosa hemorrhagica. बड़ा लंबा सा term है, but then it is important because in COVID, when that peak second wave of COVID was there, in the tenure of 1 week, I saw 5 back-to-back angina bullosa hemorrhagica cases. Now these blood blisters, they are not dangerous. They develop due to trauma. Mostly on the palate, patient ने पापड़ खाया, चुप गया, बन गया. Right? They persist for 2-3 days and then they disappear. Why they were happening in COVID patients were because COVID patients were given aspirin. You know, at that time we were giving aspirin to all COVID patients. So blood thinners पे थे. Plus that COVID test when they used to perform, वो swab they were taking from the soft palate. Because of that, those things they must be facing those traumas and developing such lesions. But this lesion does exist. आप लोग को मिलेगा in your clinical practice called as angina bullosa hemorrhagica. No need of any treatment. Don't puncture it. Don't touch it. In just 2-3 days, it will disappear. All right. Next. This is the spelling. Next. Every case with STRI is not lichen planus because although there is not much difference in treatment, but it is important to diagnose things. So this is lichen planus, characteristic web-like pattern. Next please. But this is not lichen planus because we have a particular etiology associated near the restoration. This is lichenoid reaction. Next. This is also not lichen planus because although we have STRI, but the presentation is very typical. that we have radiating striae which are coming in the center, and there is a central erythematous area which is present. Now such an appearance can be linked to as a sunray appearance also, but when you see such an appearance, never make the diagnosis as lichen planus thinking that striae are there, so it is lichen planus. Because this will be lupus erythematosus, another autoimmune disorder. Aajkal every month we are seeing such cases, again because of stress. पहले हम लोग बोलते थे ना that girls में these autoimmune disorders are common, but आजकल males maybe they are equally common because females these days they are not taking stress, they are giving more stress. Things are changing. Next please. Next please. Oh, we will skip all these slides. We'll come towards the end. Go back to the first slide now. Before this. We have reactive lesions on gingiva. Those people who are in any field must have seen these reactive lesions. Once of them, pyogenic granuloma, peripheral giant cell granuloma. So they are most common in gingiva. But then you will sometimes come across some cases which are there on gingiva, but they are not very simple ones. Next slide, please. Like for example, no, next slide. We are going back. I want to go end की तरफ. यहाँ वापस जा रहे हो आप आगे करो. Yes. So sometimes in the posterior gingival region you may find growths like this, which are not simple, which are not easy ones, because once you will biopsy them, they may come out to be metastatic lesions. Metastatic lesions you will find from prostate, from kidney, from breast, in the oral cavity, in the posterior gingival region, and the easiest way to diagnose it, patient will tell you that I have paresthesia in my chin and in my lip. Numb lip, numb chin. So that will be present along with the metastatic lesion. Characteristic, this is one of the diagnostic pattern about it. We change it. So this was the case where we performed CT and MRI. You all know these are two axial sections. Can you all differentiate that which one is CT section and which one is MRI section? CT is for heart tissues. So where the bone and the teeth are appearing bright, that is CT. Where they are appearing dark, it is MRI. So it is easy to distinguish. Next slide. Next slide. Cut it short. Next. We'll come to some change it. Change. Yes. So is it angular cheilitis? Some unusual presentations. It is not. Looks like angular cheilitis, it is not. It is a split papule. How many of you remember that split papule is a finding that we see in the patients of secondary syphilis. Syphilis बीच में होना ही बंद हो गया था. But past 4 months I have seen 2 patients of syphilis. It is coming again, right? And this is split papule. If such a papule is present which is split into 2 halves, it is called as split papule, and it is a manifestation of secondary syphilis. Next slide. What is this? Can you see it and immediately say it is a? What we see on the half of the tongue is vesicles which are translucent, looks like toad's eggs or frog's eggs. This is lymphangioma, typical presentation of lymphangioma. Next slide. Is it leukoplakia? Leukoplakia can be at any site, buccal mucosa, floor of the mouth, ventral surface of the tongue. Now, that are high risk site, but leukoplakia kahin par bhi ho sakta hai. But this particular lesion on the ventral surface of the tongue was scrapable. So if you ever find some scrapable lesion, that too on the ventral surface of the tongue, please go for renal examination of that patient. Check the urea levels. Now this condition is uremic stomatitis, very commonly seen in patients who are on dialysis or having chronic renal failure. Next slide. Such patients can also develop something like this. This is called as uremic frost, because of these are all urea particles which have developed here. Uremic frost, you go to any nephrologist or any OPD where kidney patients are there, you will find many such cases of uremic stomatitis and uremic frost. Next slide. What is this? Have you heard of condylar hyperplasia? One side of the condyle, it grows on and on and on. Okay, so next slide. Next slide. Next slide. So I'll end here. I'll keep it very short. you all must be tired. So I will come again wherever we meet again, if I will be called again. So I will give a detailed presentation because I love what I do. I love to teach. I love to show these cases because I want to make people aware that our branch has so many things which are always getting ignored. So we'll meet again. Thank you so much, and thank you specifically the organizers of Perry Fawcett this convention, and especially to Dr. Anmol and Dr. Ashish, who are my family. Thank you so much.
I know you all are waiting for the results. I would like to invite Dr. Anmol Bagaria ma'am and Dr. Ashish Chandra sir. Please wait for a few minutes. We are announcing the result of scientific presentation. Dr. Soumya Garg for securing first position in the scientific poster presentation. Dr. Dr. Amish Bansal for securing second position in the scientific paper presentation. Dr. Monica Chaurasia for securing second position in the scientific paper presentation. Dr. Stuti Joshi for securing third position in the scientific poster presentation. Dr. Rahul Gorak for securing third position in the scientific poster presentation. Dr. Devashri for securing second position in the scientific paper presentation. And the last, Dr. Nisha Yadav for securing first position in the scientific paper presentation. Congratulations to all the winners.
Ma'am? Ma'am? Yeah, you can click.
Thank you, ma'am. Thank you, sir.
आने वाली है।
इसके साथ फोटो करवा दें।
कर दे रैम स्टार्ट।
Dr. Ranjit.
Yeah.
Dr. Ranjit and Dr. Amruta for second position in paper presentation. Dr. Abhinaya for securing second position in the paper presentation. If anyone is left for the scientific award, please come forward. Dr. A. Siddharth Verma, sir, for securing first position. If anyone is left for the scientific prizes, please come forward. Thank you, sir. Thank you, ma'am. I would like to invite Dr. Ashish Chandra, sir, for vote of thanks.
Thank you, everyone. I thank to all the delegates, all the fellows for making this conference, convocation and award ceremony a great experience for everyone. I hope that this was a great learning experience for all of you, and the fellows who have been inducted today, they have this prestige that they can induct new fellows to the academy. So I announce that they should encourage new fellows to our academy. Thank you everyone for a wonderful day and a wonderful conference. Thank you.